clinicians from a broad spectrum of fields, including basic, clinical, and epidemiological research. As you know, the Cancer Symposium is being held virtually for the first time due to the ongoing COVID-19 pandemic in the interest of public health and safety. We thank you all for joining us. Before we begin, I would like to share some housekeeping points with everybody. The disclosures for the presenters and speakers can be reviewed within the live stream tab of the website. Please feel free to visit our virtual exhibitor hall. To visit the virtual exhibit hall, you could scan the logo on the screen. Also, our abstracts and poster session is also in the virtual abstract hall. Please scan the logo on the screen for access. And tweet us. We are at Houston Methodist Cancer 2020. You can use your phone to participate and submit questions for the presenters. You may submit questions at any time during the presentation. The questions are moderated and they are addressed based on the time and content. You have two options on how you are able to participate, and they are on your screen. And now, for our first speaker, I would like to invite our Cancer Center Director, Dr. Jenny Chang, to kindly provide an overview of the Houston Methodist Cancer Center. Dr. Chang is the Emily Herman Chair in Cancer Research in Houston, Texas. She obtained her medical degree at Cambridge University in England, and then she finished her fellowship in medical oncology at the Royal Marsden Hospital and Institute for Cancer Research in the United Kingdom. She was also awarded a research doctorate from the University of London. Her recent work has focused on the intrinsic therapy resistance of cancer stem cells, which has led to several publications and international presentations. Dr. Chang's clinical research aims to evaluate novel biologic agents in breast cancer patients. And at the moment, she's our fearless leader. Dr. Chang.
Thank you, everybody. And I would like to say before we start, this has been a tremendous time in the history of our country, in Houston Methodist, of our Cancer Center. And Dr. Jocelyn Randhawa and Dr. Eric Benneker have done a stunning job in to bring together a virtual meeting. It's virtual in many ways for our 8th annual Cancer Symposium. So basically, we're just going to go through some of the things that have been happening. I'm trying to move forward. Okay, I'm just quickly go through. So we started this about 8 years ago. We started our Cancer Center about 8 years ago in a very competitive landscape. And one of the things that we set out to do was to basically provide the best high-quality transformative care in cancer that we can find. We had to, in creating this Cancer Center, create a sense of urgency, create a vision, communicate this vision, empower others to act on this vision, create short-term wins, consolidate, produce more wins, and finally institutionalize new approaches. For those who are in business school, this is called Cutter's 8 steps in trying to transform something that is non-existent. So when we started, there was not an academic cancer center. We had very good clinicians that were together, but we all were doing our own things in silos. The idea of creating the Houston Methodist Cancer Center with a vision of being one of the country's best was to basically transform these silos into a cohesive whole. And we actually adopted Cutter's 8 steps. So the first step was the vision. What is the vision of the Houston Methodist Cancer Center? It is to be a leading, transformative cancer center that leads clinical trials and translates basic discoveries that we find in our laboratories into standard clinical practice. We needed to communicate this vision, which we did quite adequately through governance and everything. And all our faculty here in the Houston Methodist Cancer Center buy into this vision, they articulate this vision, they believe in this vision, and that was a communication. And this finally led, after 8 years, to the last 3 years, we are now on a roadmap for NCI designation. And in 2017, we began this journey. So this is a 3-year-old journey. The first 5 years was the infrastructure, the next 3 years now is the vision. And here, what we did in 2018, we had about 8 million in funding. We want to get, by 2023, 15 million in grant funding. We recruited key faculty in this. We needed a basic science leader, and we recruited Dr. Cheng Yi, who was from Cleveland Clinic. He was the chair in cancer biology in Cleveland, and he came here to head our cancer biology program. We transformed our core technologies. We have phenomenal, highest cutting-edge cores here, technologies here, from imaging site of fancy machines to 70 Tesla MRIs. But we needed somebody to oversee all that. Dr. Wong, who came from Harvard, heads that program. So we beefed up our basic science research first. The next component, now that we have made these wonderful, stunning discoveries, was to translate that into clinical trials. We have an enormously flat landscape in Houston. How then would we be able to basically transform these discoveries into clinical trials? And through work, which was first started by Dr. Bernaker, now being championed by Dr. Gaia, whom I'll talk a little bit about, we are now basically able to offer clinical trials throughout the whole huge metropolitan area called Houston. The next, and the last final step in our transformation, is how do we actually measure our impact? Are we able to impact and actually decrease mortality due to cancer? We spent a lot of time thinking about this, and the next step is to think about ways in which we can have preventive strategies. And through our ongoing close collaboration with Texas A&M, we shall articulate some of our plans in the next 5 years to have prevention strategies. With the overall goal, not that it's important, but the overall goal is NCI designation in a few years from now. Why this goal is important is not actually the goal. It is the journey to that goal that basically brings us together. So this is your org structure. So this took a lot of time, and the pieces, except for one, which is education, is filled out. Cheng Yi, Dr. Yi, basic science, Dr. Gaia, clinical trials. Esninola, he is a wonderful surgical oncologist who's interested in prevention, disparities research. Dr. Darko is in charge of our community because we have community hospitals. Jane Boland, she's from Texas A&M and has a joint appointment here, and she's going to be in charge in community outreach and engagement. Dr. Wong, whom I previously mentioned. Tamim Malbari, he's our administrator. And we have wonderful programs underneath these. I'll talk a little bit about them as we move along. So this is a strategic plan. The goal is hopefully before 2023, but these are our programs. We have innovative therapies, immunology, cancer prevention, and outreach. And intersecting this, we have an EAB, an IAB, shared resources, and clinical trials. But most importantly, whatever we do has to have impact in the area we serve. So this is, again, rehashing of what I said previously. And the 3 programs are immunology. Dr. Xu Shen leads that. Innovative therapies. We have coolest new toys and new drugs are coming out in the pipeline. Dr. Haifa Shen is in charge of that. Dr. Esnola for cancer prevention and control. Okay, overarching and overclosing all this, we need to have clinical trials. Dr. Gaia was recruited from Virginia. He's the current medical director of NSVP. And I'm very pleased to also say we have a new boss in heme malignancy, Dr. Sid Ganguly from Kansas. And basically, he is a real clinical trialist in heme malignancies. This is going to be a very key position as we integrate our clinical trials in heme malignancies out into the community. So 3 programs. First, innovative therapeutics. Again, 2017, we have probably over $20 million worth in grant funding for nanotherapeutics, one of the strongest programs here in the Research Institute. We have our sRNA delivery through our RNA core, which I'll tell you a little bit about. And we have diagnostics are going on using small nanotechnologies. Overarching this, our U54 also looks at vaccines, prevention, and whether we can scale this up into cell-based therapies. Now, cell-based therapies is one of the very important areas in which we're investing a lot of our resources. Immunotherapy, as you heard, Susha Shen was recruited again, and she was recruited slightly after that. Again, we have, Dr. Bernecker had some of the most fascinating studies we have with oncolytic viruses, with interleukin-12, etc. We're going to use combinatorial therapies to basically change the tumor microenvironment. And again, cell-based therapies, we just had a very generous donation from the Johnsons to start the Johnson Center for Cell Therapeutics. Dr. Pengali will be representing us from the Cancer Center point of view, but this is an area in which we are going to work closely with Baylor College of Medicine to bring new therapies, both for heme and solid malignancies, using cell-based therapies. More about experimental therapeutics, Stephen Wong, he does drug repositioning, John Cook with his RNA core. Again, toys, we have so many toys. Here is the 7T MRI, which is one of its, only in the country. And this basically, the resolution of the 7T MRI is almost as if you're looking at the brain itself. We overlap all our research endeavors on what we know are our patient population. So we know how many patients we have in breast cancer, we know how many patients we have in lung, GI, GU, blood. And we overlap our research strategies on the patients for the patients we serve. So we've done very well over the last few years. We have gone on a binge on recruiting high talent, high quality researchers for our basic science. And basically at the moment we're ranging about 13 million or more, 13.5 million in total funding, of which about 6.5 million are actually NCI dollars. We're more than halfway there. We're very close to our desired goal of 8 to 9 million for NCI dollars. Clinical trial recruitment, we're going to hit 400. We want to hit 400. This has not been a good year. It's been a COVID year, and clinical trials have taken a little bit of a slowdown, but we're still doing pretty well. We will probably track 2019 numbers and hit about 300 this year. It's understandable, but we have 100 more patients to recruit, and we will get there. But at the end of the day, is impact. How do we basically impact this community? We are now doing a very deep dive on what is called our catchment area. Who is it that lives in Houston and the surrounding hinterland? How do we actually, what are their needs? How can we impact their needs? And through this, we want to know about underserved areas, minority areas. We need to engage our population. We need to engage our care providers. We need to engage our patients. So this is through collaboration with Jane Bolin in Texas A&M, where you can see there's a huge high mortality rate that is related, for example, this is lung cancer, in rural Texas. So we're going to move forward, and a lot of this, again, is championed by Dr. Bernecker. But most importantly, once we have all that set, we need to basically take our clinical trials and our practice out into the community, and that will be the goal over the next 5 years. Not yet a doctor, but she will be soon. She's submitting her doctorate thesis. Riette Lambert is the director of our clinical trials office. She has done a stellar job, a phenomenal job in coordinating this whole effort. She works closely with Dr. Gaia in opening up our clinical trials in the community. And this is the goal. So at the moment, we have about 30 medical oncology, hematology folks. And basically, the goal is basically to add on another 20 over the next few years, both in the community and in Houston Methodist main campus. This is our strategic planning line for our submission for our CCSG, our Cancer Center grant for NCI. We are smack on track. We were slightly delayed due again to COVID, but we plan to have our first advisory board external EAB meeting. These are the people who are coming in, very well known in the field, and we're having it on October 2nd. And it will be virtual, very much like this. It feels odd, but yes. And so all this short-term wins. So you can do this if you're short-term wins. And our short-term wins is that we have made it again to the honor roll. And cancer has, it's a very decent number 17. In fact, it's fantastic. And this is a real testament to how cohesive this group is, how the clinical trials are moving along, how the practice and everybody has come together with this collective shared vision of being the best that we can be, the best that we are, the best, one of the very good alternatives to cancer care, clinical trials and practice in Houston. We're not number one, but it's okay. And so this is where we are different. We are where patient care meets excellence. And we are number one in Texas, and we'll continue to strive to be the best we can. Thank you very much for your time.
Now, I would like to introduce our hematology keynote speaker, Dr. Tafiri. Dr. Tafiri did his med school from the University of Athens, Greece, followed by his residency at St. Joseph's Hospital in Chicago. Subsequently, he did his fellowship in hematology at the Mayo Clinic before joining the faculty there, and is currently a professor in hematology and internal medicine. He has had a long and illustrious career as a leading thinker and researcher in the field of myeloproliferative neoplasms. His academic and research achievements have been copious, with over 800 publications. Today, he will be talking to us about the science and practice of myeloproliferative neoplasms. Dr. Tafiri.
Thank you very much. Can you hear me?
Yes, we can.
Okay, very good. Let me first thank the organizers for honoring me with their invitation in this important function. I have nothing to declare, and my objectives in this talk are to introduce you to the field of myeloproliferative neoplasms, and just for the sake of definition, the WHO classifies myeloproliferative neoplasms as one of the major categories of myeloid malignancies. And under the umbrella of MPN are several clinical pathologic entities as listed. But today, we're going to focus on the JAK2 related MPNs, and specifically polycythemia vera, which I would refer to as PV, essential thrombocythemia, ET, and primary myelofibrosis, which I would refer to as MF. And what I would like to do in this talk is give you a little bit of a background in classification and pathogenesis, and then spend most of my time in contemporary diagnostic, genetic prognostication, and treatment algorithms. The field of MPN has exploded, and it has become one of the most appealing entities, especially for young hematology and oncology trainees. And it all started in 2004, actually, when William Venchecker from France discovered the JAK2 V617F mutation. His observation, along with other esteemed leaders from Harvard, led by Dr. Gilliland, and also from Europe, the UK and Switzerland, they all reported their observations at the same time in 2005. And the JAK2 mutation, as you know, the JAK2 is an important signaling molecule that is important for ligand signaling from homodimeric receptors such as erythropoietin receptor, thrombopoietin receptor, or MUPL, and granulocyte colony stimulating factor receptor. The ligand receptor engagement results in phosphorylation of JAK2, which in turn results in phosphorylation of STAT5 and other signaling pathways, including MAPK and PI3K ACT pathways. The mutation in JAK2 results in constitutional activation of the JAK2. In other words, it's ligand independent, and it results in the phenotype. Now, since that discovery in 2004, there has been other additional discoveries along the pathway of JAK-STAT, or all JAK-STAT activating, and they include mutation in the thrombopoietin receptor MUPL and mutations in calreticulin or CALR gene. And all of these mutations ultimately result in JAK-STAT activation. The mutation in JAK2 occurs not on the kinase domain, but the pseudokinase domain. It appears that the pseudokinase domain usually inhibits kinase activation, and this mutation appears to abolish that inhibitory activity. The mutation in MUPL occurs near the transmembrane and cytosol connection, and that results in gain of function, therefore resulting in, again, constitutional activation of the JAK-STAT pathway. The mutation in CALR occurs in the C domain, actually, which results in the abolition of the KDEL domain, which is important in localization of calreticulin in the endoplasmic reticulum. And it appears that the calreticulin mutation has an indirect JAK-STAT activation by binding to MUPL and then resulting in MUPL activation. Now, to just give you an overview, the JAK2 mutation occurs in almost everyone with polycythemia vera, as you can see here, and the 3 to 5% that are JAK2 V617F negative, most of them carry other JAK2 mutations, including exon 12 mutation. And this JAK2 mutation of V617F also occurs in about 50% of patients with ET or MF. The CALR mutation and the MUPL mutations are not found with PV, only rarely, but the CALR mutation occurs in about 20 to 25% of patients with PMF or ET, and the MUPL mutation occurs in about 5 to 10% of patients with ET or PMF. Now, it is important to recognize the fact that there are about 10% of patients with MF, about 15% of patients with ET that are negative for all these three so-called driver mutations, and they are usually referred to as triple negative patients. Are there other mutations? And the answer is yes. About 80% of patients with myelofibrosis carry other mutations, and the most frequent of which are ASXL1 and TET2. These mutations are also frequent in PV and ET, where such other mutations occur in over 50% of the patients. Now, on this slide, I have listed the spectrum of all other mutations, but it is important for you to pay attention to two points here. One is what the most frequent mutations are, and that's TET2 and SXL1, which means that whenever you have these patients, and if you were to do next generation sequencing on them, it wouldn't be surprising to find TET2 and ASXL1 mutations. But what I have done here is I have shown with a red arrow the prognostically relevant mutations among these. For example, in MF, the prognostically relevant mutations are ASXL1, SRSF2, and U2AF1 primarily, but also there is some prognostic contribution from CBL, CBL, IDH2, TP53, and EZH2. There are two other mutations that are important prognostically in blast phase, but not necessarily in chronic phase myelofibrosis, and they are RUNX1 and PTPN11. Prognostically relevant mutations in PV are ASXL1, SRSF2, and IDH2, but for all practical purposes, the only one to remember is SRSF2. Now remember, SRSF2 was also prognostically relevant in MF, and it also appears to be prognostically relevant in ET. So it appears that in ET, the spliceosome mutations, including SRSF2 and SF3B1, are prognostically important. So now we go to see how these scientific discoveries that have been remarkable have helped us reshape our diagnostic and prognostic approach to these diseases. Diagnosis at this point is pretty straightforward. In PV, since almost everybody carries a JAK2 mutation, whenever we suspect PV, we just order peripheral blood JAK2 mutation. These mutations are present in the peripheral blood as much as they are in the bone marrow. So there's no need to do a bone marrow just to do the mutation analysis. So in PV, if you find a JAK2 mutation, you're suspecting PV, it's probably PV. If not, then you wonder, well, could this be the 1% of patients that are JAK2 negative? And that is where a bone marrow examination and the serum erythropoietin level might contribute, and that might help you confirm whether or not it is a JAK2 negative PV. In ET, it's a little more trickier because these mutations are not specific to ET, and they can be found, this could be PV or it could be prefibrotic myelofibrosis, but at least finding one of these three mutations, which are carried by 90% of patients with ET, one of these three mutations, would confirm that you're dealing with a myeloproliferative neoplasm, and a bone marrow examination then might be necessary to distinguish ET from prefibrotic myelofibrosis or other JAK2 positive myeloid malignancies. So here, you might need a bone marrow examination for further distinction. In myelofibrosis, obviously, you need a bone marrow. But more importantly, here, when you do the bone marrow, do not forget to do the driver mutation screening to confirm that this is indeed an MPN. And there are some specific cytogenetic abnormalities, such as trisomy 9 and deletion 13q, which when present suggest that you're dealing with primary myelofibrosis as opposed to another myeloid neoplasm that might be accompanied by reactive bone marrow fibrosis. Now, as I have shown you, it appears that if you use these mutations, things become simplified. And one of the sticking points has been, is this true ET, or am I dealing with another myeloid malignancy that can be JAK2 or other driver mutation mutated? Now, in ET, when you do a bone marrow examination, you would see that the megakaryocytes are very much mature appearing, and they're usually found in loose clusters. Now, contrast this with the bone marrow morphology picture in myelofibrosis, where the megakaryocytes are more angry looking. They are usually found in tight clusters. And a good pathologist can sometimes distinguish this, but not always. Obviously, in reactive thrombocytosis, you just find mature appearing megakaryocytes. In another JAK2 mutated myeloid disorder, the so-called RARS, or refractory anemia with ring sideroblasts, where 50% of the patients might carry the JAK2, in the bone marrow, obviously, you will see the ring sideroblasts. But more importantly, there is another mutation that is specific to this disorder, and that is SF3B1, and you can do a peripheral blood mutation screening for SF3B1 if you really suspect this. And don't forget CML that can present with isolated thrombocytosis, thus mimicking ET. And here, the bone marrow shows megakaryocytes that are dwarf and very small. But more importantly, this is easily ruled out by doing BCR-ABL. Now, I want to say a couple of things about that. First of all, BCR-ABL presence in CML is dominant. It is obviously 90% of the cells. But in other diseases like ET, other myeloid malignancies, you can have a very small clone, which is not morphologically apparent, but a small clone that carries JAK2 or MUPL, and that doesn't necessarily make it an ET diagnosis. It just makes it a CML diagnosis with a small clone of JAK2-carrying stem cells. Now, for most of us who are clinicians, we don't necessarily have to rely on the pathologist's view on whether the bone marrow looks like myelofibrosis or it looks more like ET. There are certain things that we can see from the peripheral blood that would help. In ET, there is usually no anemia. A slight anemia might be present in prefibrotic myelofibrosis. But most importantly, and I want to make this point clear, if you look at the MCV and RDW, these are always given to you along with the hemoglobin. Usually these are normal in ET. But if the RDW is increased or the MCV is decreased, then you should seriously consider the possibility of prefibrotic myelofibrosis or myelofibrosis for that matter. Similarly, the peripheral blood smear in ET is quite underwhelming. But the peripheral blood smear in prefibrotic myelofibrosis could show some leukoerythroblastosis, basically, which means that there are circulating nucleated red blood cells and immature myeloid cells, and there are some teardrop cells. Not always, but sometimes. Another very important finding in myelofibrosis is increased LDH. That's almost never seen in ET. And finally, when you are told that the patient has a JAK2 mutation, please don't forget to ask what the allele burden is, especially when you're trying to distinguish ET from other myeloproliferative neoplasms. In ET, the allele burden is usually less than 20%, much less than that. But in otherwise occult PV, or prefibrotic myelofibrosis, the allele burden might exceed 20%. In other words, if it exceeds 20%, then you should seriously consider it. If it is below 20%, you cannot rule it out. Now, this is all good, and it's very simple if you are dealing with a clonal myeloid disorder and you look for the mutations. But for most of us in clinical practice, over 90% of the cases that come with rule-out polycythemia are not polycythemia vera, and that they're what we call non-PV erythrocytosis or secondary erythrocytosis. And the way I approach this is I always start with the serum erythropoietin level. And if it is subnormal and it's not PV, then I seriously consider the possibility of an erythropoietin receptor mutation. If the erythropoietin is increased, especially if it is markedly increased, then I seriously consider the possibility of an erythropoietin-producing tumor or renal artery stenosis or post-transplant erythrocytosis, and so forth. If the erythropoietin is normal, then I consider the possibility that it can either be congenital, other than EPO-R mutation, or it can be a compensated normal from secondary erythrocytosis that is associated with cardiopulmonary disease and what have you. Now, the most important thing here, if the erythropoietin is normal, is when you deal with the differential diagnosis, please always start with testosterone. Is the patient using testosterone for one reason or another? Because that usually answers the question. And by the way, that is not necessarily an indication to stop the testosterone. If the patient is getting a good quality of life with the testosterone, whatever the case might be, then there's nothing wrong with an increased hematocrit, which is not PV. And all the patient that needs is maybe one baby aspirin along with the testosterone supplement. Now, congenital erythrocytosis is very rare, maybe less than 10% of the cases that you suspect. And here I have listed all the possibilities, but most of them are extremely rare. But the only thing I would mention is if you are suspecting it, the mutations that are usually you want to look for are the VHL mutation, the von Hippel-Lindau, HIF2A mutation, and PHD2 mutation that are all listed in the slide for you. Now, let's go into survival and prognosis. And this is based on over 3,000 patients seen at the Mayo Clinic with a median follow-up of 20 years. And you can see very clearly that the survival curves are wonderful for ET and PMF. They're not terrible. In other words, these diseases are not like MDS or acute leukemia. And as you can see, ET and PV are clearly much better in terms of survival than primary myelofibrosis. And similarly, the risk of leukemic transformation is much higher in primary myelofibrosis, almost 10% during this follow-up period, as opposed to less than 5% in the other two. And also to note that polycythemia vera has a higher chance of transforming into myelofibrosis compared to ET. But interestingly, the risk of thrombosis is very similar along the three, with PV having the highest risk of thrombosis, followed by ET, and then followed by PMF. Now, when you compare the survival curves with a control population, the normal population, and here we use the Olmsted County, and clearly, even when we took the low risk, and this is a figure that we prepared, just taking low-risk patients with ET or PV, and clearly showing that life expectancy is significantly shortened, although these patients can expect a long life expectancy. Now, the most important prognostic factor in ET and PV is age. Advanced age in all these three diseases is worse with an older age. And if you look at young group of patients, for example, age less than 40 years, the median survival in ET and PV exceeds 35 years. And interestingly, the median survival in myelofibrosis, if you are below age 40, is 20 years. So just having a diagnosis does not automatically mean that you have to look into transplant for very young patients, because you have time to observe that patient for a long time. And the same is true for middle-aged patients between 41 and 60. And in older patients, of course, the age takes toll, and it's not necessary that the disease is worse in older patients. Now the question is, are there other things other than age that can affect prognosis in these patients? Let's start with ET and PV. We just published an international prognostic scoring system that is actually enhanced by mutation information. We took 502 patients from the Mayo Clinic and the University of Florence, and we found that age obviously remains the most important prognostic factor. And interestingly, we also found that male patients live shorter than female patients. That appears to be true with any indolent disease. But other than sex and age, we found that patients with spliceosomal mutations, SRSF2 and SF3B1, fare worse. Now, I want to make a point here. Although these patients fare worse, you have to remember that first, the mutations are very infrequent, relatively infrequent. 7% of the patients with ET carry one of these adverse mutations. The second thing is we might be identifying occult prefibrotic patients, since these mutations are also quite prevalent in patients with myelofibrosis. In other words, if you have a patient with ET, do you need to do next generation sequencing? Well, I will probably not do it, because even if I find it, I can't do anything about it. As long as you communicate this fact to the patient, I don't think you need to necessarily do next generation sequencing in order to find these mutations, and maybe unnecessarily increase the anxiety to the patient. But it might be a way of identifying prefibrotic myelofibrosis. Now, important in ET patients is another sinister mutation, the TP53 mutation, and these mutations appear to increase the risk of leukemic transformations in ET. So if you were asked, what are the adverse mutations in ET? It would be the spliceosomal mutations, SRSF2 and SF3B1, and then the TP53 mutation. In PV, again, age is the most important prognostic factor, but in addition, we have the SRSF2 mutation that appears to have a strong prognostic implication. And then in ET also, we found for survival, leukocytosis and abnormal karyotype are adverse features in this regard. Also, in ET, we did find some other mutations that might increase the risk of transformation to myelofibrosis, but these mutations, specifically U2AF1 and SF3B1, are also mutations that are prevalent in myelofibrosis. And as I said before, this could be another marker of a prefibrotic myelofibrosis, and therefore it will help you in generally appreciating what might be going on and deciding whether or not you need to do a bone marrow examination to look at morphological clues. Again, I want to emphasize, these mutations are not frequent, and you don't necessarily have to do NGS as long as you appreciate the possibility. Now, there are some patients who might want to know everything, and you could do the NGS. There are some patients who say, listen, what are you going to do about it other than just increase my anxiety? So you have to use the art of medicine here to decide who needs what. Now, I identified William Benschenker as the main person who discovered the JAK2 mutation and led to the explosion of the scientific advances we have in MPN. Equally important is another giant in the field, Tiziano Barbui from Bergamo, Italy, who's actually led all the seminal studies, all published in the New England Journal of Medicine, that have actually shaped our current practice in ET and PV. For example, the way we use hydroxyurea in high-risk ET and PV all come from a study that he published in 1995 along with his esteemed Italian colleagues. Our use of low-dose aspirin in both ET and PV stems from the randomized study that he published in 2004. And most recently, our insistence on aggressive phlebotomy to keep the hematocrit below 45% in PV also comes with another randomized study published in 2013. Now, as I have shown you, in ET and PV, survival looks very good, especially in young patients. And we don't treat these patients to prolong survival or prevent the complications of clonal progression, such as acute leukemia or myelofibrosis, because nothing has been shown to help in that regard, and the risks are relatively low. The reason why we treat patients with PV and ET is primarily to reduce the risk of thrombosis. The JAK2 mutation is equal to thrombosis. Anytime you have a JAK2 mutation, you have to worry about thrombosis. And in another seminal study, Dr. Barbui have shown that patients with ET can be distinguished in terms of their risk for thrombosis based on primarily two factors, which is the presence or absence of JAK2 mutation and age. Now, based on that, our current risk stratification in these diseases look at very low risk, intermediate risk, and high risk patients. Very low risk means that you're young, you have no thrombosis history, and you are JAK2 unmutated. In other words, you don't have these strong promoters of thrombosis. These patients might not need anything, including aspirin. They might not need it. Unless there is a cardiovascular risk factor, then you'd give them one aspirin. Now, if you are like very low risk, but you have a JAK2 mutation, then you go into the low risk category, and there the emphasis is on aspirin therapy. And I usually use one baby aspirin twice a day, since once a day aspirin does not secure coverage for 24 hours. Now, the intermediate risk is a new category that includes otherwise good-looking older patients. In other words, age above 60 years is not an automatic indicator of a prescription for hydroxyurea. If you are older, but you don't have a JAK2 mutation or thrombosis history, you could be managed just like your younger counterparts, just with aspirin. For high-risk patients, that means you either have thrombosis history or you're older and also have a JAK2 mutation. That is where we usually use hydroxyurea as a cornerstone of therapy. And depending on where the thrombosis history is, if it is arterial, we usually use one baby aspirin twice a day. If it is venous, that means in addition to hydroxyurea, you need systemic anticoagulation. In polycythemia vera, risk factors are simple, just advanced age and history of thrombosis, since everybody is JAK2 positive. And here, the treatment based on those, the low risk patients, meaning they are young and don't have any history of thrombosis, can be treated with twice daily aspirin therapy. And the high risk patients, either they're older or have thrombosis history, are treated with hydroxyurea, and in addition, need to be treated with twice daily aspirin if the history of arterial thrombosis, or systemic anticoagulation with a history of venous thrombosis. Now, what if you can't use hydroxyurea for one reason or another? My second treatment of choice is clearly pegylated interferon. My third choice will be busulfan, which I think is maybe one of the most effective drugs in myeloproliferative neoplasms. And if all fails, and if the patient is showing signs of transformation into myelofibrosis, then ruxolitinib can be used. Now, the reason why I use the interferon alpha as a second treatment choice is it has been shown over years that it induces very good complete hematologic remission, good molecular remission up to 20%, although nobody knows whether this means anything in terms of longevity or protection from other complications of the disease. Now, believe it or not, my choice after interferon is busulfan. In our hands, busulfan has been extremely wonderful, and we have looked at over 1,000 patients with ET and over 1,000 patients with PV, and could not find any suggestion that busulfan is any more leukomogenic than hydroxyurea. We don't use anagrelide anymore, and we only use ruxolitinib if there is some suggestion of transformation into myelofibrosis. During pregnancy, we try to just stay with aspirin alone. If it is a high-risk patient, then obviously interferon alpha. And talking about interferon, there is now another pegylated interferon. You all know about Pegasus, which is nicer because you can give it every 2 weeks. The side effects may be a little better. And then the ropeg interferon, you can give it every 3 weeks, but otherwise everything is the same. Ropeg interferon is no different in terms of side effects or efficacy compared to Pegasus. The only difference would be that you might be able to give it every 3 weeks. And the other major important difference is the fact that this could be FDA approved, and therefore patients, you can get reimbursement for the treatment. Now in myelofibrosis, things are a little different. And this is primarily because not only is life expectancy shortened, but also there are complications of the disease that require attention, including huge spleen, as you can see, and constitutional symptoms. And our therapeutic options with myelofibrosis revolve around what your objective is. If your objective is to cure the patient or prolong the life of the patient, then the only thing that can do is allogeneic stem cell transplant. Don't waste any time. If your objection is just to palliate the patient, then you can either do observation, and then the treatment depends on what the problem is. If the problem is anemia, then there are anemia-effective drugs like thalidomide and androgens. If the problem is a big spleen, I usually start with hydroxyurea, but JAK2 inhibitors work very well. And ultimately, you might need splenectomy. If the problem is constitutional symptoms, you have to use JAK inhibitors because hydroxyurea doesn't work there. If the problem is extramedullary hematopoiesis, involved field radiotherapy is the way to go. And then, of course, there is usually experimental therapy. Now, in terms of prognostication, cytogenetics is the most important. I have listed the bad actors here for you. Inversion 3, chromosome 17q, trisomy 21, monosomy 7, and so forth. And then this, along with mutations, if you just have that, you can have a very nice risk stratification simply by using molecular findings. And as you can see, if you are molecularly blessed, meaning that you have a type 1 CALR mutation, which is very good, you don't have any bad karyotype, and you don't have the bad mutations, then your survival at 5 years is 94%. And intermediate is not that bad, and here you are allowed to have 1 point, meaning that you could be CALR, type 1 CALR absent, which are most of the patients. And otherwise, then you have to seriously think about transplant. Now we used this for the molecular classification as I have shown you. But if you want to add some clinical features, such as anemia, constitutional symptoms, and circulating blood, then you can use a more refined prognostic scoring system, which we called MIPS 70, as published in JCO. And you can identify patients which are going to live forever, really long, but you can also identify patients that you have to rush into transplant with. And based on that, this is our treatment algorithm in myelofibrosis. If you are very low risk or low risk, first do no harm, just observe these patients. They can live a very long time, 30 years sometimes. If you have a high risk or very high risk, don't play around, take these patients to transplant. If you are intermediate risk, or if you have a low risk that is treatment requiring, then my preferred option is to put them in clinical trials. Otherwise, it depends on what the problem is, and I've already gone through what you should try to consider for what the problem is. Now, this is based on a study that is published in Blood showing that if you did transplant in low risk or intermediate 1 risk patients, you would probably kill the patient faster than the disease. If you do transplant in high risk or intermediate risk patients, then you probably can help those patients. Now, is there anything else you can do other than transplant to prolong? No, we've looked at it with the JAK inhibitors. That's the most popular in the treatment. We looked at it at ruxolitinib. And even the company-sponsored study didn't show significant improvement in survival. And we also looked at it with other JAK inhibitors like momelotinib. Absolutely no difference as to whether or not this patient received a JAK inhibitor as compared to those patients, historical controls that did not receive JAK inhibitors. What is important is whether or not they carry adverse mutations. The question is, can you overcome high-risk karyotype or adverse mutations? And yes, we've done a study in our center clearly showing that transplant, first of all, is better than no transplant, with a 50% survival, long-term survival. And this is true whether you are high risk or intermediate risk karyotypically. And others have shown the same thing, again showing that the transplant benefit is not neutralized by high-risk molecular mutations or cytogenetic risk. And if you can't transplant the patient, then the question becomes, what can you do to palliate the symptoms? We've got tons of JAK inhibitors, approved are ruxolitinib and fedratinib. They all work the same in terms of spleen and symptoms. Momelotinib appears to also have an edge in terms of helping with anemia. The others actually make anemia worse, but it is not approved as yet. And obviously, you have to look at the side effect profile. It appears that fedratinib has the worst profile in terms of side effects. And at this point, the JAK inhibitor that is used up front when you are thinking of JAK inhibitor therapy is ruxolitinib. And the points that you need in your practice is that the indications is you have to have marked splenomegaly or severe constitutional symptoms that are resistant to hydroxyurea. There is no sense of putting everybody on ruxolitinib just because they have the diagnosis. You have to ask the question, is there an indication for ruxolitinib use? And obviously, there are side effects. Patients become anemic or thrombocytopenic, and there are long-term side effects with immune suppression. And you also have to remember that you can't stop this drug quickly. You have to taper it off. And these are the unresolved issues, and these are one of my two last slides. And one issue is, how do you manage the spleen before transplant, since transplant is the only curative therapy? Do you not, intervene with anything? Do you do splenectomy? Do you do splenic irradiation? Do you use ruxolitinib before, after? These issues are being addressed at this point. I don't think any hard conclusions can be made, but I can tell you what I'm doing right now. If the spleen is like less than 15 centimeter, then I usually don't do any specific intervention, just let the transplant take care of it. I am doing less and less splenectomy because it might delay the transplant process. I don't do splenic irradiation, but you can do it, and there are centers that do splenic irradiation. But what if I have to do something? I think using ruxolitinib would be the way to go before the transplant. What about palliative treatment options when the ruxolitinib fails? Well, the first thing I would do is increase the dose, and I don't care about the counts. It's all a matter of benefit and risk. If the patient is getting some benefit and kind of losing it, but maybe the platelets are a little low, I still try to increase the dose before I go somewhere else. Splenectomy always remains, experimental therapy always available. Fedratinib, I said don't hold your breath because we have not had, because we've done all these studies, we've initiated all these studies, we have not had that much luck in patients with ruxolitinib failures. And these patients are very sick, and the platelets are very low, very difficult to use fedratinib. And then finally, how do you manage blast-filled disease? And that is a terrible disease, as you can see. And when we looked at 410 patients between Mayo Clinic and the Italian groups, we were able to show that if you don't do anything, survival is dismal. If you do something and get a complete remission, then you can prolong survival, but the long-term survival remains dismal. So what is the intention to how to manage these patients? Try to get them into CR or transplant. That's how you can prolong. The question is, how do you do that? With intensive chemotherapy, we were able to achieve 35% ER. With just hypomethylating agents alone, 4%. But most recently, we looked at retrospectively our experience in 14 patients, of which 12 are evaluable. And the addition of venetoclax to HMA resulted in what appears to be a more superior complete remission rate as opposed to HMA alone. So I think this is a very reasonable drug to use in trying to bridge into transplant or give patients some time so that they can manage their affairs. Now, finally, I have included two last slides for your pursual in the slide, but I'm not going to talk about them because none of them are exciting. These are all experimental drug trials that were presented at ASH. None of them are exciting. And the question you might ask is, well, if you don't think that they're exciting, would you give it to your patients? Well, the question is, I am not my patient, and patients have different agenda. Some patients don't want to sit around and wait for something better to come. They want to try whatever there is. I respect that patient. But if it was me who had the disease, it's very unlikely that I would participate in any of these trials because they're not that exciting. So I will leave you with that, and thank you very much for your attention.
I know we're short on time, but we do have a question from one of the viewers. Where do you think the impetus for future research in MPNs is expected to have the maximum impact on patient outcomes?
That is a very profound question. And the person who made that request clearly knows that there is no good answer to that. I think that the transplant data is very encouraging. So I think we should stay with the possibility of transplanting patients who are high risk. But in terms of palliative treatment, there are so many drugs, there are so many targets, and everybody is trying to make money. Everybody, as you know, that the drug company's interest is to get their drugs approved and make profit. Clearly, this is the elephant in the room. And the way these drug companies are designed is to accelerate and enable the approval of this drug, not necessarily to change the lives of our patients. So I would plead with the drug companies to give physicians the leeway to decide on the design of these drugs, rather than the companies designing the drugs and making sure that it fulfills the FDA requirement and therefore it will get approved. So if science is to drive the way, then drug companies have to rely more on scientists and clinicians to come up with the clinical trials, to come up with the protocols, to write the protocols, and actually to publish the protocols. And right now, the companies are the ones who are writing the papers, who are doing everything. So that has to change. If that habit is not changed, if that paradigm is not changed, I don't see too much progression, because we're just going to stay with drugs that make money but not necessarily help. So that's my plea. That's what I see as the future, that clinicians and scientists taking control of the research and the clinical trials.
Certainly a tough situation. Thank you, Dr. Tafiri, for the talk. We greatly appreciate it. And now,
thank you.
For our next speaker, I would like to introduce Dr. Tracy George. Dr. George is a professor of pathology at the University of Utah. She completed her med school and residency training in anatomic pathology and laboratory medicine at the University of California, San Francisco, with fellowships in hematopathology and surgical pathology at Stanford University. Her research interests include mast cell disease and laboratory hematology. Dr. George has authored hundreds of publications, and she's a recipient of the College of American Pathologists Lifetime Achievement Award in 2014. She will be talking to us about current concepts in mastocytosis. Dr. George.
So welcome to my lecture on current concepts in mastocytosis. My name is Tracy George. I'm at the University of Utah in ARUP Laboratories, and I'm delighted to give you this lecture for the Houston Methodist Cancer Symposium today. These are my disclosures. And this is the outline for the lecture today. I'm going to take you through definitions, diagnostic algorithms, classification, and end with therapy, all on mastocytosis. So let's talk about mast cells. These are really interesting cells of the immune systems. They're triggered by a number of different activators, including allergens and peptides, etc. And then they release mediators. Histamine is one of them, as well as corticotropin releasing hormone, IL-6, and a whole bunch of others. And this triggers different aspects of the human body. And we have systemic symptoms, respiratory, neurologic, musculoskeletal, digestive, cutaneous, and cardiovascular. And so these patients really present with a wide variety of symptoms, which can make diagnosing this disease very challenging as well as treating. So the way I think about mast cell disorders is there's clonal disorders, which is what I'm going to take you through today, and then there's non-clonal disorders. And non-clonal disorders are mast cell activation syndrome that is secondary and idiopathic. So the pathogenesis of mastocytosis begins with the KIT mutation, most commonly the KIT D816V mutation. And that transforms your wild-type KIT to mutant KIT where it's constitutively active. That increases mast cell proliferation and motility as shown, and you get organ infiltration, and most commonly in the bone marrow, spleen, and liver, but you can also see it in the GI tract and skin and other organs as well. So what is mastocytosis? It's a clonal neoplastic proliferation of mast cells, but it's pretty heterogeneous. So you have skin lesions that spontaneously regress in children, as shown here in these images. And that varies to highly aggressive leukemias with short survival and multi-organ failure, as shown in this patient. And the subtypes of mastocytosis are determined by the distribution and the clinical manifestations of that disease. We also now know that advanced systemic mastocytosis is a multi-mutated myeloid neoplasm. This was first described by Andreas Reiter and colleagues, where when they looked at a series of different types of systemic mastocytosis, they found that their patients with indolent and smoldering mastocytosis had 0 additional mutations other than the KIT mutation. But those patients with SM and associated hematologic neoplasm had 1 to 4 additional mutations, including TET2, SRSF2, ASXL1, ASIBL, and EZH2. And this work has been now validated by multiple other investigators in the field. And we now know that the SAR phenotype, standing for SRSF2, ASXL1, RUNX1, renders an adverse prognosis for overall survival in those patients. So let's move on to diagnostic algorithms. So I remember this patient that we saw at Stanford, and the dermatopathologists were super excited. They're like, well, look, Tracy, we've got a patient with TMEP. It's so rare. It's a rare form of cutaneous mastocytosis. And I said, well, you need to do a bone marrow biopsy in this patient because adults with cutaneous mastocytosis lesions actually have systemic mastocytosis. That's mostly indolent SM and fewer cases of advanced SM. Rarely, patients might have cutaneous mastocytosis only, but most of us think that it's a sampling error. So the workup of adults with cutaneous mastocytosis skin lesions is first the skin biopsy to confirm, yes, it's mastocytosis, a serum tryptase level, quantitative PCR for KIT D816V. This is a super sensitive assay like digital PCR or ASO PCR, and it can be performed in the peripheral blood, and then a bone marrow biopsy with ancillary studies. And I'm going to get into the ancillary studies, so stay tuned. What about adults without mastocytosis skin lesions? So you have a patient, they've got signs and symptoms that are suspicious for mastocytosis. You first start off with KIT D816V testing of their peripheral blood. If that's positive, it is highly likely your patient has systemic mastocytosis. So you need to do the bone marrow biopsy and associated ancillary studies to subclassify that. If it's negative, you're then going to look at your serum tryptase level. If your serum tryptase level is elevated, meaning more than 20, again, proceed to bone marrow biopsy. If it's less than 12, so that's normal, it's likely your patient does not have systemic mastocytosis. And if it's in between, like 12 to 20, you need to evaluate other symptoms, and you might want to even check for hereditary alpha-tryptosemia. This has recently been described by John Lyons at the NIH, and these patients have extra copies of the genes that encode for alpha-tryptase, and their baseline serum tryptase levels are slightly elevated. So what is the mastocytosis pathology testing standard of care? Well, there's laboratories, and these are all labs that you know about, your CBC, your serum tryptase, your comprehensive metabolic panel, and alkaline phosphatase, and other labs as directed by the patient's symptoms and signs. There's morphology. You need a blood smear, a bone marrow aspirate smear, a bone marrow biopsy, and you're going to do special stains like reticulin and trichrome for fibrosis, iron stain to assess for ring sideroblasts. And then you have to immunophenotype both your mast cells and your non-mast cell components. And what do I mean by that? Because you want to look and see, do you have mast cells, number one, and are they aberrant? So you can do this by flow cytometry, and there are specialized techniques to flow mast cells, and that's been nicely published by the Spanish Mastocytosis Network, RIMA. And you also want to do standard flow cytometry where you look at your other lineages, your blasts, your lymphocytes, monocytes, etc. And then you want to do immunohistochemistry on that bone marrow biopsy. You want to use KIT or CD117, tryptase, CD25, because CD25 is a marker of aberrancy. If your CD25 is negative, and especially if you have well-differentiated mast cells, then you might want to add on a CD30, and then a CD34, which will, of course, will be negative in mast cells, but increase in blasts, and you might do other stains as well, because you're not just looking for systemic mastocytosis, you're also looking for, are there any other associated hematologic neoplasms? And then last but not least, it's genetics. So karyotype, very important if you're looking for an AHN or an associated hematologic neoplasm. FISH for PGFR alpha, if the patient presents with eosinophilia. You want to do quantitative PCR for KIT D816V on blood and probably also on bone marrow. You want to do your myeloid gene panel by NGS, because again, we want to look for these additional somatic mutations. And you may do, depending on your patient's signs and symptoms, hereditary alpha-tryptosemia, because there's evidence now that's being published that those patients who have both systemic mastocytosis and HAT, hereditary alpha-tryptosemia, are going to be more symptomatic than those patients who have systemic mastocytosis without HAT. So let's get into classification, because this has changed in recent years. So the WHO 2017 classification that was published added a subtype of systemic mastocytosis called smoldering, which is somewhere in between indolent and aggressive. They changed the SMAHNMD to SMAHN, or systemic mastocytosis with an associated hematologic neoplasm, so just a terminology change. And then there was acknowledgement that mast cell leukemia can present both acutely, that is with C findings, or without C findings, and that's the so-called chronic mast cell leukemia. And these very rare chronic mast cell leukemia patients often evolve from other forms of mastocytosis. So you might have a patient who goes from indolent to smoldering to aggressive, and then ends up with a chronic mast cell leukemia. And then there's mast cell sarcoma, which I won't discuss further. And we got rid of a category, the extracutaneous mastocytoma, because no one had seen it. So this has remained the same pretty much. So how do you diagnose systemic mastocytosis? Well, you have to have one major and one minor criteria, or at least 3 minor criteria. The major is multifocal dense aggregates of mast cells, and an aggregate is defined as 15 or more mast cells. And then the minor are atypical morphology, so more than 25% of mast cells have an atypical shape or immature, an activating D816V KIT mutation, CD25 expression with or without CD2 expression, and a serum total tryptase greater than 20, unless you have an AHN, an associated hematologic neoplasm that's myeloid, in which case that invalidates criterion number 4 because they can sometimes secrete tryptase. So this is how I think about it, okay? There's cutaneous disease, skin only, and then there's systemic disease. You can also have skin involvement. And then there's subtypes of mastocytosis. Those that are more indolent, like indolent and smoldering systemic mastocytosis, and those that are more advanced. And these advanced are the SMAHN, aggressive systemic mastocytosis, and the very rare and aggressive mast cell leukemia. So how do you make this call? So now we're getting into the B and C findings. So B stands for burden of disease. So indolent SM is defined as 2 or less than 2 B findings, and smoldering is 2 or more. And these include 3. 1, mast cells more than 30% in the bone marrow and a serum tryptase level greater than 200, and that is an and. 2, organomegaly without impaired organ function. And 3, I find this one the hardest, signs of MDS or myeloproliferative neoplasm in the bone marrow without meeting the WHO criteria for an MDS and or an MPN. But we'll get into this. And then the advanced systemic mastocytosis, there's 3 types. The first one, easy, mast cell leukemia, 20% or more mast cells on an aspirate or blood smear. The next is SMAHN. You have to meet criteria for a WHO-associated hematologic neoplasm, and these are usually myeloid. This can be AML, MDS, chronic myelomonocytic leukemia, and MDS-MPN unclassifiable. And they also have to meet those criteria I showed you for systemic mastocytosis. And then the third type of advanced SM is aggressive systemic mastocytosis. And this meets criteria for systemic mastocytosis, right? The 1 major, 1 minor, the 3 minor at least. And you have to have 1 or more C findings, and that means cytoreductive requiring findings. Those include cytopenias, hepatomegaly with impaired liver function, skeletal involvement with large osteolytic lesions and pathologic fractures, splenomegaly with hypersplenism, and malabsorption due to GI mast cell infiltrate. So you may have to biopsy other organs to prove that your patient has a C finding. So let's get into therapy, because I think this is the most exciting area of systemic mastocytosis in recent years. So this is a great image from an excellent paper published over 10 years ago. And I like it because it really shows on these Kaplan-Meier plots that indolent disease is shown in that kind of red-orange color that behaves the same as age-matched controls in terms of overall survival. And you can see then how the other 3 main forms of disease, the mast cell leukemia in green, the SMAHN in that gray, and the aggressive systemic mastocytosis in yellow tend to do far worse. So KIT mutations have important implications for treatment and for selecting which tyrosine kinase inhibitor you're going to use, because the vast majority of patients have an imatinib-resistant exon 17 mutation, usually D816V or D816Y. That's most of your patients. The exact percentage depends on the study that you're quoting. And then there are rare patients that have imatinib-sensitive juxtamembrane mutations, for example, in exons 8 or 11. These are far rare, but you can see important for helping you choose which therapy to give your patient. So treatment comes in a variety of forms. There's observation only, there's topical therapy, symptomatic therapy, and then cytoreductive therapy, which has been typically reserved for those patients with advanced SM, so the most aggressive types of disease. So back now in 2016, we published a large international multi-site study looking at the efficacy and safety of midostaurin in advanced systemic mastocytosis. It took us 7 years to accrue enough patients for this study. I'm just going to jump right to the point. And before this, we didn't really have effective treatment for these patients. We found that for any subtype of advanced SM, the overall response rate was 60%. This varied from 50% overall response rate in mast cell leukemia to 75% in patients with aggressive systemic mastocytosis. So pretty impressive given that we didn't have ways to treat these patients. You can see here the variety of major responses and minor and partial responses. You can see we didn't have any CRs in this study. And the duration of response was pretty remarkable. Median was a little over 2 years, and you can see that median duration of response was not reached in patients with mast cell leukemia and aggressive systemic mastocytosis. So that's super exciting because what that means is that these patients were still living being treated with midostaurin. The clinical pathologic measures of response, you can see here in these waterfall plots, the bone marrow mast cell burden dropped dramatically in these patients on midostaurin, and that paralleled serum tryptase levels in these patients. And we also published an investigator-initiated trial, which was based in North America, and we actually started it before the international trial and published it after it, and we had similar results. And you can see with 10 years of follow-up, now we actually do have a few CRs as shown in bright green. So midostaurin, as you can see in these, this kinome illustration, is really a dirty TKI, right? Here it is over there. Its KIT is shown in bright yellow, but all of the off targets are shown in this red-orange, okay? So that's why we call it a dirty TKI, and you can see the biochemical IC50 below. Now look at avapritinib. Avapritinib is a KIT targeted inhibitor, and it has a very low IC50. So now I'm going to show you some data from the avapritinib clinical trials. So this is data from the phase 1 Explorer. Part 1 was a dose escalation study in 32 patients with advanced SM, and Part 2 was the expansion study, including those patients with cohort 1, advanced SM, and then cohort 2, advanced SM, that were evaluable by modified international working group criteria. So here's where we get into central pathology. So I led a team that did the central pathology review of this, and there also was a study steering committee that adjudicated each patient. And we had central assessments that were performed for serum tryptase, imaging levels. We did the central pathology. There was another lab that did the mutation assessment. And we did the central adjudication of diagnosis and response. And only responses that were confirmed for 12 or more weeks were considered. And this was very surprising. We found that 45% of the local subtyping of systemic mastocytosis changed during central adjudication. And there were 3 main reasons. The first was we found evidence of an associated hematologic neoplasm on central pathology. So the diagnosis changed, for example, from an ASM to an SM-AHN 20% of the time. The second reason was we found that WHOC findings were not present or documented upon review. And this was done by the Central Adjudication Committee. Not just me, we've got hematologists in there. And this was also almost 20% of the time. And the most common C finding that was not present was skeletal findings, where it was decided that after review of the radiologic imaging and the reports that it really wasn't a true C finding. And then weight loss was the other one, because remember, weight loss has to be due to GI mast cell infiltrates, so most of the time you have to have a GI biopsy. And then there were a variety of cases that had other central pathology discordances, just 6% of the time. So what this means is, at least this is what I think it means, is that WHO C findings are complex and mis-subtyping is common. 13 of 34 local diagnoses of aggressive systemic mastocytosis were felt to be ISM or smoldering due to the lack of WHO C findings upon central review. And we found that, not surprisingly, the presence of WHO C findings in aggressive systemic mastocytosis correlated with a higher serum tryptase level, as shown here, and a higher median marrow biopsy percentage of mast cells in that bone marrow. But whether patients were diagnosed with aggressive systemic mastocytosis or indolent or smoldering by the Central Adjudication Committee, you can see that their best change from baseline for serum tryptase is shown in green, and the other waterfall plots are bone marrow mast cells. And you can see a marked reduction in serum tryptase levels and in bone marrow mast cells in these patients treated with avapritinib. So this brings me to, what are the clues to diagnosing SM-AHN? And so this was presented at a Society for Hematopathology workshop back in September in Arizona. And it can be pretty easy. Some of it, if you've obviously got increased blasts in the blood or bone marrow, hey, you're likely dealing with an SM-AHN. Cytopenia as well, that's more variable. You can see that in other advanced SM subtypes. But if you have a leukocytosis, a monocytosis, a marked neutrophilia that's persistent, that's a clue you might be dealing with an SM-AHN. If you have evidence of obvious dysplasia, again, that's a clue you might be dealing with an MDS or an MDS-MPN. And if your bone marrow biopsy is hypercellular, away from those dense mast cell aggregates, well, that's also a clue you could be dealing with an SM-AHN. Abnormal karyotype, that's exclusively associated with associated hematologic neoplasms. And then here's a good one. If, when you test the peripheral blood using a super-sensitive method like a quantitative PCR for KIT D816V, and it is positive and high, and you have no circulating mast cells, that means your KIT mutation is in those leukocytes. And that's another important clue that you're dealing with at SM-AHN, because if you test the bone marrow, it can be high in a variety of different subtypes of systemic mastocytosis. And similarly, you can also see additional somatic mutations in actually any of the advanced SM subtypes. So this is a nice slide that I like to use from Andreas Reiter, because this is another way of thinking about it. You can have the KIT D816V mutation as shown at top, involving only mast cells. And that's typically what you see in patients with indolent systemic mastocytosis. But when you have multi-lineage involvement, so you've got that KIT mutation in both other hematopoietic lineages and mast cells, then you're more likely dealing with an SM-AHN. And I put in myeloid because the KIT mutation is present in both the other hematopoietic lineages and in the KIT mutation. These tends to occur in myeloid neoplasms. So that's why a surrogate marker for this is looking in the blood with a supersensitive method for KIT D816V mutation. And then there's those patients who have both multilineage involvement and multi-mutated disease, and those are also can be SM-AHN, but also mast cell leukemia. And then some of the additional somatic mutations are listed that you can find are listed below. So what about back to our study? So all patients enrolled in the study were 69. The modified international working group evaluable patients were only 39. Okay, and you can see the different SM subtypes is listed here. And not surprisingly, those patients with modified IWG evaluable that patient group, those patients had higher ECOG performance status. Okay? And we saw higher percentages of mast cells in the bone marrow. We had higher serum tryptase levels and a higher KIT D816V allele fraction. So what happened with avapritinib? So 65% of patients returned to normal serum tryptase levels. And this occurred in all sorts of different subtypes of SM, as shown in those colored dots. It included those patients who had the SAR genotype, and including those patients who've been previously treated with midostaurin. 79% of patients cleared bone marrow mast cell aggregates. And again, all different subtypes of SM, SAR genotype, whether they'd been previously treated or not. 84% of palpable spleens became non-palpable. And there was a more than 50% reduction in marrow KIT D816V in 88% of patients. You know, suggesting that some of these patients actually look like they're going into some sort of molecular remission. So we saw a high rate of confirmed modified IWG responses across all the advanced SM subtypes. You can see 77% of patients. And this varied from 100% of patients, there are only 3 of them with ASM, to 75%, including patients with mast cell leukemia and patients with SM-AHN. And we saw an overall response rate of 73% of SM patients who had an SAR genotype. We also saw that responses occur rapidly and deepen over time. And I think that's easiest to see. If you look at the bright green on the bottom, that's complete remission. And you can see months on treatment with avapritinib, how that the bar graph grows and grows. The median time to initial response was quite early at 2 months. And 74% of patients maintained a response for at least 1 year. And patients have been on therapy up to 34 months. So interestingly, here's the survival curves. The median overall survival was not reached for any subtype of systemic mastocytosis because the patients are still living. So this is great news. The estimated 24-month overall survival rate was 78% for all patients with advanced SM, and for those patients who we reclassified as indolent or smoldering, it was 100%. What about adverse events? So most adverse events were grade 1 or 2 as shown. Cytopenias were the most common grade 3 or greater treatment-related adverse event. There were no grade 5s. 44% of patients discontinued treatment due to these AEs. 13% discontinued due to clinical progression. And for most of these, this was progression of their AHN to like acute myeloid leukemia. And then we had intracranial bleeding in 7 patients. 5 of the 7 patients were able to resume therapy, and we thought this was related to platelet count, and so we implemented dose modifications for thrombocytopenia. And 71% of patients remain on treatment. So here's an example of a patient. She's 45. She had an SM with an MDS-MPNU, and you can see the marked reduction in mast cell aggregates and serum tryptase that's shown on the left. And then look at the KIT variant allele frequencies in blood and marrow, and that shows a similar marked decrease in a similar time. And interestingly, this patient also had mastocytosis skin lesions, and these also disappeared while the patient was on therapy, as shown. This was a patient that we had with smoldering systemic mastocytosis. She was a 55-year-old female who presented with hepatosplenomegaly. Her serum tryptase level was more than 300. Her hemoglobin was 10.5 with normal white count platelet and liver function tests. She only had a D816V KIT mutation, no other mutations. And you can see in this bone marrow biopsy photographed by my colleague, Dr. Anton Retz, that there was 75% involvement by mast cell aggregates, all expressing KIT, tryptase, and CD25. Here's what it looked like 6 months later, right? The bone marrow is now normal cellular or trilineage hematopoiesis. If you stain it for KIT, as shown here, this is the brown stain, you can see that you still have some areas with persistent disease. I estimated about 5%, and there were a few aggregates. The CD25 is now negative, and the patient initially also had some fibrosis in the bone marrow, and that is now gone. It's MF0. At 10 months, you can see it's still normocellular. You still have about 5% mast cells. Interestingly, the shape is a little different now. They were a little bit more spindle-shaped, and now they're quite round as well. Here's another patient. It was a 61-year-old man with fatigue, weight loss, hepatosplenomegaly, and ascites. He had an absolute monocytosis, and we diagnosed him with ASM-CMML0. He also had a deletion on 13q. He had 3 mutations, the KIT D816V, and 2 TET2 mutations as shown. The second TET2 mutation was a VUS, a variant of undetermined significance. Here's the bone marrow. You need to count the mast cells. You can see they're highly aberrant here. You've got spindle-shaped forms. There were 10%. I counted 4% blasts and 31% monocytes. Here's samples of the core biopsy. You can see that dense aggregate of mast cells marking with KIT and CD25. And interestingly, the tryptase was pretty dim and only in a subset. So we sometimes see that where these patients with advanced SM are going to have very dim tryptase expression. After 6 months, the serum tryptase level has dropped to 14.4. The patient is now normal cellular. And if you look at that tryptase stain, it's almost impossible to see the mast cells. But they're there. They're just widely scattered, mostly round mast cells. I estimated maybe 2%. They're also CD25 negative. But, and I'm not showing you the peripheral smear, I'll just tell you, the atypical monocytosis persisted, the patient's thrombocytopenic, they have a macrocytic anemia, so they still have the persistent chronic myelomonocytic leukemia. So this is interesting. So let's now map the patient's gene and their variant allele frequencies, their genetic mutations, with their mast cell burden over time. And the cycles correspond to months on avapritinib. And so you can see that the mast cell burden and the KIT D816V rapidly drop, like by cycles 3, 7, 11, but the TET2 mutations persist and really paralleling that chronic myelomonocytic leukemia, just kind of showing the utility of NGS in following these patients. Also, what did I see from the pathology point of view? Well, let's look at the mean expression of KIT and CD25 on mast cells in these biopsies. And what I saw was that there's retention of CD117 expression on mast cells throughout avapritinib therapy, but in contrast, CD25 expression markedly goes down by cycle 3 and cycle 7 on patients with avapritinib therapy. And this is very similar to what we saw in midostaurin, but it's much more dramatic here. So this is my bone marrow response to avapritinib model. And you can see at baseline, you've got a patient, it's bright KIT and it's tryptase positive, and you got mast cell aggregates, and they usually co-express CD25 with an elevated serum tryptase level. But by months 3 to 7, actually what we see is that the patients can become hypocellular in the bone marrow. You can still see some mast cells, usually not tight aggregates anymore, and they're funny shapes, so you still might see some spindle shape, maybe even an immature mast cell or two. But by months 7 to 11, the bone marrow is now normal cellular, and the mast cells have changed as well. They now lack CD25 expression. They've gone from immature and spindle-shaped forms to small, round, well-differentiated mast cells, and they look like normal mast cells. We also saw some preliminary evidence that there might be an improvement in bone marrow fibrosis. So what I'm showing here are reticulin stains from a patient with SM and myelodysplastic syndrome with multilineage dysplasia. And at baseline, they had MF3 fibrosis. But then by cycle 7 and also at cycle 11, that decreased to MF1 fibrosis. And then in the graph over here, you can see that patients with MF3 at screening on average went down to MF1 at cycle 3, cycle 7, and so on. So, in conclusion, avapritinib induces complete and durable responses across the systemic mastocytosis spectrum. We had a 77% confirmed central overall response rate by modified IWD criteria. The responses occurred at a median of 2 months, and they deepened over time. We had 4% of patients discontinued for treatment-related adverse events, and 71% remain on treatment. And avapritinib was granted breakthrough designation for advanced SM and orphan designation for mastocytosis. There are now phase 2 trials for both advanced disease and indolent disease that are enrolling in Europe and North America. So I want to thank everyone, especially the patients and their families, the phase 1 investigators is listed here, and our newly formed American Initiative in Mast Cell Diseases. So thank you very much, and I'm happy to answer any questions that you have.
It was a very enlightening presentation. We appreciate the insight. And I believe we have a few questions. We can start with, how do we manage GI symptoms if that is the only presenting symptom, diarrhea and bloating? Is budesonide the best option?
As a pathologist, I can only answer some of these questions. But definitely treating GI symptoms is the most appropriate thing to do. Budesonide is one option. I'm going to defer to my clinical colleagues on the management of GI symptoms.
Thank you. I think there's another question. What are your thoughts on the presence of clonal mast cells in the marrow of CBF AML patients? I believe they mean core binding factor AML patients.
Yeah, so this is a really interesting topic that I've published on, is that we see increased numbers of mast cells in the bone marrow of patients with AML and H21 translocation specifically. And in some of those patients, I found that you do have a, quote, hidden systemic mastocytosis, or maybe not so hidden mastocytosis. We have a case right now that we're managing at the University of Utah, where when the patient relapsed, we found evidence of systemic mastocytosis. In that case, just a small amount of disease, but about 5%. And interestingly, this is not unusual. We see this about 10% of the time in AMLs with H21. And importantly, you have to manage that systemic mastocytosis. And so you need to know what particular KIT mutation is present. And so in the case that I'm dealing with, we had a very unusual KIT mutation in exon 11 that was imatinib sensitive. So treatment with reinduction also included imatinib, and now the patient's in CR, and we're going to go ahead and transplant. But what that means is that you should be stating every single bone marrow with AML with H21 for tryptase, because the mast cells are incredibly subtle in these bone marrows, and sometimes you only see the mast cells after induction therapy for AML, for example, when the mast cells really pop out. But if you go back, and that's often in the initial bone marrows, you can see increased numbers of mast cells with tryptase staining. And so then you have to apply your WHO criteria to see if you actually meet criteria for systemic mastocytosis. In the case we had, we went back, and at diagnosis, there were increased numbers of mast cells, but they did not meet criteria for systemic mastocytosis. It was only when this new KIT mutation developed that we had evidence of systemic mastocytosis. So be wary with your AMLs with H21. I have not seen similar findings in the other core binding factor, the AMLs with inversion 16.
So I think as a follow-up, if you have a patient with core binding factor AML that's KIT positive and you're suspecting a mast cell clone, so you would just recommend staining with tryptase to see if there's a separate clone, or would you do cell sorting to see where the KIT mutation's coming from?
Well, so that's a really great question. And what people have done previously in the literature is they've shown that the mast cells that are present in core binding factor AMLs with H21 translocation are related. And there's really nice studies that were done in Austria and Germany that showed that the KIT mutation is present in both the mast cells and in the blasts. And actually the H21 translocation using FISH testing is present in both the mast cells and the blasts. So we really often just assume now that if you do have a KIT mutation, that it's going to be present in both blast and mast cells, because this is an example of an SMAHN, or systemic mastocytosis with an associated hematologic neoplasm. So we know that the two are related. And that's been my experience in these cases. So you can go, and it is incredibly interesting to do cell sorting and then to look for the KIT mutation, because these are reportable cases. But on a practical matter, if you don't have access to cell sorting, we assume that the KIT mutation is present in both. And so looking for the mast cells, in addition to staining the biopsies with tryptase, you also need to look at your aspirate smears very carefully. And in many of these cases, when I've gone back and looked at them, you can actually find the mast cells. And of course, mast cells aren't just spindle-shaped. They can sometimes be those immature promastocytes, which are round and can sometimes be overlooked.
Thank you. And I believe we got a new question. Since the MF goes away in the marrow, does splenomegaly resolve in part because the need for extramedullary hematopoiesis resolves, or just because mast cell disease is treated?
So that's a really interesting question. We know that systemic mastocytosis has a propensity for involving the spleen. And although, of course, we don't recommend doing splenectomy in these patients, but I have seen spleen specimens from patients who have had splenectomy for one reason or another. And the splenomegaly in those patients is due to extensive mast cell disease. Is there extramedullary hematopoiesis? There may be a little bit in those patients, but in general, the splenomegaly is resolving, in my opinion, because the mast cell disease is being treated in the patient. So I think that it's not so much extramedullary hematopoiesis, but just treatment of mast cell disease, which is in the spleen, it's going away, so your splenomegaly is resolving.
Thank you. And I think lastly, we have one more question. What should we expect to see with the upcoming research to improve our understanding and ability to treat or possibly eradicate this disease?
Well, so mast cell disease is a really hot topic right now, and there's a lot of research that's going into treatment of this. So I expect that we're going to see additional targeted KIT inhibitors that are going to become available on the market. So, we started with midostaurin, kind of our dirty TKI. We've moved to avapritinib, a very targeted TKI for KIT. And we're going to start seeing additional next generation KIT targeted drugs. And that's going to help us treat this disease. And just like AML, with this BEAT AML trial, the molecular findings, I think, are going to drive our treatment for this disease. That seems to be incredibly effective. Now, there also are other research approaches, some by other very important researchers in the field. I think targeting CD123 makes sense. We looked at targeting CD30 and that didn't work out for mastocytosis, but I think that's another approach, the immunologic approach, looking at antigen expression on mast cells. So those are some of the exciting things that we're doing, as well as, we're also doing checkpoint inhibitor. That's my own research, which I didn't present today, looking at PD-L1 expression on mast cells, which we're seeing as well.
Thank you. I think that's all the questions that we have thus far. Dr. George, we really appreciate you joining us today. Thank you so much for your input.
Thank you, everyone.
I think we will take a short break at this time. And as we go on break, I would like to take the opportunity to go over some key housekeeping points again. So please don't forget to visit our virtual exhibitors hall. We're grateful to the supporters of the symposium. Please also visit our virtual abstract poster hall, and you have the code on your screen to scan for access. And tweet us. We're at Houston Methodist Cancer 2020. And you can use your phone to submit questions for the presenters, and you can submit the questions at any time during the presentation. You have two options on how to participate. You can either go to polev.com/Methodist and enter your question, or you can text Methodist to 37607 once to join and then text your questions. We will reconvene in about 15 minutes after the break for the next session. Thank you. Welcome back. I hope everybody had a nice chance to visit the posters and the exhibit hall virtually. Now moving on, I would like to introduce our next speaker, Dr. Lakisa Hill. Dr. Hill completed her medical school from University of Texas, Galveston, and her residency from Vanderbilt University. She went on to do a clinical fellowship in hematology oncology at the MD Anderson Cancer Center and subsequently joined the Houston Methodist Baylor Cell and Gene Therapy Unit. Today, she will be talking to us about the role of stem cell transplants in myeloproliferative neoplasms. Dr. Hill.
Good morning. I'm one of the BMT attendings in the Center for Cell and Gene Therapy at Baylor College of Medicine in Houston Methodist Hospital. And today, my talk will focus on indications for allogeneic stem cell transplant in patients with myelofibrosis. Here are my disclosures, and here are the objectives I will cover over the course of the talk. So despite the availability of JAK inhibitors for the treatment of myelofibrosis, allogeneic stem cell transplant remains the only curative therapy for both primary and secondary myelofibrosis. And while the efficiency or efficacy of allogeneic transplant results from high-dose conditioning chemotherapy in addition to graft versus tumor effect following allogeneic immune reconstitution, the procedure is associated with significant morbidity and mortality due to regimen-related toxicities, graft rejection or failure, graft versus host disease, and high risk of infectious complications. The need for transplant is often questioned both by patients and providers now that quote-unquote less risky therapies such as JAK inhibitors are now more widely available. While there is a lack of consensus and heterogeneity of data on various aspects of stem cell transplant for the treatment of myelofibrosis, such as the role of age, best graft source, and conditioning regimen, this has led to continued controversy in the selection of patients best suited for stem cell transplant. Ruxolitinib, as you all know, was the first JAK inhibitor approved for myelofibrosis in 2011, and in August of 2019, fedratinib, a JAK2 selective inhibitor, was approved. And while JAK inhibitors may provide significant improvement in splenomegaly, constitutional symptoms, and quality of life measures, they do not modify the underlying disease course or provide curative therapy. Reduction in the JAK2 allele burden is only modest at best and does not appear, and JAK inhibitors do not appear to reduce the risk of leukemic transformation. Long-term data has shown that approximately 50% of patients will discontinue ruxolitinib on average of 2.5 to 3 years due to loss of response and/or side effects. Others, such as those with multiple mutations or unfavorable cytogenetic karyotype, may have an inferior response to JAK inhibitor treatment and therefore a much shorter time to treatment failure. It remains unclear if the favorable response related to JAK inhibitors leads to better transplant outcomes because patients who respond to JAK inhibitors have an intrinsically more favorable biology, or because JAK inhibitors improve the clinical status of patients, allowing them to proceed to transplant. In this slide here, we have data from the Center for International Blood and Marrow Transplant, or CIBMTR, which shows trends for transplant and myelofibrosis between the years 2000 and 2014. Diagram A represents the number of transplants that were carried out each year during this time frame, and as you can see, despite the approval of Jakafi in 2011, the number of transplants has actually increased, unlike when TKIs were approved for the treatment of CML and the use of transplants drastically decreased. And in diagram C, we observe that the number of transplants in patients greater than 60 years of age, which is represented in the blue portion of the bar, and the percent of transplants using unrelated donors has also continued to increase over time, which may be influenced by the adoption of reduced intensity conditioning, which has allowed a larger proportion of older patients with myelofibrosis to be considered for allotransplant. As I'm sure you are all well aware, there are multiple prognostic scoring systems that have been developed with the primary aim to determine which patients with myelofibrosis should be referred for transplantation. In general, patients with intermediate risk 2 and high risk disease who have a median overall survival of less than or equal to 5 years or greater than 20% risk of leukemic transformation over 5 years should be referred for consideration of allotransplant. Of note, all of these scoring systems were based on studies done in patients with primary myelofibrosis only and were also developed prior to the wider availability of JAK inhibitors. In contrast, low and intermediate 1 risk patients are not routinely offered transplant. However, patients with intermediate risk 1 disease who have transfusion dependence or unfavorable cytogenetics, especially if younger, should be considered for allotransplant. And while there is no consensus regarding the optimal prognostic tool to use, in general, models that incorporate both cytogenetic and molecular features are more discriminatory in distinguishing these risk groups than those that use clinical features alone. If both cytogenetic and molecular data is available, then GIPS is a simple tool used to determine those patients that fall in both either the highest or lowest risk of death. For those falling into an intermediate risk category based on GIPS scoring, the MIPS 70 plus version 2 can be used to further stratify those patients to determine what patients might ultimately benefit from transplant. However, each center and physician has their own preference and may prefer using MIPS 70 upfront. And if no molecular analysis or cytogenetic information is available, then the DIPS plus scoring can be used. Recently, the myelofibrosis secondary to PV and ET prognostic model was introduced to assess prognosis in patients with secondary myelofibrosis and has been validated in both EBMT and Spanish registries in patients with secondary myelofibrosis. However, this has not yet been incorporated into standard practice among most transplant centers. And whether or not this will translate into better overall survival in patients with secondary myelofibrosis undergoing transplant will require further studies. Meanwhile, it may serve as an additional prognostic tool to base the indication for allotransplant in this subgroup of patients. Tafari et al. Have also recently shown in a retrospective study that allogeneic transplant can overcome adverse survival effects from very high risk and unfavorable karyotypes in myelofibrosis. In the unstratified analysis, denoted in diagram A, the median survival was 9.3 years in patients who underwent transplant versus 3 years in those who did not proceed to transplant. And in a comparison of post-transplant survival in 56 patients who were compared with a control group of 56 patients with primary myelofibrosis stringently matched for age, DIPS score, and cytogenetic risk category, patients with intermediate risk 1, 2, and high risk disease, or those with very high risk or unfavorable cytogenetics who underwent transplant, which are these lines demonstrated as dotted lines, had significantly better overall survival compared to those who did not ultimately proceed to transplant. So early referral remains the critical factor for optimal transplant outcomes, as delays in referral can reduce success rates for transplant, as there may be a narrow window of opportunity, particularly for those with higher risk disease, to proceed to transplant, and delays might preclude the ability for patients to undergo transplant altogether. Here are patients that should be considered at the time of diagnosis: those with DIPS intermediate 2 and high-risk disease, those with DIPS intermediate 1, with low platelet counts, transfusion dependency, or complex cytogenetics, or patients who have any of the following high-risk non-driver mutations, or those with triple-negative disease. If allogeneic transplant is a possibility, HLA typing should be pursued upfront and potential donors identified at the time of diagnosis, whether or not the patient proceeds immediately. So careful review of patients' disease and transplant-related factors is required in the appropriate selection of patients who are eligible for transplant. There are no prospective randomized trials comparing transplant to non-transplant therapies to further guide clinical decision-making, but based on available data, we know that JAK inhibitors do not modify the disease course, although multiple other agents are currently undergoing clinical investigation. Patients who have non-CALR driver mutations, significant cytopenias, high-risk cytogenetics, non-driver mutations or subclonal mutations, or patients with increasing peripheral blasts or leukemic transformation are at risk for significantly shortened survival if they do not proceed to allo transplant. On the converse side, patients who are older individuals and thus more likely to have comorbidities, which may create challenges even when using reduced intensity conditioning regimens, may suffer worse outcomes after proceeding with transplant. Lack of a suitable donor is also an important concern, as studies have shown that patients who undergo mismatch unrelated donor transplant have increased non-relapse mortality and decreased survival. And patients with severe portal or pulmonary hypertension are also at increased risk of higher non-relapse mortality due to regimen-related hepatotoxicity or respiratory failure. I would also like to point out that insurance coverage also plays an important role in patients who are able to proceed to transplant, as myelofibrosis is not currently an indication for transplant under the National Coverage Determination, and therefore is not covered under Medicare insurance, which presents a huge barrier of access for older transplants seeking consideration for allo transplant. While post-transplantation hematological recovery has regularly been reported in splenectomized patients, along with better graft function, the influence of splenectomy on post-transplantation survival or relapse is more controversial, thus giving the not insignificant periop morbidity of 25 to 30% and a mortality rate of 6 to 7%. Use of splenectomy is not routinely recommended. However, it may be considered on a case-by-case basis, particularly in patients with a significant spleen burden or significant pain and constitutional symptoms related to the enlarged spleen. So optimal timing of transplant is based on individual patient and transplant specific factors, which have to be carefully considered in each patient who is evaluated. Also taking into consideration the patient's goals of care and desire for quality of life. But in general, the aim is to proceed to transplant as soon as a donor is identified if the patient is otherwise eligible. Delay in therapy, which leads to progression of disease or leukemic transformation, is associated with very poor outcomes, and patients with blast transformation do significantly worse with transplant and are not generally considered eligible. However, if they receive induction therapy or debulking therapy and achieve a good response or remission, they may be later considered for transplant. And in patients who are responding to JAK inhibition, while there are no prospective studies addressing the question of what time point patients should proceed to transplant, there has been a large retrospective study evaluating patients who underwent transplant between 2009 and 2014. And in this study, they showed that in patients who were responding to Jakafi prior to transplant, the 2-year overall survival was 90% versus 55% in those patients who had stable disease or worsening splenomegaly, development of constitutional symptoms, compared to 32% in patients who actually had leukemic transformation. Response to Jakafi was also, pre-transplant was also associated with a lower 2-year non-relapse mortality. And so while one must be cautious in drawing any strong conclusions from this study due to the retrospective nature and the potential risk of selection bias, these data do raise an important question that I mentioned earlier regarding whether better outcomes in these patients is related to clinical improvement prior to transplant from use of JAK inhibitors, or is it a result of a direct effect of JAK inhibitors, or does it just select for patients who have a more favorable disease biology? Another important consideration in patients who are receiving ruxolitinib pre-transplant is the timing of discontinuation. And so, as we all know, that abrupt cessation of Jakafi can be associated with significant and even life-threatening withdrawal syndrome. And so typically we initiate taper within 5 to 7 days prior to the start of conditioning in an attempt to prevent complications from withdrawal syndrome. And this chart here is just a picture of a suggested taper based on a study done by Gupta et al. However, the discussion and timing of taper should always happen in collaboration with the transplant provider to prevent unnecessary toxicity and potential delay of the patient proceeding to transplant. So what is the best donor and conditioning regimen? Well, there is no one best answer, and there's no consensus regarding the optimal source of stem cell graft or choice of conditioning regimen. And the approach varies by institution and by transplant physician. Peripheral blood currently is the most used source of hematopoietic stem cells for both match-related donor and unrelated donor transplants. And while alternative donor sources have been shown to have some efficacy, the true success rates and incidence of complications such as graft failure and graft versus host disease remain to be determined. In terms of the use of reduced intensity versus myeloablative conditioning, the results are variable, but overall seem to be comparable. And so generally myeloablative conditioning can be offered to fit patients who are less than age 60 to 65 years old. Here I've listed several studies in descending order from time of performance, with most recent studies listed on the top. with the exception of the last study, which I'll mention in just a second. And as you can see, most studies included patients who received both reduced intensity and myeloablative conditioning, with a median age of patients being in the mid-50s. In the three most recent studies listed at the top, they primarily use reduced intensity conditioning. And after 3 to 5 years of follow-up, you can see that the overall survival at 5 years ranged 47 to 65%, with the non-relapse mortality of 16 to 24%, in comparison to some of the older studies where 5-year overall survival was 30 to 55%, with a non-relapse mortality of 30 to 50%. And these outcomes were in all comers, not stratified by donor type or conditioning intensity. And the last study here by Samuelson et al. Specifically looked at patients aged 60 to 78 with a median age of 65 who underwent match-related donor or unrelated donor transplant using a variety of conditioning regimens. And the 3-year overall survival was 45%, with a non-relapse mortality of 30%. And while these patients were probably so highly biased and selected, the results were encouraging that show that older patients who were fit and in good condition should be considered for allotransplant. So looking at slightly more recent data on transplant outcomes for myelofibrosis, this is again data from the CIBMTR, and on the left-hand side, or your right-hand side, we have patients who underwent match-related sibling donor transplant between the years 2007 and 2017. It was roughly a total of 1,900 patients, which included both myelofibrosis and secondary myelofibrosis due to ET or PV. And in the subsequent chart, we see outcomes for patients who underwent unrelated donor transplants. And the 3-year probability of survival in patients undergoing match-related donor transplant was roughly 61% for myelofibrosis, and in the unrelated donor arm, essentially comparable at a 3-year survival of 55%. And then looking in the overall trends over time, you can see here that in each of these time frames, with the most recent being 2011 to 2017, the 3-year survival in patients with MPNs has continued to slowly improve over time. And so, do mutations matter for transplantation outcomes? We know they matter for upfront outcomes at initial diagnosis. And so several groups have attempted to evaluate the impact of mutations on the outcomes of transplant. A study by Kroger et al. Retrospectively evaluated 169 patients who underwent transplant with busulfan conditioning, and the results showed that presence of CALR mutation was associated with favorable overall survival and non-relapse mortality, while AXL1 and IDH2 were independent prognostic risk factors for decreased progression-free survival. Ali et al. Evaluated the outcomes of patients who underwent reduced intensity conditioning with flu-mel and looked at a variety of somatic mutations, including AXL1, EZH2, IDH1, 2, SRSF2, and UTAF1, and noted that patients who had UTAF1 had increased non-relapse mortality, although CALR, AXL1, and IDH1 and 2 mutations were not found to have any significant impact. And in a study of roughly 100 patients evaluated by Tamari et al., these findings also showed that there was no impact on overall survival or relapse-free survival for patients with AXL1, SRS2, IDH1 or 2, or EZH2. And so while these findings further support the use of targeted gene panels to determine mutational risk profiles, larger prospective studies are needed to fully validate these findings. This slide here essentially just is an example looking at a new prognostic scoring system known as myelofibrosis transplant scoring system, which was developed in an effort to try and better predict outcomes following transplant and assisting with counseling regarding post-transplant prognosis. And in this analysis, there were both patients with primary and secondary myelofibrosis included. 7 individual independent risk factors were identified, including age over 57, KPS less than 90, non-CALR, MPL driver mutations, AXL1 mutation, use of an unrelated mismatched donor, and elevated white blood cell count or low platelets prior to transplantation. And they were able to use these risk factors to define 4 levels of risk stratification ranging from low to high, with 5-year survival risk by risk group of 83% in the low risk, 64% in the intermediate, 37% in the high risk, and 22% in the very high risk group. And so while additional validation is required, this score system is an additional tool to help with clinical decision making for patients who are eligible for transplant and maybe on the fence about whether or not to proceed. And this study here is really a retrospective multi-center analysis that looked at disease and treatment-related factors to assess association and survival differences based on transplant data obtained from the CIBMTR between 2000 and 2014. And non-transplant data was obtained from the MPN Research Consortium. And what I would really like to point out in this graph here is that while there was early dropout in the transplant group, primarily due to transplant-related mortality, and the curves crossed much later in the clinical course, several years out, up to 5 years out, the slope of the curves start to change much earlier, around 1 year following transplant, and then plateau, indicating that the overall survival benefit with transplant actually begins much earlier than when the curves actually cross. And long-term survival advantage with transplant was observed for patients who had intermediate 1 or higher risk disease, although potentially at the cost of higher early mortality. And the magnitude of this overall survival benefit increased as the DIPS risk score increased. And so this study just further highlights the need for, again, careful patient assessment and risk-benefit discussions with patients regarding transplant versus non-transplant options, as well as continued development, the need for continued development aimed at therapies or interventions to reduce post-transplant complications. So just briefly mentioning some of the transplant complications that can occur due to splenomegaly and portal hypertension or extramedullary hematopoiesis in the liver. These patients can be at high risk for liver injury. If they have pulmonary hypertension, potentially at increased risk of respiratory failure during the course of the transplant. Graft failure or poor graft function is a potential complication. And as I mentioned earlier, potentially higher risk of this in patients who have significantly enlarged spleens, but the reported incidence varies anywhere from 2 to 25%, and also depends on the conditioning regimen and cell source. Infection is a risk for all patients, not just myelofibrosis patients undergoing transplant. And of course, graft versus host disease and relapse are the primary causes of non-relapse mortality. So issues remaining to be addressed are questions that still are unanswered, include administration of JAK inhibitors throughout treatment, including use post-transplant, the use of Jakafi after transplant for persistent splenomegaly, the timing of transplant for responders to JAK inhibitors, and in patients failing to respond, should they proceed directly to transplant after lack of response in the first few months, or should other investigational agents be tried? And again, the timing of proceeding to transplant as soon as a donor is identified, should that happen even in patients that are responding to JAK inhibitors. And so just a few key points. Allogeneic transplant is associated with prolonged survival and potential of cure in the appropriate patients, particularly those who have high-risk disease. The transplant referral should occur early after diagnosis, both to assess suitability and to determine donor options. And patients should be repeatedly seen or assessed during the course of disease, because those who may not have been eligible initially may become candidates over time. Age should not be a hard stop or barrier for referral. And patients with intermediate 1 risk disease who have high-risk features such as transfusion dependence, increasing peripheral blast, or adverse cytogenetics or karyotype should be referred for evaluation as well. Overall, the use of JAK inhibitors pre-transplant is safe and should be used in patients that are symptomatic prior to proceeding to transplant. And if at all possible, the mutational status should be determined to further help refine the risk of patients that are considering proceeding to transplant, or even to determine the indication for transplant. And in general, additional studies are needed, not only to find better agents to treat myelofibrosis, but also to address many of the controversial issues surrounding transplant in terms of best conditioning regimen, best GVHD prophylaxis, and also addressing ways to improve non-relapse mortality and relapse following transplant. Thank you for your time and attention, and I'll take any questions at this time.
Thank you, Dr. Hill, for that talk. I think we're running a little behind, so we may have time for one question. There's a question that came in. Is there a role for CAR T-cell therapy in myelofibrosis patients?
Okay, so great question, but at this time, there's currently not any, certainly not any clinical trials that I'm aware of using CAR T-cell therapy. There may or may not be some basic science research going on in the area, but I think the primary issue would be identifying a potential target antigen, which I am not aware of. So at this time, unfortunately, no, there's no options as far as CAR T-cell therapy for myelofibrosis.
Thank you. Thank you, Dr. Hill. At this time, we will move on to our next speaker in the interest of time. For our next speaker, I would like to invite Dr. Prithviraj Bose. Dr. Bose completed his medical school from the University of Calcutta in India. He then completed his internal medicine residency from the Henry Ford Hospital in Detroit, Michigan, and a clinical hematology-oncology fellowship from the University of Oklahoma. He is currently an associate professor in the Department of Leukemia at the MD Anderson Cancer Center. He is leading a number of important therapeutic clinical trials in myelofibrosis at MD Anderson, as well as in other MPNs such as essential thrombocythemia and systemic mastocytosis. He will be talking about novel agents and combinations for myelofibrosis beyond ruxolitinib. Dr. Bose?
Thank you, Jasleen. Thank you, Dr. Chang, and all our friends at Methodist. As you see, my topic today is beyond ruxolitinib, so newer drugs, combinations that are being developed for myelofibrosis. My interest is primarily drug development, and of course, within the MPN space, myelofibrosis is where most of the action is. So ruxolitinib, of course, has been our cornerstone of therapy for myelofibrosis for 8 to 9 years now. This is the drug that produces dramatic and rapid benefits in terms of symptoms and spleen for patients. It's truly been a game changer in the field, I believe, and has become the mainstay of therapy and has a survival benefit in patients with intermediate to and high risk disease that as was shown in the long-term follow-up of the COMFORT trials. But today's talk again is on newer agents and where we go, what might be next on the horizon, and some recent approvals as well in the field. I'm just trying to see here if I am having a problem with okay, we're good. All right, so this shows you the kind of the JAK inhibitor story, which is a little bit of a checkered path, as I'm sure many of you are aware. Some of the JAK inhibitors had to be discontinued because of toxicity. There were others like momelotinib and pacritinib, which were in phase 3 trials that did not gain them approval, regulatory approval, but which may have a second lease of life and are entering phase 3 trials again. With a different design, different population, to try and see if those drugs can be approved. Of course, ruxolitinib has been around for a while, and since 2019, we have fedratinib, which is also an approved option. Fedratinib is a JAK2 inhibitor, whereas Rux, of course, as you know, is a JAK1, JAK2 inhibitor. Now, getting straight into fedratinib, as this, remember, is an approved option at this time. Let's go over the Jakarta study, the study that led to the approval of fedratinib. So this study is actually not a new study. It's important to sort of remember that. It was actually published in 2015, as you see at the bottom. And after that, the drug, as some of you are aware, was actually discontinued for a while by Sanofi, the original manufacturer, because of concerns over Wernicke's encephalopathy. And now it is again back, and we will touch on that story. But this is just a reminder that this trial was sort of contemporary with the COMFORT trials, not quite, but soon after. So this trial was also a placebo-controlled study like COMFORT 1, and 2 doses of fedratinib were looked at, 400 and 500, as you see on the slide. Platelets had to be 50,000 or higher. Now remember, in COMFORT, they had to be 100,000 or higher. So that is one difference. And otherwise, the patient population, again, was the usual intermediate to and high risk by IPSS with splenomegaly. Now, moving on to the primary endpoint, as you are well aware, JAK inhibitor trials in myelofibrosis or MPNs in general often look at the 35% spleen volume reduction as their primary endpoint, and this one was no different. That was the primary endpoint. You see here that both doses of fedratinib were significantly superior to placebo. You had 36.5 at the 400 milligram dose. Now, just to put things in perspective, in Comfort 1, this percentage was about 41 to 42. So very similar, 36.5 here. One important difference is that in Jakarta, they actually reported the results that were confirmed 4 weeks later, a little bit of a departure from the other studies. So you had to do the MRI one more time 4 weeks later to confirm the spleen volume reduction. And that might be the reason that the rate is a little bit lower. But 36.5 at the 400 milligram dose, you see the symptom score nicely going down on the right side of the slide. Now, side effects, Jakarta, in this trial, remember fedratinib is a FLT3 inhibitor. Unlike ruxolitinib or momelotinib, fedratinib is a FLT3 inhibitor, and like you know from midostaurin, which I'm sure you use for AML and sometimes mastocytosis, anytime you inhibit FLT3, you're going to get nausea, vomiting, and diarrhea. That's just an on-target effect. So it's important to prophylax against those things. And then anemia, thrombocytopenia of MS. So the fedratinib label has a black box warning, though, even though this is an extremely rare complication. It is there, it's important. It is important to check thiamine levels and not give fedratinib if they're low. It's important to replete the levels, and you should be concerned in a patient that's alcoholic or is malnourished for thiamine deficiency, which can precipitate this very serious complication. Again, very low rates. One confirmed case, a couple of presumed cases, possible cases, I should say, with some confounders, and then several other cases which were not. And it did not really get the drug approved. Why? Because it was, again, like I said, in non-inferiority head-to-head trial where it was non-inferior to Rux for spleen, but not for symptoms. And the exact numbers are shown on the slide. Well, then Simplify 2 was done. This was in a post-Rux population, so second-line trial after Rux. Now, the problem for momelotinib in this trial was that the best available therapy, which was the comparator arm, ended up being Rux in like 88% of patients. So it almost became another momelotinib versus Rux trial only in post-Rux patients. So here, the spleen was the primary endpoint, and it was not met. However, there was a signal for symptoms, and that's interesting because of what I'll show you on the next slide. In Simplify 2, the symptom improvement with momelotinib was an interesting 26, was an intriguing 26%, whereas the best available therapy, which remember was mostly Rux, was only 6%. So this is the upcoming study. This is the study that hopefully we can all enroll to, and is going to lead to approval for this drug. It's important, of course, to get a JAK inhibitor that improves anemia, definitely an unmet need. This is the trial design, 180 patients. These will be prior Rux, or prior, JAK inhibitor patients. So it's the second line study. Now look at the primary endpoint. It's symptoms. It's not spleen. Symptoms, the primary endpoint, and anemia improvement, spleen improvement, those are your key secondary endpoints. What's the comparator? Danazol. Danazol is a reasonable drug for anemia. I'm not so sure about spleen and symptoms, but that has been chosen as the comparator in this study. It's a 2-to-1 randomization. Now the other drug is pacritinib, the other JAK2 inhibitor. Now this is just JAK2, like fedratinib, no JAK1. So pacritinib, the advantage of it is that it is relatively non-myelosuppressive. Again, why is not entirely clear, but it's non-myelosuppressive, relatively speaking, and this has been in several trials, as you see on the slide. Now, PERSIST-1, I'm not going to elaborate too much. This was a kind of a straightforward JAK inhibitor naive population. It was pacritinib versus best available therapy and pacritinib 1. Which is not surprising. This is JAK inhibitor naive population, and the comparison was not to a JAK inhibitor. Now note, however, that the spleen response rate was only 19%. Now we just talked about Comfort 1, Jakarta, where it was more about 40%. So why might that be? Well, I mean, of course, these are different drugs and different trials, but also important to remember that in PERSIST-1, because this is a non-myelosuppressive drug, there was no lower limit for platelet count. So any platelet count was permissible. We know that's a more difficult population and they may have lower response rates. So that's just something to keep in mind. Now, PERSIST-2 was the more what I would call relevant trial, where patients could have had prior RUX, and about 45% had received prior RUX, and best available therapy could be RUX. So this was I think a more robustly designed trial, the PERSIST-2, where they looked at 2 doses of pacritinib versus best available therapy, which, like I told you, could be RUX, and was in about 45% of patients. So prior RUX allowed, best available therapy could be RUX as well. And these were thrombocytopenic patients, platelets less than 100. So a little bit of a more difficult population, if you will, than the COMFORT trial. Now here, again, the drug could not get approved because it was superior for spleen, but not for symptoms, when you compared the pooled pacritinib data to the best available therapy. And these were co-primary endpoints. So you got one, but missed the other. Now, if you looked at only the 200 milligram BID dosing of pacritinib, now that one was superior to best available therapy, but that was not how the trial was powered, and it did not get approved. To make matters worse for this drug, at that time, there was significant concern mounting about cardiovascular events, bleeding, etc., and a full clinical hold was placed on these trials. After that hold was lifted, the company proceeded under the direction of the FDA with a study called PAC-203, which is at the bottom of the slide. Now, this was purely a dose-finding study. They looked at 3 different doses, trying to figure out the safest dose, and also building in a bunch of risk mitigation measures, like no anticoagulants, QT, being very careful about QT prolonging drugs, etc. And this found that 200 BID was the most effective dose. They did not see those cardiovascular or bleeding events. However, if you look at the bottom right, the response rates were sort of disappointing. 9% spleen response, 7.5% symptom response. But then again, difficult population. Many of them had low platelet counts, and really it was a dose-finding trial. Important to note that the response rate for the spleen was a little bit higher, actually 17, so about double of 9 in the patients with less than 50,000 platelets. So which brings us to the way forward for this drug. So this drug will be exclusively developed in patients with less than 50,000 platelets. Remember, there was a signal in this population from PAC-203, like I just said, and this is a non-myelosuppressive drug. As you are aware, neither ruxolitinib nor fedratinib have data in the less than 50,000 population. So we have an unmet need there. These are the eligibility criteria for this Pacifica trial. This is now open, including at MD Anderson. The momelotinib study that I mentioned will also open soon. Serge Verstosik from our group is leading that. So back to the Pacifica trial, as you see, this is platelets less than 50, and prior RUX is allowed, but not more than 3 months. So not more than 3 months of prior JAK inhibitor, or 6 months if the dose has been no more than 10 a day. So either low dose RUX for 6 months or any dose for 3 months, but they don't want people that are extensively pre-treated. And the physician's choice is the comparator, which is essentially things like steroids, danazol, erythroid stimulating agents, not IMiDs. Those are the physician's choice options. Now, moving on from there, we covered the JAK inhibitors, and I won't go through this slide, but this is just to show you that because of the success of RUX, there are many drugs that are attempting to build build around Rux, build on Rux, and develop a combination that can either help the cytopenias, which are a problem with Rux, as we've discussed this morning, or synergize with it and give us deeper responses. Rux is primarily a drug that is good for spleen and symptoms, so we would like something that is more disease biology focused. So these drugs are of interest because luspatercept, as you know, is FDA approved. It's approved for MDS and beta thalassemia. So what are these? They are activin receptor ligand traps. So these are your fusion proteins. They're fusion proteins that essentially sequester these ligands of the TGF-beta superfamily, not TGF-beta, but that superfamily. They bind those ligands and block their interaction with the activin receptor. By doing so, they improve anemia because these ligands suppress hematopoiesis. Now, this is a study design in myelofibrosis. Remember, it's not approved today in MF, it's approved in MDS. But this is the study design. This is from ASH 2019. It looks a little complicated, but if you focus on the left upper part of the slide, there are really 4 cohorts. They can be either people who are not needing any transfusions, or they can be formally transfusion dependent. And then those are broken down by, are they on Rux or are they not on Rux? So that's your study design essentially. Here are the results. Now the dark blue is the primary endpoint. The lighter blue is your secondary endpoint. So the primary endpoint for transfusion dependent patients is obviously transfusion independent. And for patients who are not transfusion dependent, for them, it's a sustained increase in hemoglobin by 1.5. You have to sustain that for 12 weeks. You've got to sustain anything for 12 weeks, essentially by the IWG criteria. So as you see, if you look at the dark blue bars, generally you get the feeling that the patients on Rux are doing better. Now, this initially seemed counterintuitive because, not only do they have MF, they also are on Rux, which is going to suppress their hemoglobin. So why are they doing better? That's not entirely clear, but that seems to be the signal, and the company is taking this forward in that population. Patients receiving Rux. In fact, this particular study has been expanded for the transfusion-dependent cohort on Rux. And again, quickly, as to what the light blue bars are, those are your secondary endpoints, which is a 50% reduction in transfusions or a mean increase of 1.5 in hemoglobin. Not an increase at every time point, but just a mean increase. All right, so moving on from there, there's lots of drugs, as Dr. Teferi mentioned this morning, representing various classes that are being investigated. I'm just going to show you 3 of them. There's many that are being explored. So this is the bromodomain inhibitor from Constellation Pharmaceuticals. Now, there is some really nice synergy between Rux or JAK inhibition and bromodomain inhibition. It's dependent on NF-kappa B primarily, because bromodomain inhibitors interfere with transcription. So ultimately, you shut down the cytokines, etc. So this is the study design. It's a big study. It's a big study, kind of 3. Think of it as almost 3 studies in one. So you've got the arm 1, which is receiving the bromodomain inhibitor as monotherapy. And then you've got arm 2, which is getting it as an add-on to patients who are on a stable dose of Rux, but are having sort of a suboptimal or insufficient response. And then arm 3, which was added later, is frontline. Frontline JAK inhibition with BET inhibition. So that's kind of the latest arm. So this is the study design. It's about a 100 patient study. It's a fairly large study compared to some of the others that we have now. Now, and it's a pretty logical, intuitive endpoint. If they are transfusion dependent, the endpoint is transfusion independent. If they are not transfusion dependent, the endpoint is 35% or higher spleen volume reduction. So with that background, this is showing you arm 1 and arm 2, which, remember again, arm 1 is monotherapy, arm 2 is with Rux. None of this is frontline. They're all patients who've either had Rux before or they are on Rux but not having a very good response. So the color coding is there. This is your spleen response slide. You see there's more orange than anything else. And this is the group, the cohort 2A, which are the folks on Rux and transfusion dependent who appear to do the best. And same thing now for the symptoms. Here again, it's that cohort, the orange, the where the drug is added, BET inhibitor is added to Rux in transfusion-dependent patients. But here also cohort 1B in the dark red, which is the monotherapy in non-transfusion dependent, seem to do quite well as well. Now, one last thing before we get into the front line here. With this drug, remember, anemia is a major unmet need in MS. It's luspatercept, might be an answer, but probably will not be the answer. And this is a difficult problem. We need multiple drugs. So CPI-610, the bromodomain inhibitor monotherapy, also actually shows a signal for anemia. This is the cohort 1 patient. 1B means not transfusion dependent monotherapy patients, where you see an increase in the hemoglobin. Now, here is where the excitement currently is, because this drug is going into a frontline pivotal trial of CPI-610 with Rux versus Rux alone. Now, that is not what I'm showing you on the slide, just to be clear. That is being designed, developed, that's coming. But this is the frontline cohort of the study I'm showing you, the MANIFEST study, where you see this 63% spleen response rate at 24 weeks, which is better than what we saw with Rux alone. Again, different trials, but there could be some synergy here that we are starting to see. And here is symptoms. Again, about a 59% response rate at 24 weeks. Again, higher than what you expect from Rux alone in the pivotal COMFORT trials, where it was more like 45%. So 42 spleen, 45 symptoms, this seems to be higher. Caveat is that the Rux dose was 1 dose level lower because of the combination of the 2 drugs. The Rux was dosed at 1 dose level lower than you would think appropriate for the platelet count. Now, like I said, I'm going to discuss just 3 drugs in all among these newer ones. Navitoclax is the other one. You're all familiar with venetoclax. Now, navitoclax is actually an older cousin of venetoclax, which blocks both BCL2 and BCL-XL. BCL-XL believed to be more important in MPNs because it's a direct target of JAK2. So this is why this rather than venetoclax is being developed. Now, this is one of these add-on trials where you keep your Rux, you keep the stable dose, you add the navitoclax or add whatever drug you're adding to see if you can get some synergy and improve upon the suboptimal response. So here they had to have had Rux for at least 12 weeks, stable dose, and then you could add navitoclax if you still had an enlarged spleen. Now, these are the results for the spleen. This has attracted some attention. Now, just to put things in perspective, this is only 34 patients, just 34 patients, but you have this 30% rate of spleen response. And remember, whenever I say spleen response, I mean 35% spleen volume reduction. That's fairly standard. So 30%, which is actually a little bit better than anything else in the add-on setting. Symptoms, similar story, 35% here. And symptom response is your usual 50% decline in the total symptom score. 35% is what we see with this drug at 24 weeks. So, and this drug was also, by the way, navitoclax is also going into a pivotal trial with Rux versus Rux alone. And that's one of the thoughts in both frontline and in the suboptimal setting. So there's many others, which we clearly cannot cover. All of these are being studied as monotherapy. These are not being studied yet with Rux, or maybe 1 or 2 has been, but for the most part, these drugs are being studied alone. Of course, some are not, like I already covered CPI-610 and then PRM-151. The antifibrotic agent has also been studied with Rux. And then there's interest in PD-1, just like in every other field of oncology as well. But this is a kind of a listing of the various single agents that are being studied. Now, I'll show you just one of them. This is imetelstat. Imetelstat was, Dr. Teferi 5 years ago. We all remember the New England Journal paper with the pilot study that he did, which showed the early activity of this drug. This drug was then taken into an industry-sponsored randomized trial. There are 2 doses, as you see here. But what is really important is to look really quick at the definition of Rux failure. So it's very important as we compare across trials to know who the patients are. So the RUX failure here is defined a little bit differently from what we talked about for fedratinib, for example. But it's a reasonable definition. You know, they have to have pain, spleen volume increase, or worsening splenomegaly, as is listed at the bottom of the slide. Now, there's a lot of numbers here, and we are getting close to the end here, but just to draw your attention to the top three. Survival, I'll talk a little bit more about that on my last slide, which is coming up, but survival was striking here. So 28 months on the higher dose arm, and generally in the post-RUX setting, multiple groups, ours, Moffitt, and the Italians, have reported only 13 to 14 months. So the survival was sort of striking, but remember, this is not a comparative study. This is imetelstat, just 2 doses. Now, the lower dose was closed because of lack of efficacy. So we won't really get into that, but the survival was better than what you'd expect in the higher dose. Spleen and symptoms, not that impressive, but they're listed on the slide for you. So last slide here, just to show you again that it was the survival that really caught people's attention with the higher dose of this drug. And we will see where this goes next. There are clearly plans to develop it further. The blue here is the higher dose, the red is the lower dose, but that's holding up so far. This is from EHA 2020, so just 2 months ago, you have about this 28-month median survival. And that is everything. Thank you so much for your attention, and I'm happy to take any questions.
So I think we have one question that came in. They're asking, what are your thoughts on incorporating PEG interferon after ruxolitinib failure? How would you choose which to pick first, JAK inhibitor or interferon?
Yes, thanks for that question. So interferon in MF, has not been as impressive or nearly as impressive as it has been in PV and ET. Remember, MF is a much more molecularly complex disease and frankly a more advanced form of MPN than PV or ET. So I don't expect interferon to work in RUX failure, in true RUX failure patients. I would not use it in that setting. The data with interferon in MF is really in very early patients. Dick Silver has published on that. And now there is a trial that Dr. Kilajian is leading in France. There's actually 2 trials, there's one other as well, where it's being combined with RUX. So I don't think interferon is for later disease. If I use it, I would use it in really early disease.
Thank you. I think that's all for the questions. Thank you, Dr. Bose. This concludes the hematology part of the symposium. I would like to invite my colleague, Dr. Berniker, to kindly come up and introduce our next keynote speaker. Thank you.
Thank you, Jasleen. Excuse me. It's really my honor and privilege to introduce our lunch keynote address. Jill Feldman is a tireless advocate for lung cancer patients, caregivers, and researchers. It's exciting for us to belatedly see the utilization of very passionate and activated advocates who are really helping us in terms of, not just in terms of providers, but in terms of researchers to hear the patient's voice. Jill is a lung cancer survivor herself. Her family has been touched with lung cancer. She is one of the founders of EGFR Resistors, which is a advocacy group that helps with education, philanthropy, and getting clinical trials rolling for EGFR mutated lung cancer. So without further ado, Jill.
Thank you for inviting me to speak. My only disclosure is I have lung cancer. But my story started long before I was diagnosed with lung cancer. When I was 13, I lost my dad and 2 grandparents to lung cancer. And then my mom and my Aunt Dee Dee died of lung cancer when I was in my 20s. In the 14 years between my dad being diagnosed with lung cancer and my mom being diagnosed, there wasn't a single advancement in lung cancer treatment, despite it being the #1 cancer killer. My family and I felt helpless and hopeless, and while there wasn't any research on hereditary lung cancer, I knew our familial lung cancer couldn't be just a coincidence. There also weren't any lung cancer walks, support groups, or research organizations. In fact, there wasn't a lung cancer community at all. Stigma was a huge barrier, but also people didn't live long enough to become advocates. It's hard to understand what it was like if you weren't in the lung cancer space back then, but I want you to think about the work you do today. What if you weren't able to pursue your career path in cancer research because there wasn't any funding available? Think about how different your research and practice would be without any cancer organizations or resources. And imagine how you would feel if you only had the same 3 treatment options to offer every single one of your patients, knowing the benefits were marginal and that the side effects could be worse than the cancer itself. That was the lung cancer world not that long ago. Now, imagine if you were the patient. What would you have done if you were diagnosed with stage 4 lung cancer without any groups or resources to turn to for help? In 2001, 7 newly diagnosed lung cancer patients were introduced in Chicago, and together they decided to do something about it. But because of the nature of the disease, 4 of those patients died soon after they met. One of them was Gail Levy. Picture this, a 40-year-old mom of 3 in the hospital, actively dying and on a respirator, unable to talk, but so desperate and determined to raise awareness and funds for lung cancer research that she used a whiteboard to communicate and plan until her last breath. Most organizations are founded in memory of a loved one, but that is how the Longevity Foundation was born. Thankfully, Melissa Zagon, a 32-year-old mom and lawyer, became the heart and soul of longevity, and she, along with Kay Barmore and Patty Helfand, kept their vision alive. Sadly, Missy and Kay died in 2007, but their tireless efforts left a lasting legacy. Longevity was founded in my community, and I got involved shortly after it got off the ground. After so many losses to lung cancer, I was so grateful to find a community and a way for me to confront a disease that had devastated my family. I did what I could to get educated and be an advocate so I didn't have to see someone else I loved suffer through the cruelty of lung cancer. While doing so, in 2009, I was diagnosed with lung cancer at 39 years old. My kids were 6, 8, 10, and 12, and their only association with the disease was death. They were scared, and my greatest fear was becoming a reality. I was following in my family's footsteps, and there still wasn't any promising research that convinced me that the path would change. Ironically, I was also president of Longevity at the time, and I still felt helpless. Research was moving in the right direction, but not fast enough. It felt like a vicious circle because in order to raise more awareness and funding for research, we needed more survivors. But in order to increase survival, we needed more funding. It was so frustrating. Thankfully, it's a whole different lung cancer world now. Developments in lung cancer research over the past 10 years have galvanized the community. There has been remarkable growth in the number and variety of therapeutic options. An example, in the past 11 years, I've had 2 surgeries. I was on targeted therapy as adjuvant therapy after the first surgery, and I've had SBRT to treat some unruly cancers. And while I was upset when I had progression a year and a half ago, it was the first time I was not overcome with fear. And although a hard pill to swallow, no pun intended, the targeted therapy that I am still on was a durable option, and I was confident it would buy me time to allow research to catch up. I never would have said that or believed that 5 to 7 years ago. Research matters, and so does the role that patients play as research advocates. It didn't happen overnight or by chance, but social media started to boom and our community was growing by leaps and bounds. Patients were living longer and better lives because of advancements in research. Subsequently, we have and continue to build an army of lung cancer advocates. And with the discovery of oncogene-driven lung cancers, patients and caregivers started building online communities specific to the type of lung cancer they had. The groups continue to grow in number and in size. When my parents were diagnosed with lung cancer, the only distinctions doctors could make was whether a person had small cell lung cancer or non-small cell lung cancer. And as I mentioned earlier, there were only 3 treatment options for all lung cancer. This chart shows the actionable mutations in non-small cell lung cancer adenocarcinoma today. And it actually seems to continue to grow frequently. With these targetable mutations and therapies, targeted therapies, treating lung cancer is more complex and complicated than ever before. As you can see, some of the oncogenes are very rare, which is why patient groups formed and why they're so important. There aren't patient groups for every oncogene in this pie chart, but the groups that have the most members are the ones that are more common, like EGFR and ALK, or have effective treatments like ROS1. So what do our groups offer patients and their families? Hope, support, education, empowerment, and connection. Cancer fosters an instant intimacy. There is nothing like connecting with someone else in the trenches. Someone who understands how you feel, can provide information, and who you can talk to about things you don't feel comfortable talking to your loved ones about. Someone who gets it in a way that no one else can who hasn't lived it. So here is the list of the oncogene patient groups as of now. And again, you have to understand when you have a rare type of cancer, finding a community that provides support and resources is life-changing. Conversely, when a community can educate members, break down barriers to diagnosis and treatment, and accelerate research, it can be life-saving. Targeted therapies are generally the best treatment option for oncogene-driven cancers, but they aren't a cure. And inevitably, the cancer develops resistance. And while I talked about all the wonderful progress in research and treatments, the reality is most of us are still depending on that next promising treatment. And I just want to mention, I know there are a lot of you out there that treat different types of cancer, and the ROS1 group and the NTRK group are both of those groups are tumor agnostic. The ROS wonders and the ALK positive were actually the first oncogene groups to be formed in 2015. But then in mid-2017, I, along with 5 other EGFR patients and 1 caregiver, founded the EGFR Resistors. It is incredible that our community has grown to over 2,000 members from 70 countries in just 3 years. We have a closed Facebook group for our members, and we communicate with the broader community through our website, Twitter, Instagram, and monthly newsletter. We felt when we first created our group that it was important to define our purpose in order to make sure that we spent our collective time and efforts on projects that fit the purpose and not be distracted. As a result, we created our goals, vision, and mission. Our goal is to improve outcomes for those who are diagnosed with EGFR positive lung cancer by accelerating research. I'll go into research in a little bit. But our vision is to change EGFR lung cancer into a manageable chronic disease. Ultimately, a cure would be nice, of course. Our mission is to continue to raise awareness of EGFR positive lung cancer and to address critical gaps in clinic and in research. We aim to improve outcomes for our disease using 4 methods. One is supporting patients and caregivers, and that's through our closed Facebook group. This group is only open to patients and caregivers because we want a safe place where people can freely share concerns with confidentiality. Second is increasing awareness and education for our members, and we do that in a number of ways, including providing information and firsthand experiences with treatments and trials, giving tips for communicating with their healthcare team, sharing information about symptom and side effect management, and helping with asking the right questions. And all of that assists in building confidence for patients so they can be an integral part of the team and part of their healthcare and advocate for themselves. And a lot of them end up advocating for the disease as well. The third is improving access to effective diagnosis and treatment by sharing information about critical issues such as getting a second opinion, which is especially important if a person is treated in a smaller setting and their doctor may have never seen a patient with their kind of cancer. Other critical issues include having molecular testing, having repeat biopsies upon progression, suggesting resources to assist with cost, insurance coverage issues, and sharing information about clinical trials. And actually, in this fast-paced world of new developments, patients and caregivers are often the ones who bring the information about testing and treatments to their doctors. And last but not least is accelerating and funding research. Even though there have been advancements in treatments for EGFR positive lung cancer, as I mentioned before, resistance is inevitable and our survival rate remains low. But many of us are alive today because of research, and we understand the importance of continued research. So I just want to talk about our research priorities for a minute. As I mentioned before, our mission is to understand the unmet needs of our community. So in order to do this, we have focused on developing relationships and communicating with all stakeholders in the lung cancer community to drive important research questions. We have then strategically identified projects to address these questions and answer genuine unmet patient needs. To accomplish all this work, we have created research partnerships with advocacy organizations and industry to assist with education and funding our projects. So far, we have collaborations with CEC Oncology, GoTo Foundation, AstraZeneca, and Longevity Foundation, and we are always open to future partnerships. I want to talk about some of the exciting work that we have done. Without CEC Oncology, the EGFR resistors truly would not be what it is today. CEC Oncology is a company that focuses on continuing education for doctors, nurses, and other medical practitioners. Joni Fowler, founder and CEO, reached out to the EGFR resistors soon after our launch. The company had already done some work in the EGFR lung cancer space, so it was a great fit for us to work together. We have incorporated our patient perspective into CEC's EGFR lung cancer symposiums, including a recent symposium during virtual ASCO on the myths and legends in EGFR positive lung cancer. One of the first projects in 2018, CEC helped us secure a grant to hold our inaugural think tank for EGFR lung cancer, where we gather top thought leaders to discuss the gaps in practice and research for EGFR lung cancer and ways to target these gaps. And it really, really helped us zero in on what our group priorities are. One of the ideas that came out of the think tank was a research summit, and CEC Oncology again partnered with us and helped us secure grant funding. This past November, we held our inaugural EGFR Resistors Research Summit in Chicago, which was better than we could have ever imagined. 16 fellows and junior faculty from across the country presented their work in front of the EGFR resistors and 7 mentor judges. The judges asked questions, provided feedback, and ranked the presentations. And ultimately, the top 5 presenters won monetary awards for their home institutions. The young investigators also received training in presentation skills and in grant writing, and they received mentorship from the judges. We created this summit, this incredible experience, to encourage young investigators to continue their work in EGFR lung cancer and foster collaborative efforts early in their career. And that's exactly what it did. We are in the process of planning our second research summit for this coming November, and while it will unfortunately be virtual, I have no doubt that it will be just as successful. We also recently collaborated with Longevity Foundation on a research project called Project Priority. Priority stands for Patient Reported Initiative on Resistance, Incidence, and Treatment Study. We wanted to understand the needs of the EGFR lung cancer community, identify areas for improvement in diagnosis and treatment, and give voice to patient concerns regarding risk factors, treatment and symptoms, and side effect management. TKIs have been a game changer in treatment for EGFR positive lung cancer, but while they have proven to prolong patients' lives, the full impact of an EGFR positive lung cancer diagnosis has not been well documented. So we created a comprehensive IRB approved survey with the input from patients and caregivers, but also clinicians, researchers, and regulators, specifically because we want them to use this information. The survey gathered data from 350 people from around the world and covered 3 different domains: demographics and risk factors, diagnosis and treatment, and the psychosocial impact of an EGFR lung cancer diagnosis. The baseline data was collected from 2 different cohorts of the 350 participants from April 2019 to May 2019. We were so fortunate to present some of the data at the International Association for the Study of Lung Cancer's World Conference in Barcelona this past September, and at their North America Conference in Chicago this past October. The longitudinal study opened just this May 2020, and we just closed it up last week. The analysis for that is ongoing, and we plan to share at future conferences, but we did ask some specific COVID-19 questions that I will share with you in a little bit. So we have a lot of rich data that I'm happy to share, but I just want to give you a snapshot of our findings and our baseline findings. So we found that low rates of biomarker testing, and that wasn't really surprising, but the high rates of hospitalization was, especially considering patients were young and relatively healthy. We found that patients in the US are still not receiving the FDA-approved standard of care as their first-line treatment. But a significant and very disturbing finding was the high rate of patients diagnosed with clinical depression, which probably underestimates the number of patients who actually suffer from depression. So I wanted to share this slide with you because it really highlights why our study and the data we collected matters. This slide compares side effect profiles between the FLORA study, which the 2 left columns in green, and Project Priority, which are the 2 columns in blue. And if you look at the difference between the clinical trial and the real world trial, it's not really that surprising because clinical trials, they take people who match certain inclusion criteria, which exclude real-world patients who have brain mets or prior cancers and poor performance status. And I think here, what's important to highlight is you can never minimize side effects. Tolerable is relative to each patient. In addition, many patients don't fully disclose side effects to their healthcare team out of concerns of being taken off a trial or treatment or a dose reduction, or in many times they're just determined and stubborn. And I am one of those patients. As I mentioned, the analysis for the longitudinal study is ongoing, but this slide is on the specific COVID-19 questions. As you can see, the majority of people have real concern about the pandemic affecting their cancer care, with the biggest concern being delay in their treatment and delay in lung cancer research. And I know there have been best practices to safe care being shared all over the world now, but the concerns are valid, as we have all seen and experienced during the first several months of the pandemic. The most common feedback that I received from physicians after presenting Project Priority data was that it was eye-opening. Again, our study stresses the importance of real-world data. The small percent of patients who participate in clinical trials isn't a complete representation of our community. So in order to fully understand the patient experience, real-world data must complement existing clinical and research data. And as patients, we know data is valuable, and that is why we have made our data available open source. But this data would not exist without our motivated and powerful EGFR resistors community. We are able to drive research, involve patients, and gather data that no one scientist, physician, or institution ever could. Data that, if used correctly, could provide critical insights that lead to better care. That is the power of patients being involved in research advocacy. The EGFR resistors are really excited to partner with Longevity again to support another research project. This one is a 2-year, $200,000 award to fund translational research that will have a direct impact on the outcomes of people with EGFR-positive lung cancer. This project is patient-driven and patient-funded research. In other words, it would not exist if it weren't for our EGFR community's efforts in raising funds, the passion of our research advocates, and the support from Longevity. As I mentioned earlier, there wasn't even a lung cancer community 19 years ago. So there aren't words to express how overcome I am with emotion seeing and experiencing the growth in the community, the advancements in research, and the value and power of patients in the entire process, something I never imagined would happen in my lifetime. So I just gave you some examples of the incredibly exciting and important work that has come out of collaborating with patients in research. Now I want to emphasize the benefits for both patients and researchers of working together. We have to work together to have the biggest impact, especially in the era of precision medicine when treating cancer and people with cancer is so personalized. The point of cancer research is to improve patient care and outcomes. But in order for that to happen, you have to first know what's important and meaningful to the patients. Our perspective and urgency can and should drive the critical research questions that truly matter to the people who have cancer. Patients are more than the face that humanizes the disease. We have a perspective and fulfill a role that most scientists and researchers can't, the lived experience. I have seen how patient input can change the trajectory of research to ensure the focus is on the patient. So some key takeaways. The biggest is research is everything to us, patients and our families. It is our lifeline, it is our future, and it's the future of our children. We are here to help in any way we can. We need you to help us help you to help us, because the value of our groups is we offer patients and their families support, education, and awareness. We offer scientists and physicians a link with patients for clinical trials. We are the liaisons with scientists and clinicians to disseminate information about cancer back into our communities. And we help accelerate research from fundraising to supporting clinical trial accrual to creating more models of rare cancers for researchers and everything in between. I cannot say it enough. Patient input makes research and its results more relevant to the patients. Partner with your patients in research. I would be amiss not if I didn't mention anything about COVID-19 though. This pandemic has hit cancer research really hard, as you all know. In fact, I keep saying that the death toll of COVID-19 is much higher if we consider all the people who did not have the disease but died because trials stopped accruing patients, follow-up care and screening slowed down, and many people were afraid to go to clinic or the hospital if they were experiencing severe side effects or symptoms. Cancer doesn't stop, and neither should we. Oncology is a team sport. I have witnessed the impossible become possible in lung cancer over the past decade, and all that can be accomplished when we work together across disciplines and institutions and recognize the value and utilize the patient perspective. I will never forget the first longevity meeting I attended in 2001. Watching the extraordinary way in which Melissa Zagon responded to her illness changed me at a time I needed it most. She helped me find my voice and taught me how to transform suffering into passion and purpose. I would not be the advocate I am today without her friendship and guidance. But over the years, I've been honored and humbled to work with hundreds of patients and advocates, doctors, nurses, scientists, and other advocacy and research organizations from all over the world. I've witnessed and celebrated the creation of a lung cancer community and what we can accomplish when we work together. We must work together. I want to thank everyone for their passion and dedication to bettering the lives of people with cancer, and to the EGFR resistors community for all of their efforts. Individually, we can make a difference, but together we can do more, be more, impact more. Thank you.
Thank you, Jill. That was wonderful. And very powerful. I'm gonna, is she there? Can you hear me?
On the iPad, there's a little button with a question on it.
Okay.
Oh, she's on there.
Okay, I believe you. Good. So, Jill, how can advocates and family members of patients help increase funding for lung cancer?
Hi, everyone. Thank you again for having me to speak. To increase advocates and family members, there's a lot that they can do to increase funding for any type of cancer. It really starts with awareness, and it starts with making sure that you are comfortable talking about your story, using your story. And with the way there's other, you could do fundraising activities and you can do events. My kids used to sell rocks. All of those things matter. Every penny counts. But the way we have been raising funds for some of the research projects that we've done more recently is, you know, doing campaigns. So we have this group of the EGFR resistors, over 2,000, you know, members, and we do campaigns showing people living with the disease. And we have it with the online tools now, you can share these campaigns and people can donate directly.
And one more question. And and there might be a lot of things, but in speaking from your own experience and from the experience of other patients, what do you think the most important area where the system is not serving patients' interests? Or if you can change one thing with the current healthcare system, what would you change?
You're correct in saying there are a lot of answers. But, you know, for me, the disparities, I just don't, what good is it to collect all this data, to develop all these new treatments, if the people who are sick can't get the treatment they need? So to me, especially again within our group, we see the disparities across the United States, but globally. And I think that with a lot of new treatments coming out, especially people who are a part of the trial, sometimes patients aren't necessarily, you know, we don't account for underserved communities within our trials as well. So, and I mean, I could go on and on and on in every different sex. There are so many, but I think we all have to advocate for the underserved communities, and we all, I mean, patients and physicians need to use our voices, because the reality is we can't assume what they need. And the only way to understand what's important to them and what they need is to infuse people from those communities into the healthcare system across the whole continuum. So their interest, their true interest, is taken into account, and we can gain the trust of the community.
Great. Thank you very much. Appreciate your time for visiting with us. Thank you.
Thank you. Thank you for having me. I really appreciate you giving me the opportunity.
Great. Thanks. A bookkeeping note, we're going to take a brief lunch break. So we'll resume at 12:45, shake a leg, get a coffee. Since you can't get your box lunch and walk around the exhibitor tables outside, please feel free to go to our exhibitors box on the website, and we'll see you at 12:45. Thank you. go. Welcome back to the afternoon session. We're going to get started with the afternoon keynote speaker. It's my pleasure and privilege to introduce Dr. Charu Agrawal, who is the Leslie M. Heisler Associate Professor for Lung Cancer Excellence at the Perelman School of Medicine at the University of Pennsylvania. Dr. Agrawal did her training at the University of Buffalo and then did her fellowship at Fox Chase. She is a national expert on the utilization of ctDNA and the management of patients with advanced lung cancer. And she's going to discuss liquid biopsies and how this can hopefully better allow us to take care of these patients. Dr. Agrawal, welcome.
Good afternoon, everyone. Thank you, Dr. Bornecker, and the organizers for giving me an opportunity to talk today. It's my pleasure to discuss liquid biopsies and the management of advanced lung cancer, and how I approach molecular testing in non-small cell lung cancer within my practice. So without further ado, I would like to share with you the learning objectives for my talk here, which are to review basic recommendations for molecular testing in non-small cell lung cancer, to identify the current types of testing available. We'll review some of the data supporting the use of liquid biopsy for molecular testing. And then briefly, I will talk to you about some other potential applications for liquid biopsy in molecular testing, including the use of technologies that can detect minimal residual disease, as well as looking at plasma-derived tumor mutational burden. So where are we today? We've made significant progress in the way that we manage patients with lung cancer, and our outcomes have continued to improve. From the latest cancer mortality statistics, we have seen that mortality is low. And actually in 2016 to 2017, we witnessed the largest drop that had been seen in cancer-related mortality, about 2.2%, which was mostly driven by lung cancer in addition to other cancers such as melanoma. And while advances such as screening have helped reduce the incidence of cancer and other solid tumors, I feel that, and this has been corroborated by data, that targeted therapy as well as immunotherapy have really led to a decline in cancer-related mortality, especially over the last 5 to 10 years. Based on an improved understanding of the biology of non-small cell lung cancer, we are now able to really distinguish subtypes of non-small cell lung cancer into very specific subsets. Here you will see a pie chart, which has now become our standard way to view, or the lens that we view non-small cell lung cancer with, especially non-squamous non-small cell lung cancer. So we know that non-small cell lung cancer is complex, but it's important to know which mutations are present, because here you will see we have various drugs now available. And this is a partial list of agents that are either available for us to use in clinical trials or are FDA approved for indications in the non-small cell lung cancer space. We have also moved beyond our usual culprits. KRAS G12C, which accounts for about 13% of all mutations in the non-small cell lung cancer space, now is potentially actionable. We have seen data with an oral agent that targets KRAS G12C. This is an Amgen drug that has shown activity in patients with this mutation with an oral dosing, with significant responses seen even in heavily pre-treated patients. And as you can see on the waterfall plot on the top right, that a majority of the patients on this trial had either stable disease or partial response. And these are very early signals, and we're all eagerly awaiting larger data from this analysis. As you can see from the swimmers plot on the bottom right, you will see that most of these responses were still ongoing at the time of this presentation. Again, underscoring the importance of looking for these mutations as they may be immediately actionable. Most recently, we have heard of approvals for other rare or uncommon mutations. RET fusions are slightly uncommon, but account for about 1 to 2% of all non-small cell lung cancers with non-squamous histology. And now we have 2 very active drugs. Blue 667 is the drug on the left, also called pralasetinib, which has shown substantial anti-tumor activity in RET fusion advanced non-small cell lung cancer with overall response rates of upwards of 58%, and even present in patients that have received prior platinum-based therapy. Again, I think very important to identify these patients. On the right, you will see a waterfall plot of responses from the primary analysis of a trial using the LOXO drug, which is now called selpercatinib and has been FDA approved for the treatment of these patients. Here you'll see significant overall response rate of about 68%. And what's important is that there is significant CNS penetration with these agents with intracranial response rates of about 91%, which are just plain spectacular. MET exon 14 is another actionable mutation that now has a drug that's FDA approved. So MET exon 14 skipping mutation is a target that occurs in about 3% of all non-small cell lung cancers. Usually these patients have a sarcomatoid histology that may be a clue for us to look for these mutations. And here are some data from a trial called Geometry that had various cohorts looking at either MET amplification or MET exon 14 mutation using a drug called capmatinib. And what they found was that capmatinib had significant responses with an overall response rate of about 48% in those patients that had the MET exon 14 mutation, not necessarily in those that had the amplification alone. Progression-free survival is about 8 months. Again, this drug is now available, and if we find a MET exon 14 mutation, we should be using this in a more personalized, targeted fashion. Tepotinib is another drug, again, looking at MET exon 14 subset. And here you can see very similar trend here, all waterfall plots that I've shared with you of all these targeted agents seem to follow this, really nice trajectory of majority of the responses falling towards the bottom half of this waterfall plot with significant overall response rate, again in the 40 to 50% range for this mutation. There's another reason why it's important to get molecular data in patients that may have a molecular alteration such as EGFR or ALK is that, our most commonly used regimens that incorporate chemoimmunotherapy or just immunotherapy may just not be effective in these patients that harbor a molecular mutation. Most of the frontline trials that have led to FDA approvals of chemoimmunotherapy or immunotherapy, such as Keynote 189 or Keynote 24, actually excluded patients that had activating mutations. There have been trials such as this one, that evaluated the use of pembrolizumab single agent in patients that had EGFR mutation. And I will say that this trial had to be stopped early because patients with EGFR mutation on this trial, despite having a PD-L1 expression of greater than 50%, did not have a response. In fact, the only patient that had a response was later found to not have an activating EGFR mutation. We also have data from second-line trials of nivolumab, pembrolizumab, and atezolizumab that did include patients with EGFR mutations. And compared to those patients with wild type, there was a consistent absence of an overall survival advantage for these patients that were enrolled on these second-line trials. Again, really saying to us that maybe immunotherapy is not the best agent for these patients that have oncogene-addicted tumors. There is another reason that we need to get molecular data, and that is that sequential use of targeted therapy following immunotherapy may actually lead to worse outcomes, including maybe a slightly higher incidence of adverse events. On the left is a paper that was published in Annals of Oncology last year, which really described the severe immune-related adverse events that were common after osimertinib was introduced following immune blockade. On this patient, about 15% of the patients had IRAEs, and the median duration of onset was pretty quick, actually, about 20 days. And we have certainly seen this in our practice as well, where osimertinib is introduced, or let's say another TKI is introduced after having been on an immunotherapy agent. These patients often present with either elevated LFTs or pneumonitis. Increased hepatotoxicity has also been seen in patients that were treated with crizotinib following immunotherapy. And here is a paper that describes that with elevated LFTs seen in majority of these patients. So this is something that we must keep in mind. And I think this also just goes to say that we should be choosing the right regimen upfront as quickly as we can and as easily as we can, so that we can avoid harming our patients with these inadvertent side effects. So I hope that I've convinced you that there are three reasons really to get molecular data. One is to really emphasize that we are able to personalize medicine. We have now 8 actionable targets with FDA-approved agents in the first-line setting, where we have the ability to offer patients a RET-directed therapy or a MET exon 14-directed therapy, in addition to the EGFRs, ALKs, et cetera, that we have always known about. I hope I've convinced you that we can improve outcomes, because chemoimmunotherapy or immunotherapy may not be the best approach, as we just don't have data. Some of these subsets were not even included in the landmark trials. And then also, I think the last but not the least important point is that we should really aim to lower toxicity, because sometimes these patients, when they get a TKI after having had IO, may have increased risk of adverse events. So I'm often asked which markers should we get, and I like to divide this up into my must-have, good-to-have, and nice-to-have boxes. And over the last year even, I've had to change these slides around because, as I just shared with you, we've had some recent approvals come through. So in my must-have category, I think everyone should have PD-L1 IHC. Folks should definitely have EGFR, ALK, ROS1, but also I think BRAF, MET, exon 14, as I discussed with you, RET, and now we have also NTRK fusion, which may be present in patients with non-small cell lung cancer, is a target that we should be looking at. I included KRAS as one of the good-to-have markers because, as I shared with you, there is clinical trial data of preliminary efficacy with KRAS G12C targeted agent, and we anticipate to see larger data soon. And also because these molecular alterations often do not coexist. So if I have a patient with KRAS mutation, I can probably safely move on and say that they are less likely to have an EGFR mutation. Or B2 is another target that's actually very interesting. And there are drugs that are specifically being looked at. HER2 is another marker within the good-to-have space, especially with emerging data on antibody drug conjugates. On the right, you will see the red box, which is my nice-to-have information. And these are sort of our emerging biomarkers like STIK11 and KEAP and PTEN, which may actually not guide therapy right away, but actually may tell me about the lack of activity of immune agents. I put TMB in there because, TMB has sort of been this on and off biomarker that all thoracic oncologists have had either an on or an off relationship with at some point in their time over the last 4 or 5 years. TMB is no longer really considered to make decisions, at least in the non-small cell lung cancer space, but I think it may be relevant, especially as we discuss plasma TMB approaches. So once we've established which biomarkers we should get, I would also like to just draw where we are getting some of this information from and how this may change. So some of this information is really coming from common guidelines derived from CAP, ISLAC, as well as the American Molecular Pathology Association. And ASCO actually endorsed these guidelines in a landmark paper in JCO that was, or I should say a consensus paper that was published in 2018, where they recommended that we should get BRAF in addition to EGFR, ALK, ROS. And again, I think these will be updated as new agents have been introduced. I would like to say that multiplex gene sequencing panels are definitely preferred, even in this paper from 2 years ago, and they endorsed the use of ctDNA testing when tissue was unavailable. Similarly, ESMO had Pan-Asian adapted guideline, which really echoed some of the same guiding principles that I just highlighted here in bullets. So now that we know which are our preferred tests, where the guidelines are coming from, I'm often asked, which test do I use? I mean, I can use FISH, I can use IHC, I can use whole genome sequencing. And really, I like to think about it as, what is the test that can give me the maximum amount of information in the most efficient turnaround time? And this is a nice graphic which sort of helps us figure or look at this a little more carefully. So, on the bottom here is the limit of detection. And if my limit of detection is really, really low, really, really high, maybe I'm not able to cover as many genes as I can. So for example, with our beaming and droplet digital PCR techniques, I'm able to really go down, especially when it comes to, let's say, circulating tumor DNA, really go down to a level of detection that's 0.01%, but I may be limited to only 1 or 2 genes. However, if I'm up top at the top here and I'm using a technique such as whole genome sequencing or whole exome sequencing, my nucleotide coverage is extremely high, often upwards of 500 to 600 genes, and I'm able to maybe not get that much of depth of coverage, but my breadth is high. I often find that, you'll see my graphics on the right here, that these whole genome sequencing assays are often associated with very high cost. And these droplet digital PCRs give us the advantage of really being able to give a quick turnaround, often in 24 to 48 hours. But I find that the sweet spot is really the next generation sequencing, which doesn't give me 500 gene coverage, which I probably don't need for clinical practice, but also gives me enough coverage so that I'm able to at least cover the basic required biomarkers in a reasonable turnaround time. So that's the test that I think should be used, as well as currently used in clinical practice. But of course, there are other tests out there which I wanted to discuss with you. For example, for ALK, we are able to use either IHC or FISH, again, or NGS, or even an RNA fusion panel. And ALK IHC is actually approved, and here you will see an example of positive staining on the left, some rare equivocal staining in the middle, and then negative staining. And actually, if you see positive staining, it's sufficient to qualify for ALK inhibitors, although I will say that at our institution, we have gone away from using the ALK antibody. In contrast, testing for ROS1 fusions using IHC is a little bit more complicated, even though this antibody is quite sensitive and is commercially available. The fusion cases can have somewhat of a variable uptake, and it has imperfect specificity. So again, we've gone away from using this, but I put this up because there are some labs that may still be using ROS1 fusion IHC. Should we be doing one gene testing at a time, or should we be doing sequential? I think most centers and most community practices, as well as hospitals, have really adopted, the simultaneous testing rather than sequential testing. And here is a clipping from a very nice paper from Dr. Pinnell at Cleveland Clinic, where they did sort of like a cost analysis looking at the cost of upfront NGS versus single gene testing. And they actually showed that upfront NGS testing saved between $127,000 to about $1.5 million compared with single gene testing. So, I mean, we're talking about substantial cost savings as well as covering the adequate number of genes that we need to cover. So I think this is something that we must keep front of mind when we think about molecular testing. So I want to circle back to the slide to just show you that, lung cancer is complex. We now have at least 8 targets that we must look at in the upfront setting. And how do we really go about doing these tests? I discussed with you that next generation gene sequencing is probably the best test because it gives you adequate coverage and a reasonable turnaround time. So how should we go about getting it? And here's another challenge that comes up. Even though tumor NGS has been our gold standard, where we obtain tissue testing and obtain next generation sequencing on that tumor and then really use that to guide therapy, but oftentimes we find that tumor NGS is just not able to be done, or the tumor is insufficient or inadequate. So here is where we can use the power of plasma really to harness the information that is available to us in the circulating bloodstream to personalize therapy. And I just want to pause here for 1 second because I want to be clear that I will be talking about a very small specific level of information that we have available from the plasma, and that is using circulating tumor DNA that's available to us. Again, these are small fragments shed from the tumor that are then circulating in the bloodstream that we can amplify and sequence to really study the molecular profile of the tumor. I will not be talking about other circulating materials such as circulating tumor cells or exosomes, which are a clinical and research interest of mine, but have not been adopted widely into clinical practice just yet. So here's what we can do with circulating tumor DNA that we obtain from plasma. We can certainly look for mutations. We can look for copy number alterations, gene fusions. And there are also research going on in looking at DNA methylation, perhaps to use that as an early signature in screening for cancer. And certainly there are trials that are ongoing, and some of which have also been reported. But outside the scope of our discussion, what we're really interested in, again, is looking at mutations using this next generation gene sequencing. So how can we use liquid biopsy to really fully realize the benefit of precision medicine? And I thought I would break this down into sort of these 4 subheadings, which talk about initial diagnosis and therapy selection. I think where there is really a lot of immediate benefit that we can derive, and then talk about monitoring of resistance, tumor heterogeneity, minimal residual disease, as well as TMB, as we discussed. So firstly, let's start off with initial diagnosis and therapy selection. And here are 2 papers that I want to discuss with you. On the left is our research experience from the University of Pennsylvania. And on the right is really a really nice clinical utility piece that was published in Clinical Cancer Research last year by Dr. Natasha Lyle, also called the Nile study. So starting off with our experience, we sought to ask if there was really additive clinical benefit of using liquid biopsy in addition to tissue biopsy in patients with metastatic non-small cell lung cancer. And we started off with about 323 patients. And, I will say that out of these, about a third of the patients never got a tissue biopsy. And these were either due to patient choice or MD choice. And some of the patient choices were, is there something that you have where, I don't have to get an invasive procedure, or can we use a liquid biopsy? Or when the MD said, oh, that adrenal mass is really hard to get, let me not do a laparoscopic procedure to get that adrenal biopsy, let me send the plasma sample. So if I leave these 30% of the patients aside where concurrent testing could not be performed, and we focus on the patients where our intent was to do concurrent testing, I would like to highlight that even at a very large specialized academic center as ours, we were able to complete tissue biopsy. And when I mean complete tissue biopsy, meaning we were able to successfully perform NGS on tissue samples only in about 40% of the time. Often because either the biopsy was too small or the tissue was necrosed or there was just not enough DNA. And for the 31% of the patients, we only had plasma, even though our intent was to do concurrent plasma and tissue. And these were the patients that were not successful in performing tissue NGS. So when we evaluate these two subgroups together, what we saw that in these patients, with tissue alone, we were able to identify an actionable molecular mutation in about 20.5%, which increased to 35.8% when we layered in plasma, meaning that we could identify more patients with the addition of plasma-based gene sequencing. And this was not because we were not trying to identify patients, it's just that we were not able to because of the inherent challenges that are present with the acquisition of tumor NGS. Similarly, this study that I discussed with you, the Nile study, was a clinical study looking at utility of comprehensive cell-free DNA. And they started off with 307 patients where the intent was to do concurrent testing, and finally included about 282 patients with non-small cell lung cancer that were tested with both tissue testing according to physician choice as well as circulating tumor DNA. So looking at the results a little bit, with tissue, they identified 48 patients that were positive. However, with tissue, they had a total of 60 patients, but with circulating tumor DNA, they were able to increase that number to 77. So, but if you look at the overall study, mutation-positive patients increased from 60 using tissue alone to 89 using tissue plus circulating tumor DNA, which was very meaningful because these are the 29 patients that were able to avoid chemotherapy, avoid immunotherapy, and avoid adverse events. What was also interesting is that they reported the timeliness of the reports. And as you can see, ctDNA results were returned significantly faster than tissue, 9 versus 15 days, which was statistically significant. So are these findings actionable? Let's say I find a report listing an EGFR mutation on my plasma sample. And I would posit that, yes, these findings are very actionable. And there's actually data to support that. In our series, we evaluated all of the patients that had a therapy directed based on the results of the liquid biopsy alone, not the tissue biopsy, but just the liquid biopsy. And here they are all laid out. And out of these 67 patients, we had 42 patients with resist measurable disease. And as you can see from the waterfall plot, these responses were very much in line with what we would expect based on clinical trial data. We had patients that responded beautifully as we would expect if we had a tissue test. And ours is not the only experience that has corroborated this. On top, you will see post-hoc analysis of tumor, T790M positivity with osimertinib on the left, and plasma T790M positivity on the right. And if I hadn't told you that these waterfall plots were slightly different based on modality, you would think that this is the same drug, the same population, because they are completely interposable. Just to say that even if we detect a T790M on plasma, patients can still respond. And similarly, at the bottom, you will see that patients on the FLORA trial, which was our first-line trial of using osimertinib in patients with EGFR mutant non-small cell lung cancer, patients that had plasma ctDNA positivity had similar improvement in progression-free survival when they received osimertinib. I will point out one minor caveat here. They also looked at patients with plasma ctDNA negativity. And remember that all these patients had to have tissue confirmation to go on the trial. However, let's say they were positive by tissue but negative by plasma. I mean, they still benefited because of this tissue positivity, but look at the median progression-free survival for these ctDNA negative patients. It was 23.5 months, much higher than patients that had plasma positivity. And I would say that this is mainly related to the fact that possibly plasma-negative patients had low shedding and had overall low disease burden, really improving their median PFS and improving their outcomes. There are some limitations of plasma NGS that we should know and be aware of. One is that the level of or the allelic fraction may not correlate with response. So it doesn't mean that a patient with a very high allelic fraction is going to respond, or conversely, it also does not mean that a patient with very low allelic fraction may not have a significant response. We evaluated both scenarios. Here is a patient who had a very low allelic fraction, had a complete response on RECIST. And on the converse, here is a patient who had very high allelic fraction of about 26%, but only had stable disease. On the right, I also want to highlight one other limitation of plasma NGS is that the presence of visceral disease or the presence of extrathoracic disease increases our chances of being able to detect a circulating tumor DNA reportable mutation. I actually had a patient within the last 2 weeks who only had pleural effusion and only intrathoracic disease, and plasma ctDNA turned out to be negative. But since she was a never smoker, we went on and we waited for tissue, and we were successfully able to find an ALK rearrangement. And this is similar to our data here that was presented in our paper, that patients with M1A disease were very unlikely to have a detectable mutation in plasma. And I think we should all remember that a circulating tumor DNA negative report doesn't always mean that that mutation is not present. So here I have for you some analyses of what are the pros and cons, if you will, of tissue versus plasma. And I think the highest pros of plasma-based testing is that it's convenient, right? It's fast, it comes back in 7 to 10 days. And these our commercial lab partners are really doing an incredible job of getting the reports back to us as soon as possible. But it does not have that kind of sensitivity for the issues that I discussed with you. It's very dependent on the ability of the tumor to shed tissue. But they are very specific. So as I shared with you, if somebody has a very low allelic fraction of a RET fusion, if it's 0.1%, it still means that the RET fusion is real and it should be treated. So I think there are some pros and cons to this. Pros and cons, and sensitivity and specificity is definitely higher with tissue. So how do I use this in clinic, and how do I choose this in clinic? And I would like to share an algorithm which I follow. And usually when a patient with newly diagnosed non-small cell lung cancer comes to me in clinic and they have non-squamous histology, the first question I ask is tissue available? Do we have it? Because I see a lot of second opinions, and often I don't have tissue available. And that's where I sort of go with the plasma ctDNA route to try and get an answer. And if I find a mutation in plasma ctDNA, that's a no-brainer. I go on to the particular targeted therapy. But if they don't have it, as I shared with you, I do reflex to tissue. So either by the time that I'm waiting to get the tissue shipped to my institution, usually that's back, or if tissue is absolutely not available, I go in and repeat a tissue biopsy. If tissue is available, there are two options that emerge. Is it adequate or is it inadequate? Our pathologists do a fabulous job of telling us upfront the cellularity of the tissue biopsy that has been obtained, and they tell us, they say to me, Charu, your tissue is very unlikely to yield a sequencing report. Or they say it's very likely to yield a sequencing report. And then I have the following options. I can either do concurrent testing, an approach that we showed in our paper as well as in the Nile paper, that you can still increase your ability to find these mutations. You can do just tissue testing, which may, in some patients, not be the best option because you want to get a result faster. Or you can still start with plasma ctDNA and hold off on tissue testing, although I personally prefer the concurrent testing route for the reasons that I discussed with you and what our data has shown. And then in the cases that really the tissue is inadequate, I follow the approach on the left where I start with plasma ctDNA and sort of go down that route. So this is sort of my algorithm that I follow in clinic, and this is something that we have actually put together in a nice review article with several of my co-authors. So just in the last 10 minutes or so, I want to talk to you about other applications of plasma-based testing. And one of them is monitoring of resistance and tumor heterogeneity. I've been using ctDNA for a long time. So I think the first example on the left is one of my patients who was on a first generation EGFR TKI, and upon progression was found to have a T790M mutation. Again, this is a scenario that we don't usually see now because we are using first-line osimertinib, and it's sort of becoming redundant for us to even look for this mutation. However, as you can see, I initiated osimertinib upon detection of this T790M mutation in plasma, and lo and behold, we did not have any further detection over the next several samples. On the right is something that I think all of us are beginning to see as we are using osimertinib much more in the upfront setting. Here is a patient who initially had an exon 19 del mutation, and I started with afatinib. Upon progression in plasma, I found T790M. I started osimertinib, and then upon progression on osimertinib, I was actually able to find an EGFR C797S mutation that's actually perhaps a resensitizing mutation to first and second generation EGFR TKIs, and may lend itself now to patients becoming eligible for clinical trials, specifically evaluating this subset. So I do think that even though we are still learning about molecular mutations in the post-first line setting, especially when it comes to osimertinib, I think this longitudinal monitoring of plasma ctDNA may give us interesting information. And I don't have slides up here, but a similar story has panned out for ALK rearrangements, where we are able to detect mutations such as G1202R, which may be very sensitive to lorlatinib, or some other mutations such as the C1169, which may not be sensitive to lorlatinib. So I do think that this is an important modality for us to use in specific groups of patients to be able to see if we can actually get them on clinical trials. Minimal residual disease, I think, is very interesting, especially now that we have data on the ADAURA trial. And ADAURA, just for a recap, is a large phase 3 randomized trial that is evaluating the use of osimertinib in the adjuvant setting for patients that have EGFR mutant resected lung cancer. And in a report, which was actually an early interim analysis, showed that patients that received osimertinib after having resection and receiving standard of care chemotherapy in the adjuvant setting actually had a superior disease-free survival compared to patients that were on observation alone. There's been a lot of debate about this, and the question is, can we even identify those patients a little more finely? Could we perhaps use a technique such as minimal residual disease? And I think this becomes very relevant, especially in the post-ADAURA setting. So here are data from Nature 2017. This was a very large analysis. Dr. Swanton led some of this work where they used a plasma ctDNA approach to predict for relapse after surgery for early stage non-small cell lung cancer. And here are several different patients that were followed over time using this plasma-based approach. And I want to highlight that this is the circulating sort of tumor load, if you will, in terms of variant allele fraction. And in patients that had a relapse, as marked by these red R's, you can see that inadvertently, in all of these patients that had a relapse, the circulating level of, the detection of plasma mutations predated the relapse by several days to weeks. So this is a modality that could potentially be really utilized to identify the highest risk patients. This is another paper utilizing a CAPS seq approach to identify tumor in pre and post treatment samples. And here you can usually use a mutation to track in the post-treatment sample. And again, here you will see that if the ctDNA was never detected post-surgery, their disease-free survival as well as disease-specific survival was really absolutely fantastic as compared to patients that still had residual disease in the bloodstream. So I think very interesting and intriguing data that I know now there is more interest to apply in both the neoadjuvant as well as adjuvant setting. And here is some additional data where you can see that if in case there is no ctDNA circulating in the bloodstream, that probably means that there is no tumor, as you see in these radiology images where, time from there was absolutely no ctDNA here at a time when no disease was found on the PET scan. So lastly, plasma TMB is another approach using liquid biopsy. And this is the current evidence so far. Blood-based TMB utilizing a larger panel has been validated as a potential biomarker to really screen out patients that may benefit best from immunotherapy versus chemotherapy. On the left is a paper that really was a pioneer paper in this field, using a cutoff of 16 mutations per megabase. They were able to find a population of patients that did better with atezolizumab versus docetaxel. And then using the Guardant Omni panel, which is a 500 gene assay with a very large coverage, plasma samples were tested on the MYSTIC trial. This was a large phase 3 randomized trial looking at immunotherapy versus combination immunotherapy using durvalumab and tremelimumab versus platinum-based chemotherapy. And what we found was that in the highest immunogenic tumors, using as defined by a blood TMB level of more than 20 mutations per megabase, those were the patients that benefited the most with combination immunotherapy, including durvalumab and tremelimumab. And as you will see, the 2-year overall survival for these patients was very high at 48.1%, whereas it wasn't very clear for those patients that had VTMB less than 20. So I think this is a useful biomarker, perhaps, however, has not really panned out in terms of being clinically useful, as many of us are using chemoimmunotherapy. So we sought to find out whether plasma TMB could really predict for a response from chemoimmunotherapy. And we looked at all patients that had started off with a pembrolizumab-based either monotherapy or chemoimmunotherapy approach. And here you will see, using the same cutoff of VTMB of 16, we were able to clearly distinguish which patients would do better in terms of progression-free survival and overall survival. This was true for pembrolizumab monotherapy in terms of progression-free survival. Our overall survivals were not very statistically significant, maybe because these patients do well overall and our sample size was potentially small. However, we did layer on other mutations, which we described well in our paper, such as TIC11 and PTEN, as well as ERB2 exon 20 insertion mutations, where we were able to demonstrate that those mutations along with TMB may potentially be a very nice combined biomarker to really tell us which patients are most likely to benefit even from chemoimmunotherapy. So I think this is something that will evolve as the next several years go on, and we really look at subsets of patients within a larger group of patients that will receive immunotherapy. So I hope I've covered sort of this landscape of the use of liquid biopsy. As I mentioned to you, using methylation signatures, companies such as Grail Diagnostics are looking at using circulating cell-free DNA in the screening space. We are obviously very interested in the minimal residual disease space, both post-surgery and perhaps also post-chemoradiation, where I think there is a real need to evaluate patients that may have the highest risk of recurrence. And then, of course, as I discussed with you in the advanced disease stage, now it's becoming standard to use liquid biopsy in the upfront setting for diagnostic as well as therapeutic purposes. And then very relevant, for example, for ALK rearrangements in EGFR mutations to look at the mechanisms of resistance as well as consideration of clinical trials as these mutations come up. So in summary, plasma biopsies or plasma or liquid biopsies using plasma NGS are a powerful tool for targeted therapy. There are also other circulating tumor materials such as CTCs as well as exosomes that are really of interest. Plasma NGS is a very easy, facile, fast, minimally invasive way to rule in a mutation. I have a suggested algorithm here, which includes a plasma-based approach in patients where tissue may be unavailable or actually inadequate. And then other potential uses, including MRD and TMB, are being utilized, really offering us a chance to personalize therapy and continue to consolidate on the successes that we have seen over the last several years. And with that, I really thank you for your attention. And again, Dr. Bernecker, thank you for the invitation.
Thank you. That was excellent. We do have some questions from the virtual audience. Why not hold a lung biopsy unless or until the liquid biopsy is not helpful?
So I think we always still would like to get histology for confirmation of the cancer. We quite haven't got to that stage yet where we can direct treatment based on liquid biopsy alone. There is always the potential of inadvertently picking up a mutation that may be a CHIP mutation, like a clonal hematopoiesis of indeterminate potential, like picking up a JAK2 or picking up KRAS or TP53, or picking up a mutation that may be present from another primary. For example, I've had a patient who had both lung and colorectal cancer, and we picked up a KRAS mutation, which turned out was not from the lung cancer. So I think there's still a lot of value in obviously establishing the diagnosis and getting the initial biopsy.
Very good. Somewhat related. Should pulmonologists order a liquid biopsy when they are working up a lung mass that they feel is likely to be malignant?
I think this is an excellent question and something that we are actually evaluating in a research setting at our institution, where we have instituted a protocol where our interventional pulmonologists, Dr. Jeffrey Thompson, who's been my close collaborator and colleague, will often send off liquid biopsy at the time of the interventional biopsy procedure. And I have to say that, we are, the study is ongoing. But I'm happy to share that, we are able to get results on the same day as the first medical oncology visit because of this effort of sending that liquid biopsy in advance. And that has changed management for a few patients where, I can send the patient down after my appointment to go get their targeted therapy, which I have called in even before seeing them, and we've completed the prior authorization. So it has dramatically changed how we've been able to manage these patients. So I do think that, if we validate these in our research setting, this is something that could be adopted more widely.
Okay, and one more. Should liquid biopsy be used to assess response to immunotherapy?
That's a great question, and I think that's a question that we are actually working up. There is a lot of effort in looking at serial liquid biopsies as well as decline in variant allele fraction or change in variant allele fraction over time with immunotherapy. We presented a paper or an abstract at ASCO last year where we demonstrated that patients who had a decrease in their allelic fraction after receiving monotherapy, pembrolizumab monotherapy, had a much superior progression-free survival compared to those that did not. And similarly, we found that in patients that received chemoimmunotherapy, and actually that manuscript is under review right now. So I do think that this is something that's very worthy of consideration. And I will say that we are able to also differentiate. In our paper, we describe this, that we are able to differentiate patients that may have pseudoprogression from real progression. So in other words, we've had patients where, it looks like on radiological imaging that they're progressing, but they're actually not. And when you look at their circulating tumor DNA, their variant allele fraction is actually going down, really saying that if they're clinically feeling well and their circulating tumor DNA is going down, but the scan looks like it's a pseudoprogression, it's probably a pseudoprogression. So I think in those instances, it may be very helpful to have this additional biomarker to guide our management.
Great. That's it. Thank you so much for that wonderful presentation. We really appreciate it.
Thank you for having me.
You bet. Thanks. I'll introduce myself. Just to clarify, this is not an exercise in narcissism. I just think that there are a number of topics I was hopeful to discuss that are very exciting in terms of developments improving, or hopefully improving, immunotherapy response. So I'm going to discuss potentially how the use of oncolytic virus can really hopefully augment response and benefit to lung cancer and potentially other patients with solid malignancies. I now understand how the baseball players feel playing in empty stadiums, and next year, if we're still virtual, we're going to have cutout people in the audience, so hopefully that will not be what we need to do. These are my disclosures. I want to start by really just, again, setting the scene in terms of the continued toll that lung cancer takes on public health. We'll talk about, of course, the immunotherapy revolution, some of the frustrations, and then that'll lead into some of the emerging data on some of these therapies we hope to utilize for increasing immunotherapy response. So as everyone knows, lung cancer is the leading malignant killer of both men and women. The 5-year survival rate of 18.6% is lower than many of the other leading cancer sites, such as colorectal at 64.5%, breast at 89.6%, and prostate at 98.2%. Even for localized disease, the 5-year survival rate for lung cancer is about 56%. We all know that only 16% of lung cancer cases are diagnosed at an early stage for a variety of reasons. And because of that, we end up dealing with a lot of significantly advanced lung cancer. One of the other concerns during this COVID epidemic, and which one of the earlier speakers had mentioned, is we know that there's a significant drop in cancer diagnoses since the pandemic began. And it's not that cancer is disappearing, but we're seeing about a 50% cut in the number of lung, breast, and colon cancer. And we're all concerned that that's going to lead to increased presentation of advanced disease probably in the next 6 to 9 months. And again, more than half of the patients with lung cancer die within 1 year of their diagnosis. So, somewhat old slide, but it hasn't changed much. Lung cancer death rates are not the same everywhere. There's some disparities, as you see. There continues to be significant mortality in the South and in the kind of Mid-Eastern Atlantic states. It is a global problem, but it does affect people of different populations differently. Smoking rates have dropped, but they remain frustratingly plateaued in the prison population. People with mental illness, rural patients tend to have a higher smoking rate. So there remains significant work to be done. It is certainly true that not all patients with lung cancer are using tobacco. There's an increasing incidence of non-smokers. Nevertheless, we need to continue to work on not just screening, but smoking cessation. So a snapshot of just where we stand on lung cancer in 2020. As I mentioned, smoking rates have continued to drop, but stabilized. The use of e-cigs is contentious, and whether it really is something that allows tobacco users to get off combustible tobacco. I think the real concern among public health people is the use in teenagers and the explosion in middle school and high school vapors. We don't know long-term effects of what vaping is going to do over 15 to 20 years, and it's not clear how much of a safer alternative it is and whether it's a gateway to eventually transitioning to combustible tobacco. Lung cancer screening remains sadly underutilized. That was before COVID. It was estimated only about 4 to 5% of eligible people based on guidelines were getting lung cancer screening. So we need to do continued significant work in terms of getting the education out there and utilizing this approach. As you heard from Dr. Agarwal, genomic testing continues. It is improving, but it's lagging behind the NCCN current recommendations. And the more actionable mutations we have with tolerable drugs, this is very frustrating. And while the immunotherapy revolution has certainly changed lung cancer therapy, let's also recognize it is not the final answer, and there remain many people who do not respond to immunotherapy or respond and lose that response, and work remains to be done. This is a slide that's probably been seen in the majority of talks for the past 5 years. Just to remind you that we don't have infallible biomarkers for understanding response to immunotherapeutic drugs, but there clearly is some correlation between the number of coding somatic mutations and response rate to immune checkpoint drugs. So as you can see, towards the right, as the somatic mutation numbers go up, such as in cutaneous melanoma, skin cancer, where we're seeing really DNA damage from exogenous carcinogens leading to presumably new antigen formation, there are very robust responses to immunotherapy drugs. Down in the middle, you see lung cancer, head and neck, urothelial, and there are very meaningful and often durable responses here, but clearly it's not solely a basis on mutation. And then all the way at the bottom of the graph, you'll see that uveal melanomas and pancreatic cancers have truly low response rates and profoundly low mutations. So part of the problem is figuring out how do we get some of these so-called cold tumors, ones that don't cause an immunogenic response in the immune system and presumably exclude cells, T cells, from their microenvironment. What do we do to aggravate that tumor or make it hot so that patients have better responses? So at least let me talk a little bit about the success that we've had. This was a recent article that looked at the initial cohort that was treated with nivolumab on a phase 1 trial, and it looked at patients with advanced melanoma and kidney cancer, which of course at the time made sense because we've always known that those are relatively immunogenic tumors that had responses to biologics. But there was a lung cancer arm, and this is where the activity was a bit surprising, gratifying, and this is the 5-year survival. And you can see that while the lung cancer survival is not that of the melanoma or kidney cancer patients, still, if before the immunotherapy revolution, I told you that 5 years out from starting on a drug, patients with metastatic non-small cell lung cancer, all of them heavily pretreated, would be alive, you would be fairly stunned and disbelieving. So while we will talk about a lot of work to improve those numbers, this is a substantial improvement that's been very gratifying. Also to show you, it's interesting, again, the lung cancer patients, as you can see, very low rate of complete response. These were all partial responses that led to stable disease for a long period of time. But nevertheless, despite that, it's been truly amazing to see patients 5 years out alive and doing well. And to go quickly over some of the data that really led to this paradigm shift in the management of lung cancer, this was a study that looked at giving the immune checkpoint drug pembrolizumab against standard platinum doublet chemotherapy in advanced lung cancer. And in this case, these were in patients all with PD-L1 staining levels on the tumor of greater than 50%, which is high. But if you're a patient, you don't get to choose if your PD-L1 level is high, and this is not a huge percentage. of patients with advanced lung cancer. Nevertheless, you can see that Pembro substantially improves overall survival as a monotherapy to the point that this has become standard of care. And while thoracic oncologists occasionally debate whether patients with high PD-L1, more than 50%, should they get chemo in addition to Pembro, in reality and in practice, the majority of patients are more than happy, should they have a PD-L1 of more than 50%, to only take immune checkpoint drugs. And often, these responses are sustained for years. When Pembro is added to chemotherapy versus chemo by itself, looking at patients with lower PD-L1 levels, we saw not as dramatic, but still a very substantial improvement in progression-free survival. When Dr. Langer presented this a number of years ago, there was some debate about whether we would see overall survival benefit. But with updating of the data, it was clear that we did. And so Pembro plus a platinum doublet has become the standard of care now for patients with advanced non-small cell lung cancer, either with treated driver mutations or without driver mutations and without a high PD-L1. On the bottom of the slide, you can easily see that essentially everything is on the correct side of the line. Interestingly, the actual degree of PD-L1 was helpful, but at the end of the day, patients even with low PD-L1 benefited significantly from the addition of immune checkpoint drugs. Again, suggesting while PD-L1 is helpful, it certainly is not the world's most robust biomarker in selection of patient therapy. So, is the glass half full, empty? And the bottom line remains, many lung cancer patients do not respond to immunotherapy. They all want it. It's not hard to imagine why patients really want to avoid cytotoxic chemotherapy. But at the end of the day, if it's not going to be effective, the question for us is, how do we identify who's going to be resistant or benefit, and how do we enhance improvements in survival and response? And this is where some of these adjuvant therapies, adding to immunotherapy, such as radiation and oncolytic viruses, come in. So why are some patients exhibiting primary resistance to immune checkpoint inhibitors? And there are a number of reasons. We think that in many cases there's an inadequate T-cell infiltration, mainly because the tumor is not that immunogenic. Again, whether that's because the mutational burden is low or other factors needs to be worked out. There's T-cell exclusion. There's tumor cell resistance to interferon. And there are other local immunosuppressive factors within the tumor microenvironment that's suppressing response to the body's immune system. We go back one slide. There we go. Mechanisms of acquired resistance, slightly different, but there's loss of T-cell function, there's disruption of antigen presentation, and again, there's evolution of interferon resistance. So we're getting a better idea of the mechanisms leading to the development of resistance. So now the question is, again, how do we make a hot tumor microenvironment in those patients who don't have it? And there are a number of different strategies, as you can see on the slide, from metabolic reprogramming, modifications of the STING pathway, epigenetic reprogramming. We're going to focus on the cartoon part over on the right, looking at immunomodulatory factors such as oncolytic viruses or radiation therapy. So this is the Grateful Dead, and as I get older and older, I realize fewer people in the audience will have any clue what I'm talking about. So the Grateful Dead were an American psychedelic rock band that came out of San Francisco in the late 1960s. I'm going to try to explain what this has to do with oncolytic viruses. So they were a huge force in American music, and they developed a tremendous cult following. And then when Jerry Garcia, their guitarist, died in the 90s, they splintered up. And yet there are still fairly rabid fans out there who, 25 years out from the end of the band, continue to really appreciate their music. And you might say, well, what does that have to do with anything? So recently Nike decided to launch these Grateful Dead themed sneakers. And you might think they're aesthetically displeasing, as my wife did, but nevertheless, you would think, why, from this band that has really not been functional since the mid-90s, would people get excited? And that's not an unreasonable question, but the website crashed and people were unable to buy it the day that they offered. And you can go to other websites that are selling sneakers secondhand, and you would probably be horrified to see that the sneakers are now going for $5,800 a pair. And this is kind of like the trajectory of oncolytic viruses, because in the 60s and 70s there was a lot of interest, and they were able to cause local responses, but we didn't really have systemic therapies such as immune checkpoint drugs that were useful. But we do now. So again, I think that there are a number of approaches that you'll see being taken in the clinic. So one approach, obviously, is to add a number of immunotherapeutic drugs together in combinations. There are a lot of on and off switches on T cells, and you can look at drugs that block the off switch or turn on the on switch. And this is a very attractive possibility, but toxicity does go up once you start combining immunotherapeutic drugs, and cost really starts to go up. And certainly it goes up with all of these things, but I think that we have to always keep in mind what the cost of these drugs are and how is the medical system going to be able to make sure benefits get to patients while we're not breaking the bank. Other options, addition of radiation therapy, and we'll go over that, addition of oncolytic viruses and the rationale behind it, we'll discuss that, and then tumor vaccines, which we won't really discuss today. So just to remind you what oncolytic viruses do as a class, so they tend to be taken up preferentially by tumor cells much more than healthy cells. And sometimes these oncolytic viruses are just modified so they don't really replicate. Sometimes you can put interesting genes into the oncolytic virus so that it's taken up by the tumor cell and produced, and it can make things like GM-CSF. And then as tumor cells pretty much die and explode, the idea is that it causes effects in the tumor microenvironment with cytokine release. You get induction of T-cell mediated anti-tumor immunity, and then hopefully you get regression, not just where the oncolytic virus is injected, but hopefully systemic, and we'll look at some of that data. There's a whole cascade that gets triggered when the virus is taken up, releasing things like PAMPs and DAMPs and other cytokines, and it does add to this whole kind of milieu where hopefully antigen-presenting cells are able to better present tumor antigens to T cells for response systemically. So let me talk a bit about where we stand with the addition of radiation to immune checkpoint drugs and where that's gotten us so far. So when the medical oncologist first saw immunotherapy, it was pretty exciting. We finally had a new class of drugs to use, and the radiation therapists were a bit sad because they felt jilted, and we had often used chemoradiation for a variety of tumors. And so there was a hunt on to see how radiation could, I guess, get back in our good graces. And there is rationale for this, right? So the abscopal effect was noticed many years ago in the 1950s, where when you radiated a tumor site, that in a non-radiated field, you would see response. And it was rare, and it had been rarely seen over the years, but the idea is that, again, as radiation kills cancer cells, you get cellular damage that elicits cytokine release, inflammatory mediators, more presentation of tumor antigens to the immune system, and in fact, it acts like an almost kind of in situ vaccine. And so that has been the idea to say, well, maybe we can use this to enhance response, especially in cold tumors, to immunotherapy. I will point out initially the abscopal effect was where you gave radiation and no systemic therapy, and you had a distant response. It's slightly different than it's used now, because now we're talking about giving an active systemic therapy. The difference is now we're talking about increasing the incidence of response when radiation is given. And so the question is, do we have data that this does stuff? And some stuff is coming that's looking very interesting. I will say that We know that radiation often can affect DDR or DNA damage response genes. This was an interesting paper that came out recently that essentially showed that in patients with mutations in those category of genes, in DDR positive, that the response rate to immune checkpoint drugs was higher, that the progression-free survival was better, and so that is interesting, and maybe not only is this a new biomarker that can help us as part of the puzzle of who's going to respond, but it might also allow us to exploit damage to those genes. I will also show in the same data set, they looked at patients with high PD-L1 greater than 50%, a group that we knew already did better with immune checkpoint. And you could again see that even if the PD-L1 is high, DDR is an independent marker of suggesting responsiveness to immune checkpoint drugs with a response rate of over 50%. But we've already seen this in real life, in real people, and this was the Pacific trial that really completely changed the management of locally advanced lung cancer. This was a trial that looked at patients treated with chemoradiation. They were randomized afterwards to placebo or durvalumab, an immune checkpoint drug. And you can see that as those patients were followed, there was a substantial progression-free survival advantage in the arm that got durva at 18 months, 44% to 27%, and follow-up data has confirmed a overall survival advantage. So this quickly has become standard of care now for locally advanced lung cancer, which has traditionally been a very difficult to treat stage of disease. You'll see that when they looked at the prognostic factors, most of the important stuff was on, again, the correct side of the line. It didn't really matter if they were squamous or non-squamous. Curiously, whether the PD-L1 was above or below 25%, there was some variation, but not super strong. Both groups responded. Importantly, in this data, you'll see that when patients, when the last radiation, the randomization to durva or placebo was within 14 days, you'll see that there was a significant improvement favoring durva. Now, that might mean one of two things. It either means that patients who can go onto durva quickly after finishing chemoradiation because they tolerated it better because of other factors are more likely to do better anyway, or it means that there was some residual effect of the radiation, and by starting durva sooner, you are getting a better synergistic reaction. And I suspect it's the latter. And so in this case, we try to get our patients onto durvalumab as quickly as possible after the completion of chemoradiation. Now, it has been used in metastatic disease. This was a paper from Thielen et al. That was in JAMA Onc last year that looked at patients given pembrolizumab, and then some got SBRT. You'll see it's not, at the end of the day, it was not a huge trial. It was a phase 2 that looked at 40 versus 36. This was not a positive trial statistically. There is a trend of benefit in the experimental arm. You'll see that everything's bouncing over the line at the hazard ratio. But there was some interesting stuff to tease out. And the important thing on this table is if you look at the control arm versus the experimental arm being the group that got SBRT plus Pembro, that in PD-L1 greater than 50%, not shockingly, both groups did well because we expect those patients to do well. But in the PD-L1 of 0, you can see that the experimental arm, and I know we're dealing with tiny numbers, but nevertheless, there is maybe an inkling that the experimental arm did better because of radiation and SBRT causing a cold tumor to be hotter. And this is something that we need to continue to look at. Luke et al. Also looked at multi-site SBRT in patients given Pembro. This was really more for toxicity, looking at a number of sites in patients with a number of histologies and solid tumors. There was some interesting data. It was definitely safe. Encouragingly, there was not increased toxicity with the addition of SBRT to Pembro. But again, while we're looking for something a little more dramatic, there certainly was not worse outcome. There certainly was not worsening toxicity. Now we get to what hopefully oncolytic viruses can add to the immune checkpoint story. There are a number of ways, as I had mentioned, to utilize oncolytic viruses. So one way is to use a viral vector to essentially transduce genes into tumor cells. And at Houston Methodist, we've been using an HSV-TK for many years, but the idea is that in this adenoviral vector that's taken up by tumor cells selectively, it incorporates the HSV-TK. You then give the patient ganciclovir, and as HSV-TK works on that, you get compounds that essentially are toxic to dividing cells. So you exploit differentially tumor cells versus normal cells, and then you're able to cause DNA damage. And it's been used for about 20 years, including data in prostate cancer. And the important thing, essentially, that you're seeing on this slide is in rat model, at the bottom line, you'll see this is a combination of radiation and the HSV-TK, giving by far the slowest growth and the fastest response. And you'll also see that they had by far the longest survival. So it clearly looked that giving an HSV-TK into a tumor and then giving radiation synergistically was able to cause tumor death. And when they looked at and were able to biopsy it, again, you'll see the line all the way on the right, on the bar graph, the combination of HSV-TK with radiation led to by far the most infiltration of CD4 cells into the tumor, supporting the idea that it's able to mobilize the immune system. This was a study that looked at different adenoviral oncolytic viruses, although the concept was the same. They either got radiation, they got the virus, or they got both. And in the circle line on the bottom, you can see that the combination of oncolytic virus plus radiation substantially kept tumor growth down, as opposed to either radiation by itself or essentially nothing. So we know that there's a synergy here that's very interesting. So now moving on to some recent trials that have been encouraging. This was a trial that was published in Science Translational Medicine earlier this year that looked at transducing an IL-7, IL-12 into tumors. And you can see that it's given into mice. They get the virus, and then they're given anti-PD-1 or anti-CTLA-4. And clearly, mice who got the injected oncolytic virus with this IL-12 and IL-7 did substantially better, and there was clear synergy. When they looked at the pathology, again, similar to what we've seen before, an increased infiltration of immune cells into the tumor microenvironment, enhanced MHC class II expression on antigen-presenting cells, upregulating multiple immune pathways, inducing, encouragingly, regression of tumors in non-injected distant tumors, upregulation of PD-L1, again, not just on the injected cancer cells, but in distant tumors, and importantly, no symptoms of a cytokine storm. This was a trial that also looked at neoadjuvant oncolytic virotherapy, but this was given before surgery. So this was in a model of triple-negative breast cancer, and you can see that they got the virus, the tumor was resected, they were then re-implanted with tumor and were given immune checkpoints. And you can basically see that in patients who got the viral injections and then got challenged with the immune checkpoint, they had a substantial improvement in survival that was dramatically better. So here's a case again of an oncolytic virotherapy in the tumor immune microenvironment, sensitizing the immune system, so even down the road, improved responses. And you might say, well, that's great. I know, it's mice. What have you done in people? So this was an interesting trial that was done also recently. It was done, however, in patients with pancreatic cancer, which I'd shown you is a very poorly responsive tumor, pretty much to everything, cytotoxics as well as immune therapy. And this utilized reovirus, oncolytic virus, the pelareorep, with pembro and various chemotherapies. These were in patients with metastatic pancreatic cancer who had already progressed on frontline therapy. And I can tell you that generally they do just horribly. The important thing here is that when patients got the immune checkpoint drug in addition to chemo and the oncolytic virus, there were 3 patients who had pretty substantial responses. So while that's not like a home run, it does show that in a very difficult to treat tumor that tends to be very cold, it's possible that we can exploit oncolytic virus and immunotherapy to better improve responses. And other trials are underway to confirm this. In that trial, you can see at the bottom that in the post-treatment, increased CD8, increased PD-L1 expression. So this is, again, more proof of principle. This was a novel study that really didn't look at anything too fancy in certain ways, but it looked at the seasonal influenza vaccine. And what they found was that when they gave the flu vaccine injected into the tumor, mice did better. So on the right, you'll see that when you give the flu vaccine and PD-L1, you had dramatic responses systemically, not just into where the flu vaccine was injected and it was sustained. And that was a much greater response than to the flu vaccine or to PD-L1 by itself. And it also, by the way, worked in mice who had been resistant to immune checkpoints. In the center, you'll see pie charts. The important thing is on the bottom, the 2 pies on the bottom show that when you give the flu vaccine and they look at dendritic cell, you see dendritic cell expansion and T cell expansion. And so, again, the attractive thing here is that this really shows further benefit. This is something that already we have available and theoretically could be used fairly quickly to act to stimulate the tumor microenvironment. There's been other studies showing similar interactions. This was a study that looked at TVEC, which is an approved oncolytic herpes virus that makes GM-CSF that we use in melanoma. And this was looking at a combination of TVEC and ipilimumab. And you can see that the patients first got TVEC, and then after about 6 weeks, they got put on IPI. And you can see that a substantial improvement in CD8 count after IPI and also in CD4 with corresponding improvements in responses. And so there was clearly a synergistic response in this trial where patients who got IPI and TVEC did better than either alone. You can see these were in heavily pretreated melanoma patients, and you can see the waterfall plots showing some nice responses. And as always, so gratifying, a number of patients with substantial ongoing responses at 24 months. Granted, it's melanoma and it's an immune-sensitive tumor, but still the combination responses are gratifying. So all of this work led to us opening the STOMP trial here. This looked at patients with non-small cell lung cancer and triple-negative breast cancer. We've just enrolled our final patients, so we look forward to sharing the data down the road, but just to give you an idea of what the trial, these were either triple-negative breast cancer patients who had stage 4 disease that either failed 1 or more lines of therapy, or immunotherapy naive patients with advanced non-small cell lung cancer who were EGFR ALK negative or had been treated already, or they could have had 1 regimen of immunotherapy. They get adenoviral HSV-TK followed by valcyclovir for 14 days. They then get 5 treatments of SBRT over 2 weeks, and then they go on to Pembro. And we'll be using the immune assessment core here at the Houston Methodist Research Institute, where we'll be able to do mass cytometry with fluorescence cytometry, where we can get just amazing details of multiple populations of immune cells that you can see on the right. That kind of looks like something the Hubble telescope takes, but instead that's all just data looking at whole different categories and classifications of immune cells. And it'll be fascinating. You can see some of the data that we'll be able to generate looking at T-cell populations before and after SBRT and HSV-TK, and then we'll be able to correlate that with response or lack thereof. And just to show one case, This was our first lung cancer patient who went on to the trial. It was a female with adenocarcinoma. You can see on the PET she had a large right hilar mass that was bulky and hot. She also had adrenal metastasis. She did not have any driver mutations. You can see that the PD-L1 is 20%. So while not necessarily high enough for pembro single agent, you might have predicted that she would do well, but she did really well. She went into a complete remission, and now at 2.5 years later is continued, is off therapy, remains free of disease. Hopefully we're going to see more and more stories like that as we get more data, and we'll share as it becomes available. So our hope is down the road that the utilization of these oncolytic viruses to modify the immune microenvironment and turn these tumor hot will allow radiation therapists and oncologists to continue to be best friends as we continue to try to expand the benefit of immunotherapy for our patients. And that's what we're all hoping for. Thank you very much. Is there a question? I have to get my own question. That's it. Thank you guys very much. We're going to take a 20-minute break, and we'll resume in 20 minutes right here. Thank you very much. Welcome back. Our next speaker is Dr. Sanchita Roy Chowdhury. She's an associate professor in the Department of Pathology at MD Anderson Cancer Center. She did her anatomic pathology residency at the NCI, and then later a molecular genetics pathology fellowship at Memorial Sloan Kettering. She is a national expert on cytology, and she's going to discuss with us the cytology and management of small biopsies in lung cancer, and hopefully explain why pathologists are thoracic oncologists' best friend. We'll get started.
Hello, good afternoon, everyone. Thank you for being here. And while I wish this meeting was in person, I'm glad to be here virtually, and hopefully at the end of the session there's going to be a question and answer, and it'll be a little bit more interactive. So I'm a pathologist. I do cytopathology and molecular pathology at MD Anderson, and today I will be talking a little bit about the management of cytology and small biopsy specimens for lung cancer patients. So no relevant disclosures, and let's move on to the introduction, which is something that we are all quite well aware of, that the management of lung cancer has been constantly evolving, and in the last couple of decades it has definitely made a paradigm shift in how we diagnose and manage these patients. So from a pathology aspect, we have definitely moved on from being just collecting tissue for diagnosis or classification of lung cancer, but also being well aware that this tissue is being constantly needed for downstream testing for biomarkers that are critical for patient management. So biomarker testing for key analytes are now standard of care for lung cancer, and this figure gives just a snapshot of what we're currently doing in terms of managing these patients. Of course, there are the FDA-approved therapeutics, including the EGFR mutations, ALK, ROS1 rearrangements, BRAF mutations, NTRK, MET exon 14 skipping mutations, RET fusions, and then there are the more emerging markers and immune oncology markers that are being pursued in terms of providing different options for these patients. So there's a long list of things that we are required to do in pathology that will ultimately guide how the patient is being treated. And often the tissue that we are testing on are limited volume specimens, or otherwise known as your small specimens. And these would include your core biopsies, your FNA samples. And the reason we're getting these small specimens, of course, are because most of these patients are diagnosed at an advanced stage, so they're not getting surgically resected. And often, these are the only specimens we have available that are not just used for the diagnosis, but some of the biomarker testing that are required for treating them. So it's critical to be able to do all of our biomarker testing on these small specimens. Now, the important thing to realize is that small specimens doesn't necessarily mean it's an obstacle to biomarker testing, and these specimens actually provide excellent substrates for testing. However, it's also important to realize that there are multiple pre-analytic factors that come into play while the specimen is being collected or processed that can impact the tissue quality and the success of downstream testing. So just to emphasize what I just said, that small specimens doesn't necessarily mean they're an obstacle. So let's take a quick look at what we mean by small specimens. So these can be acquired by many different ways, and from a lung cancer specimen collection standpoint, these usually mean either percutaneous samples that are collected either by CT or MRI or ultrasound guidance, most frequently core needle biopsies or fine needle aspiration specimens, or they mean transbronchial endobronchial samples that would include your EBIS-guided FNAs, bronchial brushings, washings, lavages, and more recently we're getting these small biopsies. For metastatic lesions, we could also get ultrasound-guided endoscopic samples. Again, usually FNAs, sometimes small biopsies. And then there's your biopsy or aspirations that are done by palpation for more superficial lesions, punch biopsies from the skin, and then the effusions or body cavity fluid samples. So let's take a quick look at these small specimens and the different kinds of specimens that we get in pathology. So when I talk about the specimen type, we're either referring to the cytology specimen, which would include your aspiration ones, which are your FNAs, or your exfoliative ones, which would include fluids or washings. It also includes histology specimens, which is your usually core biopsies, forceps biopsies, any small biopsies. And then as far as the specimen preparation type, for your biopsies, it's always your FFPE specimen, as shown here at the bottom, the core needle biopsy, or your cytology specimens, which could come in many different flavors. You could have direct smears, you could have cytospin preparations, liquid-based cytology, and then your formalin-fixed cell block preparations. And the question always comes is that, should we get an FNA specimen or should we get a core needle biopsy specimen? And the debate continues in terms of which is a better specimen, which is superior, which gives you more material for diagnosis and biomarker testing. However, to me, these specimens typically are complementary, and each one has its advantage and limitation when it comes to biomarker testing. So taking a look at the biomarker angle, when you look at an FNA specimen, the main advantage you get is the fact that you're able to do a rapid on-site assessment on these specimens. So when you can do an on-site evaluation while the specimen is being collected, it is so much easier to get an adequate sample and triage it, and that's one of the biggest advantages you have when you do an FNA. The other advantage we have that not a lot of people are fully aware of is the fact that the sheer nature, the inherent nature of an aspiration is that you tend to aspirate more tumor cells and less stromal tissue. So your tumor fraction in an FNA sample tends to be much higher than you would have in a core biopsy. It's also something that doesn't get decalcified. So if you do an FNA from a bony metastatic lesion, there would be no decalcification, and so you get better quality nucleic acids. And then in general, if you are not using your cell blocks, but you're using anything that's a non-cell block cytology, so your smears, your cytospin preparations, your liquid-based cytology, all of those don't have the formalin fixation artifacts, and so you get much better quality nucleic acids. On the other hand, if you're looking at the core needle biopsy, it's a bigger needle, so you tend to get a little bit more tissue, so you get an overall higher DNA yield. As I mentioned, you tend to also get not just the tumor cells, but the intervening stromal tissue, the inflammatory component. So if you are doing biomarker testing where you need to assess for the stromal or inflammatory component, the core biopsy would be a better specimen to test. The added benefit is that since these are formalin fixed and paraffin embedded, you can get multiple sections, and those are easy when you're trying to validate or do diagnostic testing for your IHC markers or other molecular tests. So somewhat went over these different specimen preparation types, but just to re-emphasize, the different specimen preparations give you different advantages and disadvantages. And so if you're looking at core biopsies or cell blocks, which are both formalin fixed, paraffin embedded tissue, the biggest advantage, as I mentioned, is that you can get serial sections. These are easy to validate, and so just the ease of use make them the specimen source of choice in many molecular labs. The problem with these is mainly the fact that you are unable to do an adequacy assessment at the time of acquisition of the specimen. And so often they may have low amounts of tumor or no tumor or a lot of necrosis, and may not be adequate for testing. So the other problem is that you're fixing in formalin, and as I mentioned, those tend to give you lower quality nucleic acid. And then finally, when you're cutting sections, these are usually 4 or 5 micron sections, so you're not getting the entire nucleic acid content from the whole nuclei when you cut sections of cells. In contrast, smears from cytology give you the advantage where you can do an on-site assessment, you can ensure at the time of the procedure you're getting adequate material. Also, these are not formalin fixed, so you get better quality nucleic acid, and you're getting the whole cell with the entire nuclei, so you get a higher DNA yield content from these preparations. The problem with smears is that, one, you need the technical skill and the expertise on site to prepare the smears, process them accordingly, and then you have many different ways of processing, so there may be variable yields from these specimens. And then one of the biggest problems is that anytime you're using a non-standard preparation for any test, that needs to be validated in the molecular lab, and not all labs are validated to run testing on these alternative preparations. Also, the fact that once you use this specimen, if you're going to utilize one of the smears, you're going to destroy the smear in the process, so you'll have to sacrifice that from your file. So you have to ensure that you're either digitally archiving the slide or you have some representative material as for medical legal purposes. Same thing with the liquid-based cytology. These have the advantage that you have good preservation, you have good nucleic acid content, you get entire nuclei, better yield. But the problem, again, is, one, you can't do on-site assessments in these samples, so you kind of lose that advantage of the adequacy. And second, you would have to do an additional validation because it's not your FFPE sample. So let's move on to what I mean by biomarker testing in these specimens. So in a clinical setting, when we're talking about biomarker testing, we're either talking about the nucleic acid-based test, so DNA or RNA-based testing, or protein-based testing. And most DNA, RNA-based testing involves some kind of PCR amplification or sequencing, or in situ hybridization. The most common protein-based testing that we do in the lab is, of course, the immunohistochemical testing. And all of these tests are currently employed in biomarker testing for lung cancer. So as I mentioned, for the DNA, RNA-based testing, these are usually done by mutation analysis. Sanger sequencing had been sort of the gold standard for mutation testing several years back. In the beginning, when we were doing lung cancer molecular-based testing, we were using more single-gene testing methodologies like Sanger sequencing, pyrosequencing, capillary electrophoresis. And given the number of different things that we're testing now, if we're going to do single gene-based testing, we're pretty soon going to run out of tissue to test, given the sample sizes are small and you have limited volume to test. So around 2010, 2011, next generation sequencing came into play, where we are now able to use a multiplex platform where you can test multiple genes simultaneously, look for many different genetic alterations like copy number changes, mutations, all of that on a single platform, which has a pretty good sensitivity. So currently most of our mutation analysis is done by next-gen sequencing, but again, kind of depending on the institution and infrastructure of the practice you're in, you may or may not have access to that. So as I mentioned, for the DNA RNA-based testing, these are usually done by mutation analysis. Sanger sequencing had been sort of the gold standard for mutation testing several years back. In the beginning, when we were doing lung cancer molecular-based testing, we were using more single gene testing methodologies like Sanger sequencing, pyrosequencing, capillary electrophoresis. And given the number of different things that we're testing now, if we're going to do single gene based testing, we're pretty soon going to run out of tissue to test, given the sample sizes are small and you have limited volume to test. So around 2010, 2011, next generation sequencing came into play, where we are now able to use a multiplex platform where you can test multiple genes simultaneously, look for many different genetic alterations like copy number changes, mutations, all of that on a single platform, which has a pretty good sensitivity. So currently most of our mutation analysis is done by next-gen sequencing, but again, kind of depending on the institution and infrastructure of the practice you're in, you may or may not have access to that. The second thing I mentioned was insight to hybridization, and for the longest time, ALK and ROS1 fusions were being tested by FISH. The testing requirements for FISH are a little different than mutation analysis, where it's sort of assay dependent. You're not so concerned about the tumor fraction, but as long as you're able to recognize malignant cells by DAPI, that's all that's needed so that you can count the signals in the tumor nuclei. Both ALK and ROS1 are break-apart probes, so you're able to look for the probes in the malignant tumor cells. And lastly, biomarker testing by immunohistochemistry. Again, anytime we're using IHC for biomarkers that will be used for patient management, there is a critical need that these markers are validated appropriately. There are guidelines from the College of American Pathologists that guide how the analytic validation for these biomarkers are done. And currently we have antibodies for ALK, ROS1, the BRAF V600E mutation, PD-L1, NTRK, MMR proteins. So all of these, which are relevant biomarkers in lung cancer, can be currently tested using IHC markers. So multiple factors impact tissue quality. I've already mentioned that. And there are multiple steps in the process from when the tissue is collected in the patient till it's processed and we are reviewing it and then sending it for the downstream molecular testing analysis. And there are several factors in all of these different steps that play a big role in how that tissue quality will be and how it will behave for some of these tests. And while all of these steps, from the tissue acquisition to processing and handling and biomarker testing and interpretation, they're sequential, but they are all kind of interconnected. And I'm going to kind of highlight some of these factors that play a role in how the quality of the tissue impacts biomarker testing. So let's start with specimen acquisition. The first step is to collect an adequate sample. Biomarker testing works best when you have an adequate sample. And this is especially true in context of these small specimens because you have limited amounts of tissue to start with. So how do you collect an adequate sample? Well, for one, using an image-guided technique will give you a better diagnostic yield, because if you can see where your needle is and your needle is in the lesion, chances are you will collect a better sample with more diagnostic material. Now, I cannot emphasize enough that optimizing the technique in terms of what needle gauge to use, the number of FNA passes, number of core needle biopsies that you need to take, who is doing the procedure, the expertise of the operator. All of these little factors do come into play in ensuring that you're collecting an adequate sample. Now, the College of American Pathologists actually got together with various different professional societies that included pathologists, radiologists, pulmonologists, and molecular pathologists to come up with a guideline in terms of collecting and handling these thoracic small biopsy and cytology specimens for biomarker studies. And the guideline was just recently published in the Archives of Pathology and Lab Medicine, and I was fortunate to be involved in this whole process, and so I have put in the reference if you wanted to, if you haven't seen this yet, this would be a good resource to refer to in terms of collecting adequate tissue for these patients. And I will go over some of the recommendations, like the key recommendations that pertain to lung cancer, and how it impacts some of the testing we do downstream. So here's recommendations number 1, 2, 6, and 9, and all of these kind of pertain to the collection of tissue. So there's a strong recommendation for using EBUS-guided transbronchial needle aspirations when available for the initial evaluation, diagnosis, staging, for recurrence and metastatic lesions, for mediastinal and hilar lymph nodes, as well as centrally located parenchymal lesions that are visible with ultrasound. As far as EBUS procedures, needle gauges of 19, 21, and 22 can all be used. The 19 gauge needle, we had limited data, but showed similar yields as far as biomarker testing goes. As far as the transthoracic procedures, so this is your go-to procedure for anything, any peripheral pulmonary lesions. The needle size should be up to the operator and the technique, but based on the systematic review that we did of the literature review, needles as small as 25 gauge for FNAs and as small as 20 gauge for the core needle biopsies seem to give adequate yield for biomarker studies. If performing bronchoscopy for the peripheral lesions that are difficult to reach by conventional bronchoscopy, image guidance may be used if it's available to the operator. So overall, for all of these procedures, the use of image guidance, if available, is recommended. The second thing that came out of the guideline was the recommendations for the use of rapid on-site evaluation. The use of ROSE during an FNA procedure can ensure adequate sampling and the appropriate triage of that sample for downstream testing. So depending on what I'm seeing at the time of ROSE, we can triage the additional passes in anticipation for biomarker testing. So if I'm at an institution where my molecular lab will only test from blocks, I will minimize the amount of material on the smears and maximize everything into the needle rinse with the hopes of getting a good cell block that will be adequate for all the IHC, the molecular and FISH studies that I will need. So for example, here's a patient, 72-year-old female, has a history of lung adenocarcinoma, now has enlarging lymph nodes, suspicious for carcinoma, so they schedule a neck FNA for, and before they schedule the FNA, they also put in the requisition that this is for biomarker testing. Now, we do the FNA, I'm doing the rapid on-site, and I see this. There's no metastatic carcinoma, there's a monomorphic population of lymphoid cells. I'm worried about a lymphoid proliferation, so in a patient who's 72, possibly some kind of low-grade B-cell lymphoma. So I can kind of triage that tissue, and I can send it for flow at the time, and I can make a cell block so I can do the markers. I also recommend that they do a core biopsy if needed, and then based on what I have on my cell block or the core biopsy, We can do immunohistochemical markers. We have additional flow, and we're able to give a diagnosis of a low-grade B-cell lymphoma consistent with follicular lymphoma. So what I see at the time of the procedure at Rose kind of decides how I'm going to triage that tissue. So what are the recommendations that we have from this guideline pertaining to Rose? So recommendations 3, 5, and 10. So the first one is for EBUS TBNAs. Rose should be used if available. For transthoracic procedures, this is a strong recommendation that Rose should be used if available and clinically feasible. And if you are doing a core biopsy where there is no concurrent FNA, a touch prep may be used for adequacy assessment. As far as transbronchial needle aspirates, Rose should again be used for adequacy if available. And if you're doing a transbronchial forceps biopsy where there is no FNA concurrent, the use of touch preparations can be utilized to do the adequacy assessment. Additional guidelines that pertain to Rose and collection of adequate tissue for biomarker studies are recommendations 4, 7, and 8. So recommendation 4 states to achieve optimal diagnostic yield when performing EBUS TBNA without Rose, the bronchoscopist should perform at a minimum 3 and up to 5 passes if technically and clinically feasible. When performing with Rose, obviously, clinical judgment should be used to decide the number of passes. Additional passes may be required if you're doing ancillary studies. For transthoracic FNAs without a core needle biopsy, the recommendation is that the proceduralist obtains multiple passes, if possible, to collect enough material for a tissue block. And again, we talked about this at the beginning, that the ease of getting multiple sections from the block make it the substrate of choice for IHC markers, FISH, and other studies that can be that are needed for patient care. And then lastly, to achieve optimal diagnostic yield when performing transthoracic core biopsies, the proceduralist should attempt to obtain a minimum of 3 core samples if feasible. If it's clinically feasible, technically possible, additional samples can be taken if needed for ancillary studies. So far we've been talking about the specimen acquisition and collection part and how we can optimize these procedures to get the best sample. So let's move on to the specimen processing part next. So from the guidelines, we have 2 more recommendations that pertain to processing and handling. And these are recommendations number 12 and 13. The first is a strong recommendation that cytology specimens, which include smears, cell blocks, liquid-based cytology, may be used for ancillary studies as long as they're supported by validation studies. And then core needle biopsies, when collected for ancillary studies, should be fixed in 10% neutral buffered formalin. Why the emphasis on specimen processing is mainly because depending on how the specimen is processed, you can have quantitative and qualitative differences in not just the nucleic acid, but also the protein antigenicity. So if you look at an FNA procedure, you take a sample, you can put some of the sample onto a glass slide, smear it out, and stain it, but then you have the remaining sample in the needle, and there's like a dizzying array of choices that you have. Do you fix this sample in formalin? Do you put it in alcohol? Do you put it in one of the liquid-based cytology preservatives? If you're making a smear, do you air dry it? Do you alcohol fix it? So there's a multitude of ways you can process the specimen. And depending on how you process it, you may or may not get the most adequate amount of nucleic acid content. And here's a paper that I really like showing at different conferences, not to highlight what is the best way to process a specimen, but more to show that depending on how you process it, you may get quantitative differences in the amount of DNA yield that you get. And so in this study, the authors actually compared different methods of fixation using alcohol or air-dried, different kinds of preservatives, ethanol versus cytolite, versus cyto-rich red, which are like some of the liquid-based cytology preservatives, as well as the mounting medium that's used to cover slip these slides. And they showed that you can have varying amounts of DNA yield. And it's important because the DNA yield plays a big role in the success of some of your molecular testing that you will do on these samples. And it's not just the cytology specimen, that's also true for the FFPE samples, which are your core biopsies and your cytology cell blocks. And this paper actually highlights that there are multiple factors that actually affect your FFPE tissue. And some of the best characterized factors include ischemic time, how long it takes you to put the specimen into a fixative, how long you fix it in the fixative, and how you process it in terms of if it's a bone specimen, your decalcification, how you store it and embed it. And this nicely summarizes some of the findings in this review article in terms of the different factors and how they play a role in the quality of the DNA, RNA, and protein that we will be extracting from these tissues. And again, some of these are part of different guidelines that we currently have in terms of the ischemic time, how long you put it in a fixative. The recommendation, of course, is to always fix in neutral buffered formalin and not more than 72 hours. If you're doing a decalcification on a bone specimen, the recommendation is to use EDTA and not a harsh acid that will be incompatible with molecular testing. So moving on to the specimen selection and handling portion, again, this is critical because knowing what kind of specimen is being accepted by the molecular lab that you're using, what kind of criteria they use for specimen acceptance, what kind of tissue extraction strategies they use, what kind of platform they're using, all of these things actually are important in terms of deciding which is the best specimen for testing. So when it comes to reviewing a specimen and sending it for testing, there's a couple of things to keep in mind. One is the overall cellularity of the specimen. We're talking about small specimens here, so you're not going to have a ton of material. But the overall cellularity is important because this is what translates to the amount of DNA or RNA yield you will get out of that specimen. And a question that keeps coming up when we have a radiologist doing a procedure, they will always come and ask, we need these tests done on this sample, how many cells do you need? So I always say that a cell has about 6 or 7 picograms of DNA. So if you're going to do a test that needs like 1 nanogram of DNA, you need like 143, 166 intact cells. So an NGS assay, which requires about 10 nanograms of DNA, would need like about 1,500 intact cells. Now you need to keep in mind that, of course, when you're trying to scrape off cells from a slide, you're probably not going to get the entire cell, maybe not the entire nuclei. But in the ballpark, a few thousand cells is what you need for some of these assays. So the second important thing in terms of evaluating a specimen is the tumor cellularity, which is the percentage of tumor cells you have relative to all the other cells you have in the background. And this is important because this is what translates to the analytic sensitivity of the platform you're using for the molecular assay. So assuming most tumors are heterozygous, when you look at the tumor sample that has about 40% tumor, so 40% of the cells have tumor cells, only 20% are mutant alleles in the specimen. So you need a test with a sensitivity of at least 20% to reliably pick out that mutant allele. So the lower your tumor fraction, the more sensitive your test needs to be. So if you have a sample that has a 10% tumor cellularity, you need a test with a 5% sensitivity to be able to pick that mutant allele out. So the analytic sensitivity of a platform is basically the lowest limit of detection of the assay. And so when you have a specimen, there's 2 ways of handling it. One, you can modulate the test platform to match the specimen at hand, or you can modulate the specimen to match the testing platform. So how do you modulate the testing platform. So basically you select a platform which is a high sensitivity assay to evaluate specimens that have low tumor fraction in the specimen. So for example, here on the left you have a melanoma sample. Pretty much all the cells in here are tumors, so your tumor fraction is really high. This assay sensitivity is not really an issue here. However, the tumor on the right, you have tumor cells, but they're dispersed among a lot of benign cells, so you have a low tumor fraction samples. So it's critical for a sample like this to get tested on something that's a high sensitivity assay. Otherwise, you run the risk of a false negative result. So to show an example of how this matters, I have a case here that was highlighted to me because this patient has a known EGFR mutation. It's a lung adenocarcinoma patient, was on tyrosine kinase inhibitors, and they were clinically suspecting resistance. Patient had presented with a new pleural effusion, and they wanted us to test the effusion to see if we could pick out the resistance mutation. And I get a call that says that, hey, what happened? Because the test results came back and it says there's no mutation detected. But we know this patient has a known EGFR mutation, so what went wrong? If you look at the path report, it says like PCR-based analysis. So this was done by Sanger sequencing, which has one of the lowest sensitivities. Like you need at least like 30–40% tumor in a sample to be able to detect a mutation by Sanger. And this was tested by Sanger, so obviously this result was a false negative result. So we took this sample and we reran it on our next-gen sequencing assay. And not only were we able to see the EGFR exon 19 deletion, which was the known sensitizing mutation in this patient, as seen here on the left, we were also able to detect the T790M mutation, which was the resistance mutation that they were worried about clinically, and that was present in the sample at a lower, in a subclonal population at a lower allelic frequency. So it's critical that we pick the right platform when we're testing some of these samples, especially when you have a low tumor fraction sample. One of the ways to do it is to try and enrich for tumors. So if you have a sample like this where you have tumor, but you also have a lot of benign cells, we try and circle an area that's enriched in tumor to increase the tumor content and exclude areas that have a lot of benign cells that would dilute the tumor content. So the last thing I wanted to mention is how best to triage these small specimens. I mentioned that there is always this debate about whether to do a core biopsy or an FNA procedure, but in my opinion, these are complementary procedures. There are advantages to each of these techniques, and we can use them to our advantage when it comes to biomarker testing. At our institution, we reflex most of our tests, the biomarker testing, to our histology specimens, so on the core needle biopsies. And if we have a patient sample where it's inadequate on the core biopsy, or we don't have a core biopsy, we reflex that test request to the cytology specimens. So we did a study where we looked at the number of cases that we tested using our cytology specimens, and about 30% of the cases were because the core biopsy was inadequate for testing, and most of these samples we were able to get all the biomarker testing that was requested, which goes on to show that, if possible, do both, get a concurrent FNA and a core biopsy so that you can use both samples, especially in this current scenario where we have to do biomarker testing on so many different, for so many different markers, that it makes sense that we would combine these specimens to be able to get you the results that are needed. So to highlight that, I have this specimen here, lung adenocarcinoma sample that came in for biomarker testing for lung cancer. And here's the core needle biopsy. And as you can see, most of it was kind of necrotic and fibrotic, no tumor cells. And off on the edge of one of the little cores was a little bit of tumor. Here's the concurrent FNA specimen. You have the cell block on the left and the smears on the right. And here's the list of biomarkers that were requested on this patient. So they wanted us to do the NGS mutation analysis for EGFR, BRAF, and KRAS, FISH testing for ALK-ROS1, RET, and MET, and then IHC for PD-L1, MSI testing, a lot of different things. And here we have this limited amount of tissue. So if I had to triage this specimen, this is what we would end up doing. So you have the mutation assay, FISH, and IHC. You have the core biopsy, the cell block from the cytology, and the smears. So given the limited amount of tissue we have on the core biopsy, I would probably triage this for my IHC markers and FISH testing, because for PD-L1, we only need about 100 cells. You can get serial sections cut from this block, and you can use it for the 4 FISH assays they have asked for. And then for the mutation assay, I would use the cell block or the smears, both of which are abundantly cellular, have really good tumor fraction, and would be more than adequate for the NGS assay that we would do. The other key thing to remember is that communication is key. We need to have a clear communication between the oncologist who is ordering the test, the radiologist, the lab techs who are preparing the specimen, and the pathologist. Because the last thing you want is to have a specimen like this that you need for biomarker testing, and then the diagnosis is made, and then they ask for the biomarker testing, we recut the block, and this is what's left on it. So if we know upfront what is being requested of the specimen, you can probably cut unstained sections right up front without having to reface that block. And so communication is a critical part of this whole biomarker testing scenario. So in conclusion, what I wanted to highlight is that small specimens are not an obstacle for testing. However, there are multiple factors that play a role in how that tissue is collected and handled and how it will behave for downstream testing. And so appropriate triaging of the tissue and handling of the tissue can improve the success of biomarker testing. And to do that, we have to be part of the clinical team to be an integrative diagnostician. So you have to have the clinical, radiologic, molecular, and pathologic correlation to be able to put all of these little components together and get the best biomarker testing for the small specimens that we typically get for lung cancer. So thank you so much for being here today. Stay safe, and I am happy to answer any questions that you have. Thank you.
Great. Thank you. That was wonderful and very comprehensive. And we do have 2 questions for you. The first one, is there a difference? Can you hear? Is there a difference between EBIS and a CT-guided biopsy in terms of yield?
In our experience, we haven't seen that much of a difference. We did a study where we looked at the yield in terms of biomarker testing, and as far as FNAs go, they were very similar. We did a recent RNA-based study, and in that, there was a little bit of difference in terms of the results we had between the core biopsies versus the FNAs, but as far as when we compare the FNAs, they're very similar.
Great. And is rapid on-site assessment practical in smaller community hospitals, and can AI help?
So this is a very contentious topic. I mean, if you ask 2 pathologists their view on the use of rapid on-site assessment, you'll get 2 different answers. And part of it has to do with that it's a tedious procedure. It's not well reimbursed. So it's resource intensive in terms of time and the personnel. And so if you ask whether it helps with getting an adequate sample, yes, it does. But there's no question about that. The problem is that as you mentioned, like in smaller hospitals, they may not have the infrastructure to do that for every single procedure. So the CAP guidelines, when we were focusing on how do you collect for ancillary studies, what we recommended and what the expert opinion was that in cases where you anticipate that there will be a requirement for biomarker studies, if you have it available, to utilize it, because you want to make sure that in that first try that you get an adequate sample and you don't have to resort to doing a repeat biopsy. But yes, it is problematic to have a person doing it at the time of the procedure. A lot of places have started using telepathology, so even if the person is not there physically, you do the procedure, they make the slides, and we actually are doing it at our institution for some of the satellite locations, because there's not that many procedures to have a person there full-time during the procedure, but we look at it on our computer while the procedure's going on. But yes, you need somebody at, real time to be able to do that part.
Fascinating. That's great. Thank you very much for your time and expertise. We really appreciate it. Thank you.
Thank you for having me.
Sure. We're going to take a 5-minute break, and then after the break, we're going to have, we had a number of abstracts presented for the symposium. We selected 3 for oral presentations, so when we come back, we'll hear those 3 abstracts. So you won't want to miss it. We'll see you in 5 minutes. Thank you.
Welcome back. I hope everybody had a chance to visit our virtual abstract room as well as the virtual exhibit hall. It gives me great pleasure to introduce our next speaker. This year we have 3 abstract winners, and they will be giving a presentation of their work. Introducing Dr. Nan, who's a research fellow with the Systems Medicine and Bioengineering Department here at the Houston Methodist Cancer Center Research Institute. She's going to talk about their research regarding systematic characterization of ovarian cancer-derived exosomes, unveiling RNAs interfering with CD8 T cell activation. Dr. Nan.
Hello, everyone. I'm Xianan from Houston, from System Medicine and Bioengineering. And thank you for the opportunity to share our work with you today. And the work was systematic characterization of ovarian cancer-derived exosomes, unveil miRNAs interfering with CD8 T cells. Okay. The high-grade serous ovarian cancer is a very lethal, advanced cancer, and it causes more than 13,000 deaths annually in the United States. And the current treatment for this cancer have limited results in the kind of advanced cancers. And as we know, CD8 positive tumor infiltrating lymphocytes has been widely reported to correlate with the cancer patient survival, and including this ovarian cancer. But even with the presence of the TILs, the immunotherapy has limited success in the cold tumor. Understanding the interaction between the CD8 T cells and the tumor microenvironment is very important, since the microenvironment in the tumor and organs, as we know, it's very complicated. It's ranging, from the signaling molecules to network pathways, and from the subcellular components to the cells of the tumor microenvironment and the organ system, all of them tangled together. So we need to generate a systematic method to guide our studies. And among all those factors I just mentioned above, and our previous findings that's found that the tumor-derived exosomes can affect CD8 T cell activation via mRNAs. Thus, we have a hypothesis here, and the hypothesis is the specific mRNAs within this tumor-derived exosomes can affect CD8 T cell activation. And in turn, it will correlate with the HG-SOC patient survival. And there is a paper that published in 2017, and they included more than 3,000 patient samples to stain with the traditional IHC staining, focusing on the CD8 TILs and the survival time. They have a correlation. They found out that CD8 tumor-infiltrating lymphocytes correlate with the patient survival over there. And as these figures showed, in their study, they catalog the patients into 4 different groups for the based on the T cell density. It's high, moderate, low, and negative. And we can see that the survival rate increase when there is more TILs in it. And also reveals that even in a cold tumor like ovarian cancer, 80% of the patients have positive, CD8 positive TILs, but the response to the immunotherapy remains low. And this indicates that there is an immune suppression microenvironment inside the tumor. And about this study, one concern is that they use traditional pathology method to just focusing on the CD8 T cells. And but we know that in microenvironment, in the tumor microenvironment, there's a lot of more cell types involved in. So is the CD8 still going to be the most significant ones, which correlate the survival if we, do a more comprehensive study of that? That's why we conduct the imaging mass cytometry, MCA analysis. And this is a more comprehensive method that can validate the conclusion just previously we mentioned. And here we include 48 ovarian cancer patient samples here stained with 21 iron-labeled antibodies and generated high-dimensional imaging and do the analysis. And finally, we got a correlation of different cell types and the survival time. And here is the workflow for this one. And after this study, we found out that even with multiple cell types, CD8 T cells still the most, significant cell population that are associated with patient survival. And here is the study of cell density. We can see it's just a representative images. We can see there, obviously, we have a lower CD8 T cell density in the short-term survivors. And here is the long-term survivors. And not only the density indicates the results, but also we also count the total cell counts in tumor regions. We found that in the long-term survivors, we also have a higher count of the CD8 T cells. And then we do a staining. Then we do a staining strategy. We can see this is the co-stain of the carotene 8 and the CD8 and a granzyme B. And for the short-term survivors, we don't see any staining over here, co-present of the antibodies. But for the long-term survival, look at the white arrows here. It indicates that confirmed activated CD8 T cell are associated with the patient survival. Thus, we decided to use interferon gamma protection in the following screening strategy to see how the cells are activated. And before we go forward, we just here I just love to have a brief introduction of the exosomes, and we can see here the exosomes it's a kind of membrane vehicle secreted by many cells, including the tumor cell, and this one is the a typical structure of the exosomes. It's a phospholipid bilayer. It has protein, DNA, RNA packed inside, and the size is from 30 to 150 nanometers. And the exosomes from the donor cells can transport and deliver large cargoes to the recipient cells, and further release the DNA, RNA, or protein, whatever in that, and in the recipient T cells, and result in modifying the recipient cell phenotypes. And here in our case is that this specific mRNA contained within these exosomes can modulate the inhibition of CD8 T cell activation. And here is the tumor-derived exosome inhibition CD8 activation screening. This is our screening strategy. We can see we co-incubated the exosomes, the activator, and the CD8 T cell together for 72 hours and do the ELISA test to see the interferon gamma expression level change. And for this screening, we just want to find a candidate which can have a consistent effect on the CD8 T cell activation. And here is the 9 exosomes that we are using in this study, and this is the nanosite quantification results. Well, after 3 rounds of screening across multiple donors, that we find out this the exosome derived from PE01 and OVCA432 have consistent polarized effect on the CD8 T cells. We can see this is the interferon gamma expression change percentage. The PE01 is always below the baseline, and the OVCA432 is always above the baseline. In this case, we just compare the MI profiling data of these two, and we finally can narrow it down to 56 microRNAs. And finally we find out just 13 out of this 56 has been reported, and they have like 210 target mRNA in the recipient cells, And here we can see the list of the table is the 13 microRNAs we find here. If we look at their targets, we will find 12 out of the 13 have targets related to the immune signaling pathway or to the cell cycle pathway. And we found one from this one. We found it particularly interesting. It's because for the MIR181A is the only one which can overlap from our list and overlap with the list of our collaborators, which they generated like a miRNA signature list, which generated from the microdissection data. And not only this one, and not only it is the only overlap one, but also we found out it's another miRNA, it's MIR181C. It's the same family with this one, has been reported to have an increased production in HGSOC cells and increased exosome transfer to T cells, and which leads to a lower interferon gamma production. And since they are the same family, so we guess they might have the same function as well. We're still working on the microRNA list over there, but this one seems a good candidate to chase in future. And speaking of the target mRNAs, we also do a pathway analysis of the target mRNA, and we can see among the top 20 pathways. Most of them are immune-related or cell cycle-related. The results of this pathway analysis just greatly support the screening results we just produced. And here is our ongoing work. Our ongoing work includes co-efforts of the dry lab and wet lab, and we will generate more genetic data from the recipient T cells. And we also want to combine with public multi-omics data and clinical data to guide wet lab experiments. We hope to narrow this down to a particular mRNA or a particular list of mRNA or pathway related to the CD8 T cell activation inhibition. And then we plan to validate the in vitro and in vivo animal studies. And here's some summary. First, we build up a novel analyst and a modeling pipeline for MC images. MC image is a new technology. The pipeline, Ying has done a lot of efforts. Thank you for her fundamental work here. And then they find out during the MC analysis, they find out the cytotoxic CD8 T cell population is still the most significant population subtypes that correlate with the survival. And then the exome-derived exome screening strategy, screening results just review the exosome from PO1 and OVC432 has consistent polarized efforts on the CD8 T cell activation, and compare the mRNA profile between these two, reviews 13 miRNA candidates, which target 210 mRNAs. And the pathway analysis of the target mRNA support the screening results as well. And our further work is to use systematic biological methods to predict the promising signaling pathway, which can interfere with CD8 T cell activation. And following with the wet lab validation, including in vitro and in vivo study, to proceed the mechanism research as well. And I would like to thank you my lab, thank you my boss, Dr. Wang. Thank you for his guidance and encouragement in this work, and thank you for our collaborator, Dr. Sam Mok. And also thank you for the lab member Jianting Ying and Xin and Shan, and also our collaborator from MD Anderson, Dr. Sammy and So. And also thank you for the funding support as well. And at last, I would like to thank you. Thank you for your time and attention. Thanks.
Great, that was wonderful. And no questions, so you dodged a bullet. Very interesting. Thank you for that presentation.
Thank you.
Presenter set up. This is Dixita Viswanath, who's an MD PhD candidate from Texas A&M University College of Medicine. She's working in the laboratory of Dr. Catoni in the Department of Nanomedicine at Houston Methodist Research Institute. And she'll be discussing the development of an implantable artificial lymph node as therapeutic cancer vaccine. Okay, you're good.
Hi all, good afternoon. My name is Dixita Viswanath. I'm an MD PhD student from Texas A&M and my second year of PhD. And today I'm going to talk to you about my thesis project, which is the development of an implantable artificial lymph node as a therapeutic cancer vaccine. Cancer vaccines are a form of immunotherapy, which we use the machinery of the immune system to find and kill cancer cells in situ. There are many different forms of immunotherapy, a lot of which that have reached landmark successes, including adoptive T-cell therapy. Now, when we think about cancer vaccines, we often think about the first word, vaccine. We think about preventable vaccines often given for an infectious diseases population. In a vaccine, we aim to induce a durable memory response against any and all presented antigens. These preventative vaccines are often given before a person acquires a virus or an infection in order to prevent the acquisition of this infection. There's a lot of work right now about creating a coronavirus vaccine, for example. On the other hand, therapeutic vaccines are given in a sick population, in a population that already has a disease of interest, and is given as a form of therapy in order to prevent the spread of this disease. They're often given for chronic diseases such as cancer, HIV, and Alzheimer's, and as a result, they can be highly personalized using a patient-specific antigen in order to create a patient-specific response. Cancer vaccines are not new. They've actually been around for decades. Spicule T, or Provenge, is the very first cancer vaccine that was approved by the FDA in 2010. It demonstrated high efficacy in clinical trials, but it lacked clinical feasibility and clinical translatability due to its complicated multi-step treatment process. This limited accessibility and provided a high cost burden to all patients nationwide and worldwide, leading to bankruptcy and withdrawal of authorization within 5 years. In order to create a clinically viable vaccine platform, we developed the nanolymph that allows for spatial temporal elution of immunostimulants for dendritic cell activation locally and activation of anti-tumor immunity systemically. We wanted to obviate many of the observed problems within current vaccine platforms by providing a 3-step routine. First, the nanolymph will be implanted subcutaneously within a patient to recruit and activate dendritic cells in situ. Second, the nanolymph will be loaded transcutaneously and minimally invasively with personalized tumor antigens isolated from a tumor biopsy. Lastly, the nanolymph will initiate an immune response both to the primary tumor and to any sites of metastatic origin. A clinically translatable vaccine must address 5 key components. They must be bioinert, biocompatible, personalizable, refillable, and minimally invasive. And you'll see throughout this talk how we try to address all of these key components in order to create our vaccine platform. First, let me walk you through the structure of the nanolymph. The nanolymph has 2 key components. First, there's an immunostimulant reservoir highlighted in blue, where immunostimulants are placed in are solubilized and placed within the reservoir. These immunostimulants include GM-CSF, which is a cytokine that matures dendritic cell, and toll-like receptor agonists, which allow for maturation and activation of dendritic cells. Second, in the center, there's a tumor antigen reservoir encased within a macroporous hydrogel. This allows for personalized antigens to be placed within the reservoir and allow for continuous infiltration within dendritic cells. Lastly, the entire 3D printed structure is sealed with 2 dual silicon ports, allowing for transcutaneous refill and for further treatment. The immunostimulants are eluted through a nanoporous membrane, which are affixed with medical grade silicon on both sides. Additionally, the entire structure is wrapped through 2 dual nylon meshes to allow for structural stability and allow for cell infiltration. We envisioned the nanolymph to work in a 4-step process. First, the nanolymph will be assembled and loaded ex vivo with immunostimulants and tumor antigens. Secondly, the nanolymph will be placed subcutaneously and initial interactions will take place, allowing for dendritic cells to be attracted to the device. Third, the tumor antigens that reside within the hydrogel will interface directly with the dendritic cells that come within our device. The dendritic cells will then become activated due to the presence of immunostimulants and these tumor antigens. Lastly, these activated dendritic cells will be able to leave our device and migrate systemically to local lymph nodes or the spleen, for example. In order for a bio-inert medical device to occur, we must allow it to have structural stability. Therefore, we assess the degradation of all the key components of the nanolymph over time, and we observe no significant weight change over time in both the simulated physiological condition and accelerated condition. This acceleration allows us to study a period of 1 year over a short period of time. We also took SEM images of all the components of the nanolymph at certain time points, and we observed no structural changes between day 0 initially and day 55, which corresponds to a year of accelerated time. Next, we must determine if the nanolymph is non-toxic. We performed a series of MTT cytotoxic assays in accordance to the ISO protocols for 3 specific murine cell lines that will interface directly with our nanolymph. We showed no significant change in cytotoxicity, and it actually induced proliferation of certain cells due to our nanolymph extract. With all this in mind, we then placed the nanolymph on the backs of mice, B6 mice. And here on the bottom left, we see a mouse with a nanolymph on day 24. The mice are very healthy. They're able to move very well. They're eating well, they play well, and they have no significant burden due to our device. In order to test refillability, we used a 3-needle approach. 2 needles are used for loading and venting the immunostimulants respectively, and a larger 3rd needle is used to refill the hydrogels within the center of the device. So in the middle, you can see the 3 needles. All are smaller than 20 gauges, which is smaller than an insulin needle, and most are smaller than an insulin needle. Previously, our lab has demonstrated that this transcutaneous refill procedure works through a series of IVUS imaging tests. IVUS allows us to detect fluorophores within any small animal structure. And on the bottom right, you can see that prior to refilling, there is still drug within the reservoir. We flush it with saline, and all the drug has dissipated. And lastly, when you refill it, all the drug is still within the device. Therefore, we believe that our refill strategy is efficient and clinically translatable. These mice that received the controlled nanolymph exhibit a normal weight change, and they grew normally in accordance to clinical industry standards. In addition, mice that had immunostimulants loaded within the nanolymph exhibited the same weight change. We measured temperature as a measure of systemic immunity and systemic toxicity, and we demonstrated no significant change in temperature. Lastly, we performed histological analysis on the subcutaneous space where the nanolymph once resided. So on the bottom left, you can see a gross histologic specimen at 4x. At the top, you'll see the skin and the hair follicles. The white space in the middle is where the nanolymph once resided, and at the bottom, you'll see the musculature layer. On the bottom right, you'll see a more zoomed up image of this histological specimen at 20x magnification. And while we do note some evidence of fibrosis, we don't notice any significant fibrosis that would impede our medical device from functioning. Lastly, our second question, after bioinert, biocompatible, minimally invasive, and clinically translatable, is efficacy of our device. We needed to know the amount and concentration that was optimal of immunostimulants to load within our device. We performed a series of experiments in vitro using a transwell. So essentially, cells are placed in the top layer in appropriate media and are placed in a series of different conditions with different concentrations of GM-CSF and resmetiquab, which is a toll-like receptor 7 and 8 agonist. For GM-CSF, we noted that 20 nanograms per mil was an optimal concentration and proceeded with that for the rest of our experiments. Our second question was to determine which hydrogel should be used. Now, we have a lot of different opportunities for hydrogels. Many are biocompatible and many are commonly used. The two most commonly used are alginate and pluronic. They're used widely in medical devices and have been proven and approved by the FDA. Therefore, when we assessed these and compared these two devices, we noted that there was a higher cell viability within the hydrogel as opposed to pluronic or different concentrations of pluronic. Lastly, we performed a similar titration experiment using resmetiquab, which is our second immunostimulant. In this experiment, we allowed cells to be co-cultured with resmetiquab and ovalbumin, which is a model antigen labeled with FITC, a model fluorophore. We hypothesized that when cells interact with resmetiquab, they will be able to uptake the antigen and present it more efficiently. Therefore, they will be OVA positive. And we can detect this using flow cytometry. We noted that 500 nanograms per mil was the optimal concentration to detect the highest amount of OVA positive dendritic cells. With all of this together, we implanted mice with the appropriate concentrations of immunostimulants for 14 days, and we allowed the mice to interact with each other and interact with our device. Upon explantation, we can see that the device is still fully filled, and we can even see some evidence of vascularization on the bottom left, which allows us to believe that immune cells are being trafficked directly to the site of our device. We then processed the tissue within the hydrogel and compared the different population of cells within the hydrogel. And we were really excited to find out that a lot of in comparison to control, nanolymphs that contain immunostimulants have a significant increase of activated dendritic cells within our device. So in conclusion, we proved today that the nanolymph is bioinert, biocompatible, structurally stable, non-toxic, and is straightforward to use, making it clinically feasible and easily personalizable. We demonstrate that the nanolymph is a promising system for personalized therapeutic vaccines. And in the future, we will test the nanolymph for antigen presentation in vivo and determine its efficacy in a tumor-bearing mouse model. And with that, I'd like to thank my entire laboratory for all of their support and the core facilities at the RI and my MD PhD program. And I'll be able to take any questions if you have them.
No virtual questions, but I'll ask.
Yes.
So in terms of what you're able to, so you're using like GM-CSF, but there's no reason why you can't fill it with other immune checkpoint drugs, or there could be a whole playground of stuff that you can put into this eventually.
Definitely, yeah. And so that's actually one of the key parameters of the nanolymph, and it's key innovation that we can easily use this for any release of any kind of molecule or any kind of drug. And so there are a lot of different applications of the nanolymph, one of which is a therapeutic vaccine. We can use this to present any long-term vaccination, such as an allergy shot or anything like that.
And how big is it?
In full size for a mouse, it's about 1 centimeter long by 1.2 centimeters wide.
So theoretically, one day you can theoretically put it in the brain. For a GBM, you can down the road put it in a cavity where a tumor is removed.
Definitely, yeah. There are a lot of different applications. Right now, we're studying one specific cell line of interest, but right now we're trying to develop the technique. But there are a lot of different applications beyond just cancer vaccines.
I'm not trying to get too far ahead of the science, but nevertheless. Yeah. Okay, great.
Yeah, any other questions?
Thank you very much.
Of course, thank you.
And then for our final presenter, we have Andrew Chung, who's an MD PhD candidate from Texas A&M University College of Medicine, who's in the laboratory of Dr. Jenny Chang at Houston Methodist Cancer Center. And he'll be discussing the abstract evaluating the efficacy of TOSI for a subset of triple-negative breast cancer that resists chemotherapy via an autocrine IL-1A mediated self-induction of IL-6. Thank you very much.
All right. Thank you all for having me. I'm sorry the title was so long. I wish I could make it shorter. My name is Andrew. I'm in Dr. Jenny Chang's lab with the Houston Methodist Cancer Center. It's a pleasure to be presenting. So I recognize most of the audience are very well versed in triple negative breast cancer or TNBC. So just real quick, these cancers are low expression for hormone receptors and the epidermal growth factor receptor 2. In short, patients with TNBC, they typically do not do well with standard chemotherapy, and they have high rates of disease recurrence and cancer metastasis. And this is highlighted by a consistent, very grim 5-year prognosis for patients with metastatic disease. So in order to actually provide clinical benefit for our TNBC patients, we really need to get a better understanding of the cellular biology of the TNBCs, because TNBCs is a very heterogeneous type of cancer. It's not just one uniform type of cancer cell. So in order to develop novel targeted therapies, we really need to understand the biology a lot better. Having said that, to accomplish this, I am presenting one background slide on previous work done by others, where essentially they obtained hundreds, about 500 different TNBC patient tumors, and performed microarray studies, and taking the gene expression profiles. These TNBC tumors were grouped by k-mean clustering based on their differential gene expression into the 6 unique subtypes that you see here at the top. And what I'm showing are basically the canonical pathways that are predicted to be upregulated in 2 particular subtypes. For the sake of time, I will not actually be discussing all 6 subtypes that the authors found, rather just the 2 subtypes that's more relevant to my talk. The first subtype is the basal-like 1 or BL1 TNBCs, and basically they have a gene expression profile that's highly upregulated in cell cycle, cellular division. In contrast, another subtype, the mesenchymal stem-like or MSL TNBCs, they have gene expression profiles that are very similar to cancer stem cells, angiogenesis, epithelial mesenchymal transition. And one canonical pathway that I highlighted in this red box is an inflammatory pathway, the NF-kappa B pathway. I just want to point out, although the authors made this discovery, they did not discuss the relevance of inflammation to mesenchymal stem-like TNBCs, nor did they ever follow up on this. So this was just kind of left hanging right there. Now, to actually validate that the original author's subtyping method had any type of clinical relevance, what I'm showing here are 2 independent follow-up studies where both groups, basically following the original author's methodology, they subtyped their TNBC patients and then determined if there was any differential efficacy to conventional chemotherapy. And quite consistently, both groups found that the BL1 subtype, which again has canonical pathways in cellular division, cellular proliferation, patients with the BL1 tumors had the best pathological complete response after chemotherapy, whereas the MSL TNBC patients, they typically had one of the worst pathological complete response after chemo. So in assembling my graduate thesis project, given how the MSL TNBCs are chemo-resistant and they have this not well elucidated inflammatory pathway, the NF-kappa B pathway, I basically propose to investigate whether the MSL TNBCs may utilize inflammation or autocrine cytokine signaling to resist chemotherapy. And in contrast, I used the chemo-sensitive BL1 TNBCs, which lack any inflammatory gene signature, therefore they won't be able to resist chemotherapy via any type of inflammation. Okay, so switching over to my data, basically what I'm showing here is I took 4 different MSL human TNBC cell lines and 4 different basal human TNBC cell lines and performed RNA sequencing analysis. And I analyzed the gene expression signatures that are up in the MSL TNBCs compared to basal TNBCs. And then I uploaded it to an online software tool called Ingenuity Pathway Analysis. Basically, I asked Ingenuity, could it predict for me of the gene expression profile signature that is up in mesenchymal? Are any of those, is any of that transcriptome data could any of those be an upstream regulator for that gene signature in MSLs? And what I highlighted here is basically IPA predicts that the IL-1 cytokine is predicted to be an upstream regulator in the MSL TNBCs. And as you can see, both IL-1 beta and IL-1 alpha, the red arrow indicates that the gene expression transcriptome data is indeed up in MSLs compared to basals. Now, for the sake of time, I'm going to just skip right ahead to my confirmatory study where I actually validate the RNA sequencing. So before I do that, I just want to explain real quick what docetaxel is. Docetaxel is a member of the taxane family, and docetaxel and taxanes are one of the frontline choices that's given to TNBC patients in the clinic. So for both my in vitro and in vivo models, I'm using docetaxel. And as you can see with the MSL TNBCs that are highlighted in red, in response to docetaxel therapy in vitro, they produce inflammatory mediators after chemotherapy. IL-6 goes up, IL-1 alpha goes up, and COX-2 goes up. In stark contrast, this phenomenon does not really occur in the basal TNBCs highlighted in green. They make no IL-1 alpha. COX-2 really does not change afterwards. And in regards to IL-6, it's either inconsistent production or very modest production of IL-6 in respect to their MSL TNBC counterparts. So here, after establishing, okay, after chemotherapy, mesenchymals, they make more inflammatory mediators. Thinking back to the RNA sequencing data I showed previously, where the software told me that IL-1 alpha could potentially be an upstream regulator, this is where I test if that is true. So taking 2 different MSL TNBCs that were treated either with docetaxel alone, docetaxel with a irrelevant isotype control antibody, or docetaxel with a IL-1 alpha neutralizing antibody, neutralizing IL-1 alpha led to significant reduction of IL-6 following docetaxel therapy in these 2 cell lines. Likewise, you see that same trend with prostaglandin E2 production, which is the main metabolite produced by COX-2. And again, you see the same trend with IL-8. The reason I looked at IL-8 is TNBCs often, it's a report that TNBCs produce IL-8 in conjunction with IL-6 for their tumor resistance mechanisms. That's why I looked at IL-8. Now, previously I showed that the basal TNBCs, they produce no IL-1 alpha following docetaxel therapy. So I raised the question, okay, if I were to give them IL-1 alpha, is that sufficient to make them more inflammatory? And the answer is yes. Looking at 2 different basal TNBCs, simply just by treating them with recombinant human IL-1 alpha is sufficient to induce IL-6 production. Likewise, it's sufficient to induce IL-8 production. So just to recap very briefly, the mesenchymal TNBCs appear to, in response to docetaxel therapy, initiate an inflammatory cascade where IL-1 alpha is the upstream cytokine that's responsible for all this. Now, in this slide, I'm basically investigating what is actually the signaling pathway that's responsible for producing IL-1 alpha in mesenchymal TNBCs in the first place. After ruling out it was not due to NF-kappa B or AP1 activation, I discovered that the pathway is by the MAP kinase pathway, which was actually surprising to me since MAP kinase pathway is typically thought to promote cellular proliferation. But in fact, what showing the data right here, docetaxel will actually lead to activation of MEK1 and 2, which will in turn phosphorylate and activate ERK1 and 2. And this in turn will activate a transcription factor that will lead to production of IL-1 alpha and so forth, inflammation. So what I'm showing here is PD-O3 is a MEK inhibitor. So if I'm taking out this step right here, again with the MEK inhibitor, in the presence of docetaxel or even in the absence of docetaxel, by shutting this down, this will lead to a significant reduction of IL-1 alpha, again, in 2 different MSL TNBCs. And by shutting down IL-1 alpha, it likewise leads to reduction of the more downstream cytokine IL-6. And this is just a Western blot to confirm that by shutting down MEK1 and 2, I am indeed preventing the phosphorylation and activation of ERK1 and 2. So again, the MEK inhibitor in the presence of docetaxel or absence of docetaxel will lead to decreased phosphorylation and activation of ERK1 and 2 in the 2 different MSL TNBCs. Okay, so in summary, what I found is, okay, great. Mesenchymal TNBCs, after docetaxel therapy, they'll have hyperactive MAP kinase pathway activation and lead to inflammation. How can I actually make this relevant for TNBC patients? Well, so one of the inflammatory mediators that mesenchymal TNBCs produce is IL-6, and IL-6 is very well studied, not only in TNBCs, but in all cancer biology. IL-6 is implicated to promote cancer cell proliferation, cancer stem cell induction, cancer metastasis. So in designing this project, targeting IL-6 in mesenchymals seemed like an ideal targeted therapy approach. So to do this, I obtained tocilizumab with the trade name Actemra, which is FDA approved for various arthritis pathologies, and is a humanized anti-IL-6 receptor antibody. And to investigate the efficacy of supplementing tocilizumab to docetaxel therapy, what I did was basically implanted non-obese SCID IL-2 gamma receptor deficient female mice, abbreviated as NSGs. Basically, these NSG females are severely immunocompromised, which will allow for successful implantation of human cell line xenografts. So in this experiment, the NSG females were implanted with a mesenchymal TNBC cell line, and this experiment, NSGs were implanted with a basal TNBC cell line. And they were both treated and split up into 4 different groups, and with this regimen shown here in the legend. For the MSL in vivo efficacy study, the 2 main groups of interest are red and blue. Basically, red is the group that is receiving docetaxel or chemotherapy alone. And when you compare that to the group that received tocilizumab, that's the anti-IL-6 receptor antibody, together with docetaxel, this led to an increased 2-week median survival with the combination therapy group. And this therapeutic benefit was not apparent whatsoever in the basal TNBC experiment, because essentially chemotherapy alone is sufficient to keep the tumor in check. In some case, leads to entire tumor eradication. So what I'm hoping to accomplish is basically one day we can identify a cohort of TNBC patients that may be ideal candidates of targeting IL-6 while they're undergoing chemotherapy. I'm absolutely not advocating we give tocilizumab to all TNBC patients. because that's simply not true. Not all TNBC patients will produce IL-6 as a resistance mechanism. The goal is to determine which TNBC patients will actually produce IL-6 after chemotherapy, and then supplementing those patients with targeted IL-6 therapy, such as tocilizumab. So this is just a summary slide of the pathway I elucidated. Again, mesenchymals after docetaxel therapy will have hyperactive MAP kinase pathway activation, which will lead to IL-1 alpha production, which will trigger a inflammatory cascade. And hopefully one day we can translate this over to TNBC patients in the clinic. I would like to thank Dr. Chang for having me as her graduate student over the years and for her continued support, and of course my lab. I could not be here without them, as well as my MD PhD program leadership and my collaborators. Thank you again so much.
Thank you. One question, it's certainly provocative findings. For the identification of the MSL subgroup, theoretically, if this pans out down the road, are there serum markers, or eventually that's going to be gene expression profiling on the tumor biopsy?
I'm very glad you asked that, Dr. Bernecker. So one could essentially, after tumor biopsy, perform either RNA sequencing. Now, in terms of how feasible that is in terms of cost and time for the TNBC patients, that's a little up in the air. What could be faster is basically taking the gene expression signature that is up in MS cells and just doing a qPCR profile, which it will be a lot quicker and faster and cheaper for those MSL target genes from tumor biopsies in order to make that determination, are these patients MSLs?
Interesting. Great, very good. Thank you very much. That was great.
Thank you.
You bet. Okay, on behalf of my co-director, Jasleen Randhawa, I want to thank all of the speakers and presenters today. I want to thank all the people out in the virtual audience. Thanks for your patience as we kind of work through the first time doing this symposium virtually. Everyone stay safe. We'll see you next year. Thank you very much.